We have crossed, I think, 600 more than 600 delegations, registrations. So you have all given us a good support. So thank you so much for you all, and having come from various different parts of the Karnataka state. You are here with us today. I hope you will go through all the scientific sessions and enjoy scientific session as well. The food, Karavali food, coastal food. I think you will have a taste of it. And thank you so much once again.
Good morning, everybody. I think both of them have welcomed you all. As a national EC member, first thing I want to thank you all for participating in the Surgeons Day and the Surgeons Week with a great number and doing wonderful activities, and this will continue next year also all over India. So there are a lot of programs which have been done, and I made a nice newsletter thanks to Dr. Anupama Pujar. It will be released soon. The second point is next week
The best prescription is knowledge, and it is this knowledge that empowers a surgeon to heal beyond the scalpel. Good morning, ladies and gentlemen, esteemed dignitaries, respected faculty members, honored guests, and my dear colleagues. With hearts brimming with pride and joy, we extend a heartfelt welcome to each one of you to the 8th KSCASI-midCON India. South Canara City branch here of Kanachur Institute of Medical Sciences
and innovation as the torch of excellence. Over the next 2 days, this convention will serve as a crucible where ideas and the spirit of camaraderie is celebrated, all in the noble pursuit of enhancing patient care.
The theme of this year just about learning. It is about evolving from we
on this academic odyssey, let us the word of Sir William Osler is an art, not a trade.
(2025) and the Associations of Surgeons of India, South Canara City branch. We express our to all the delegates and faculty who grace this occasion with their esteemed panelists who will be enriching this discussion with their invaluable sight. Dr. Vishwanath Patan Shetty, Dr. Manjunath Kottanavar, Dr. Anupama Pujar K, and Dr. Suresh BP. May I kindly request you all to grace the dais.
Next on list, we have a lecture on surgical site infections and antibiotic stewardship by Dr. Chandrasekhar N. To chair the session, we also have Dr. Professor PSM Amir Ali, Dr. Abhinandan Vandakudri, Dr. Spurti Kamath, and Dr. Suryakant Mandolkar. I request you to be ready for the next session.
Good morning, one and all. I welcome all the delegates, the panelists on the dais for this 8th KSCASI 2025 MidCon hosted by ASI South Canara City branch at this beautiful Kanachur Medical College. As the theme of this conference suggests, fundamentals first, I am privileged to moderate this panel discussion on the most fundamental topic, that is perforative peritonitis, which is the most common surgical emergency encountered in our general surgical practice. If not managed properly, leads to increased morbidity and mortality. To throw light on this topic, we have with us the esteemed panelists. Laptop is on. Dr. Vishwanath Patan Shetty, Professor of Surgery from JNMC Medical College, Belagavi. Dr. Manjunath S. Kottanavar, Professor and HOD General Surgery, BLD Medical College, Bijapur. Dr. Anupama Pujar, Professor of Surgery, Saptagiri Institute of Medical Science, Bangalore. And Dr. Suresh BP, Professor of Surgery, Subbaiah Institute of Medical Science, Shimoga. Before we move on to the topic proper, I would like to share some historical insights about this. Peritonitis is inflammation of the peritoneum and peritoneal cavity, usually caused by a localized or generalized infection. It requires prompt diagnosis and management. One of the most famous cause of appendicular perforation peritonitis leading to death was in a public figure was that of Harry Houdini. He was a renowned magician and escape artist. So it was not diagnosed and he had to succumb his life. So this is how important it is. With this short insights, we will move on to the panelists to know about this topic. The first question will be to Dr. Vishwanath. What are the types of peritonitis?
We are having mainly the two types, the primary and secondary. And in fact, even the tertiary peritonitis is also there. So in the primary peritonitis, it is mainly seen in the medical conditions where ascitic fluid is there. In that, there will be a monomicrobial infection. Either it could be hematogenous, or it could be iatrogenic, or it could be bacterial translocation of the through the gut wall. And secondary peritonitis usually occurs in presence of the perforation of a hollow viscus or even the genitourinary tract or any solid organs which are arising from the GI tract, such as liver and spleen. Even if there is a liver abscess or a splenic abscess, if it ruptures into the peritoneal cavity, then also it is considered as secondary peritonitis. Now, what is about tertiary peritonitis? Suppose if you treat secondary peritonitis with surgical treatment, and even after 48 hours, if there are signs of peritonitis, in that condition is known as tertiary peritonitis.
Thank you, sir. Can you also elaborate on the causes of peritoneal inflammation and enumerate a few causes of perforative peritonitis?
So whenever we talk about peritonitis in surgical practice, we are talking about secondary peritonitis, and it is mainly due to the hollow viscous perforation. In our clinical practice, the duodenal perforation is or the gastroduodenal perforation is the most common cause for the secondary peritonitis, and the causes being again the acid peptic disease or peptic ulcer disease is the most common condition. And among the other causes for the gastroduodenal perforation, it could be iatrogenic, especially in the era of laparoscopic surgery. When we are inserting the trocars, many of the times we have seen that we may injure the duodenum. As you know, the duodenum is a retroperitoneal organ. The anteriorly, the chances of getting injured are more. And other causes being the malignancy and other things in the, especially in the stomach. And the next, coming to the other GI tract in the small intestine, the most common in our subcontinent setup is mainly the enteric fever or the typhoid fever, which leading to the enteric perforation. And then Meckel's diverticulum, even though it is a rare condition, but whenever there is a Meckel's diverticulum, even the perforation can occur in the Meckel's diverticulum. And the next most common being is the appendicitis. The appendicitis leading to the appendicular perforation. And remaining the colon or the rectum, the incidence is quite rare, but still we see the perforation, mainly the causes being diverticulitis and the malignancy. And the post-operative peritonitis, as I said, following surgery, there could be anastomotic leak that may lead to the peritonitis, and the blunt abdominal injury or penetrating injuries are also the causes for the peritonitis.
So the most causes of peritonitis are caused by invasion of the peritoneal cavity, and once the peritoneal fluid spills into the peritoneal cavity, it circulates largely and directed by the normal peritoneal attachments and gravity, which happened in one of the cases of famous film star Rudolph Valentino, who was wrongly diagnosed to have acute appendicitis and succumbed to the disease of a missed gastric ulcer perforation, which is named after him as Valentino syndrome. So this condition is named after him. Dr. Manjunath, can you please enumerate about the pathophysiology and pathogenesis of peritonitis?
As Dr. Vishwanath sir has already told, in secondary peritonitis, there will be hollow viscous perforation. In primary peritonitis, there is primary infection of the peritoneum without any perforation by organisms like pneumococci or streptococci. In tertiary peritonitis, there will be some post-operative after surgery for primary or secondary peritonitis, maybe like anastomotic leak. In all of these, there occurs multiplication of the bacteria. Most often, the intraluminal bacteria like gram-negative organisms like E. coli. And all of us know that E. coli cause very toxic endotoxins. They cause very severe septic shock wherein patient can develop SIRS, systemic inflammatory response syndrome, therein patient can go for multi-organ dysfunction failure and high chance of mortality. And second is any cause of perforation, let it be primary, secondary or tertiary, there will be some amount of peritoneal irritation. That gives rise to the reflex secretion of the fluid in the peritoneal cavity. That can give rise to secondary ascites or what we call it as third space fluid loss. In turn, that is going to cause hypovolemia and hypovolemic shock. And again, wherein patient can go for multi-organ failure. And second is, because of peritoneal irritation, there will be peritoneal tissue damage, wherein capillary leakage can occur, and there will be liberation of the mediators like histamine and other vasoactive amines, wherein they can give rise to the protein-rich fluid in the peritoneal cavity, especially fibrinogen. And we know that fibrinogen can combine with tissue thromboplastin, which is secreted by mesothelial cells of the peritoneum producing fibrin. Again, there can be secondary fluid loss or third space fluid loss. And fibrin, it also causes some amount of adhesions in the peritoneal cavity. That can give rise to the stimulation of paradoxical intravascular hypovolemia, and that can be the cause for future adhesions also. And this third space fluid loss can give rise to hypotension, again hypovolemic shock, and chance of mortality are very high.
Thank you, sir. So, as sir told, the microorganisms which are causing this, most common is the E. coli, followed by Clostridium, Streptococci, Klebsiella, Enterococci, and Bacteroides. Let us come to the clinical features of peritonitis. Dr. Vishwanath, can you please tell us about it?
Whenever patient who presents with peritonitis to the emergency, our main important thing is, of course, the history taking and the presentation once you examine. So main common complaint is going to be the abdominal pain, and with the history we will come to know about whether the pain was acute onset or initially the patient had a history of pain. So accordingly, the localization of the pain is going to determine what is the primary pathology. If suppose the patient says that he had a pain in right iliac fossa, and then it is generalized to the whole of the abdomen, then you can think of either it is a appendicular perforation leading to the generalized peritonitis, or whether it could be even enteric perforation leading to the generalized peritonitis. So the proper history taking and then analyzing the abdominal pain. For the postgraduates, the pathophysiology of abdominal pain is very important, and you should read and try to understand how the abdominal pain, the pathophysiology, the concept is there. So main other symptoms which are related to the sepsis, which are going to present, especially the fever, then tachycardia, and on examination you are going to see the tachycardia, and patient even if presents with a full-fledged sepsis, then you might find the patient in hypotension, and on examination the classical presentation of the peritonitis, you are going to have generalized, the rigidity is going to be present, guarding is going to be present, rebound tenderness, and one of the important examination thing is the obliteration of the liver dullness has to be examined and it has to be confirmed. In our time, we used to do abdominal paracentesis to confirm what is the content of the abdominal fluid, the infective fluid, whether it is a feculent, purulent, or bilious, and accordingly we used to make a diagnosis. Now the dilemma lies with the doctors who are going to initially see the patient is whether you are going to send that patient for the imaging examination. Depending upon the general condition of the patient, whether this patient initially requires a resuscitation with IV fluids, the BP and other vitals are controlled, then only you should decide to send the patient for the imaging. And sometimes we mismanage many of the times just sending all patients to the imaging the center or within the hospital to the imaging room without accompanying the patient, without correcting the resuscitation room, then it will lead to the increased mortality.
Thank you, sir. Thank you. We will come to the diagnostic modalities. Thank you. Will you continue to tell us about the diagnostic tools available for perforative peritonitis?
Okay. So whenever any condition, we have got a lab investigation and imaging investigation. So considering if this patient requires an emergency surgery, what lab investigations are required for the anesthesia and for the further management, those blood sample should be sent immediately from the resuscitation room or the emergency room. And of course, the CBC is going to just tell no lab investigation is specific for the diagnosis of peritonitis. Only it is going to give some information related to the infection within the body. So whatever in the CBC you are going to find increased leukocyte count, the urea creatinine might have raised because of the sepsis, and there could be fluid imbalance, electrolytes imbalance might be there, and there could be sometimes the differential diagnosis for the acute abdomen would be pancreatitis. To rule out that, you may have to send for amylase and lipase. And then some of the indicators for the sepsis such as C-reactive protein and procalcitonin also will tell you. But these are not specific investigation which are required for further management, but which will add to the further management. The main important thing is the confirmation of hollow viscous perforation. Even though clinically sometimes the findings might be equivocal, in such condition, depending upon the patient's condition, these imaging investigations have to be done. The first thing is the X-ray abdomen erect. Okay, again, whenever you want to take a erect abdominal X-ray, make sure that patient's blood pressure is normal or whether he'll be able to stand. Otherwise, the bedside, the left lateral decubitus X-ray can be taken. And then CT abdomen, it is going to give you the information whenever there is a dilemma in the definitive diagnosis of which perforation. Sometimes, as madam said about appendicular, the duodenal perforation presenting as acute appendicitis. So in that condition, the CT abdomen will tell you the site of perforation and also the severity of the peritonitis. So these are the investigation. Of course, ultrasonography is going to tell you about the presence of the peritoneal fluid, and in presence of generalized peritonitis, even small bowel edema is going to present, which can be picked up by the ultrasonography.
Let us not forget this, some of the differentials of air under the diaphragm, which is very important, and it is a favorite question of all the examiners for the postgraduates. Though the most common is the hollow viscous perforation, the next in line will be the Chilaiditi syndrome, which is nothing but the transposition of the transverse colon between the diaphragm and the liver. It can be a subphrenic abscess or a ruptured liver abscess as well. Moving forward, we will go on to the scoring systems that are available in peritonitis. Dr. Manjunath, can you please throw us a light on this?
There are many scoring systems for sepsis per se, but for peritonitis, commonly we come across Mannheim Peritonitis Index, MPI. In this, mainly 8 factors are taken into account. One is age more than 50 years, female sex, organ failure, malignancy, and preoperative duration of peritonitis more than 24 hours, origin of sepsis, whether there is diffuse generalized peritonitis, and the type of exudate. So totally there are 47 points. And depending upon the score, if less than 20, we label it as low risk, 20 to 20, 21, 20, 21, moderate risk, and more than 29, high risk. And definitely higher risk is there with Mannheim Peritonitis Index of more than 29. Next is, what we follow is Apache score, Apache 2 score. That Apache stands for Acute Physiology and Chronic Health Evaluation, second modification. Again, here we take into account 14 factors. Apart from those, here we also take into account the TPR-BP, the temperature, pulse rate, respiratory rate, and blood pressure with oxygen saturation, then acid, arterial pH, bicarbonate level, and serum electrolyte level, Glasgow Coma scale. And this is applicable not only for peritonitis, even for any case of septic shock. And we label as low risk, moderate risk, high risk, and very high risk depending on the score of 0 to 10, 11 to 20, 21 to 30, and 31 and above. Definitely high risk patient will be having high chances of morbidity and mortality. Next to come is SOFA score. SOFA stands for Sequential Organ Failure Assessment. And here mainly we take into account the six systems. That is, one is respiratory, cardiovascular or cardiac, liver, renal, and blood, that is coagulation profile mainly in relation to the platelet count, and neurological level depending on the Glasgow Coma scale. And we give the points at 0 to 4. So maximum score can be 24. So depending on this SOFA score, we can say whether patient is prone for organ failure, thereby higher mortality rate. And last but not the least is Possum score. That stands for the physiological and operative severity score for the enumeration of morbidity and mortality after surgery. This is the one scoring system which we assess the mortality after doing surgery. That means apart from the previous scoring factors, we take into account some factors related to the surgery like the total operative time, then loss of blood loss, and third is the level of contamination in the peritoneal cavity. And we give the scoring. Again, the higher the POSSUM score, more is the chance for morbidity and mortality. Our aim in case of peritonitis should be to detect the disease at the lower score rate so that we get the very least morbidity and mortality in any case of peritonitis. Madam.
In spite of all the available scoring systems enumerated now, factors which decide the severity of peritonitis is dependent on the site of perforation, whether it's proximal or distal bowel, the virulence of the organism, immunity, and the age of the patient. Moving on, we'll go on to study some of the basic steps that we follow to manage these patients of peritonitis. Dr. Anupama, how do we proceed after diagnosing a patient with perforative peritonitis in the management lines?
See, when the patient comes into the emergency room, once we think it is a peritonitis, all the peritonitis patients will come either some may be stable in early stage or some may be critically, they might present with a shock. But whatever the condition they come, they need to be optimized. Some amount of resuscitation has to go, particularly in the shock patient. And we should not waste time in finding out why the peritonitis and shock is there and then start the resuscitation. The resuscitation should, and examination, evaluation has to go hand in hand, and resuscitation should continue pre-op, intra-op, and post-op period also. So the goal of resuscitation is fluid and electrolyte has to be optimized, acidosis should be corrected, then proper antibiotic should be used, then proper analgesia and source control. Okay. So how to evaluate in the emergency room? Again, you follow the rule of ABC, that is airway, breathing, and circulation. So particularly patients who are very sick and when the brain hypoperfusion is there, they might come with altered sensorium. So they might risk of aspiration will be there because of vomiters might be obstructing their airway. So you should check for the airway patency. If vomiting is there, you have to suction and resuscitate and start oxygen mask and maintain the SpO2 at around 94% at the minimum. And then particularly if patient is too much sensorium loss and his GCS is low, below 8, and patient is in respiratory distress, you might have to intubate the patient at that time. Next is hypotension. You have to address the hypotension. So you have to start two wide bore IV cannulas. Okay. Wide bore IV cannulas are preferred than the narrow long catheters of central vein, where central veins better to be used for the monitoring rather than the rapid fluid resuscitation. Wide bore short IV cannulas allow you for the rapid fluid administration. Okay. And then the fluids actually, some of the textbooks says that there is no ideal fluid, but recommended fluid is isotonic crystalline solutions. Okay. So in that balance, that is normal saline and the ringer lactate. And in that balanced solution are more important, balanced crystallite solutions such as ringer lactate, which mimics the intravascular components. Okay, and it should be given 30 ml per hour in the first 3 hours. Okay, and then it has to be monitored. Endpoints are, you have to monitor clinically heart rate, blood pressure, and also urine output. So the heart rate should be reached to the 100 per minute. Blood pressure should be around 90 to 100 mm of Hg, and the urine output should be 0.5 ml per kg per hour. Okay, but optimization of these vitals will only tell you that there is central perfusion to the brain, kidney, and lungs are done, but there will be some kind of hypoperfusion will be there in the gut and the muscle. So this is called occult hypoperfusion. So what happens if there is a occult hypoperfusion is there more than 12 hours, that patient mortality is high. And this occult hypoperfusion also stimulates the inflammatory and the coagulation cascade, and patient might have reperfusion injury. So the better monitoring of the fluid monitoring should be done with the monitoring of invasive monitors like mean arterial blood pressure, which should be 65 mm of Hg should be achieved, and then urine output as I told, and then mixed venous oxygen saturation should be maintained at 65%. Okay, and when you start the IV line, same time you have to send for all your lab investigations and also for the ABG to look for any base deficit and acidosis. Okay, and then after you resuscitate the patient, if still patient is not improving, then you might have to start with the vasopressors, and the preferred vasopressor is the noradrenaline. Okay, and if still patient is refractive for the IV fluid and the vasopressors, particularly in a septic shock, you can use low dose steroids also. Okay, and then if acidosis is there, usually acidosis get corrected when you fluid is given and resuscitate the fluid. But if it still persists, you might have to give the sodium bicarbonate.
Thank you.
infusion.
Thank you, ma'am. Once we have resuscitated the patient, so when does it call for a surgery? That is, what are the deciding factors? Dr. Suresh?
Once a patient comes to the casualty, you have done your clinical diagnosis and you are done a supportive investigation. So you are concluding that it is a perforative peritonitis. First, you have to what Madam told, initial assessment, the scoring system, and also the emergency treatment. You have to treat hypokalemia, hyponatremia, and metabolic acidosis, and also hypovolemia. So after that, so once a patient, you have to stabilize. Once a patient stabilized, so patient may be initially patient may be in no other comorbidity like hypertension is not there, renal failure is not there, no other organ failure is there. You can think of taking patient immediately for the surgery. But patient is not stabilized. Patient is not in the stable condition. You have to stabilize the patient first. Then you can think of taking for surgery.
What is the optimal timing, sir?
Better if you take less than 24 hours. Initially 6 hours is the better one.
Thank you. With this basic knowledge, let us discuss some case scenarios. Here we have a 60-year-old male who came with the complaints of pain in the upper abdomen since 6 hours and abdominal distension and non-bilious vomiting. He gives a history of NSAID abuse for the joint pain. On examination, a pulse rate of 120 beats per minute and blood pressure of 90 by 60 millimeters of mercury. On clinical examination, patient has generalized guarding and tenderness in the epigastric region and bowel sounds are absent. When he is subjected for an erect X-ray abdomen, the erect X-ray abdomen shows air under the diaphragm. Can you please tell us the diagnosis, Dr. Suresh?
So maybe it may be gastric perforation or duodenal perforation or small intestine colonic. But if once you think of a duodenal perforation, so what you have to do is gastric perforation. Gastric perforation is commonly seen in elderly people. People who are taking NSAIDs, especially for osteoarthritis, and even they take steroids. They are prone for gastric perforation. And acid peptic disease is more commonly it is a duodenal perforation. Usually anterior part of the duodenum, that is duodenal bulb, will commonly the perforation will occur. For the duodenal perforation, if you have done initial, if patient is diagnosed early, take up a surgery as soon as possible, within 6 hours or within 24 hours will be better. If it is duodenal perforation, you have to whether you can go for laparoscopic approach or open approach. Laparoscopic approach.
So this patient of ours, when he was taken for a laparotomy, showed a duodenal perforation as in the picture. So how do we go about this?
See, once you do laparotomy, find out it is perforation in the first part of the duodenum, that is the anterior surface. So first I'll do the peritoneal lavage because already septic foci is there. Once septic foci is there, you have to take out peritoneal lavage, which is the first one, you have to do it. After giving the peritoneal lavage, and you have to primary closure of the duodenum, you have to do it. How you do it means you just take the anterior surface of the duodenum because perforation will be very small. Sometimes they'll take the posterior wall also. Avoid taking the posterior wall of the duodenum, and you have to take a bite, so at least 5 millimeter apart from the perforation. So you take a bite and keep the sutures and put a vascular pedicle of the omentum and you tie it. That's Graham's patch. You have to do it. And modified Graham's patch, you'll close the perforation and then later you put the omental patch.
So this is what we do when the perforation is less than 1 centimeter, a Graham's omental plasty. So if the perforation is more than 1 centimeter, what are the options available?
See, if it is more than 2 centimeter, is a large duodenal perforation. It may be more than 2, 3, 4, 5. Occasionally, I have seen one patient really 4 centimeter. That what you have to do, there are so many things you can do it. You can closure of the primary, that perforation with omental patch, and you can do pyloric exclusion surgery. What is pyloric exclusion surgery? Means you can close the pylorus part and you do the GJ and feeding gymnostomy. Other thing is you can do, that is gastrotomy and retrograde duodenostomy and also feeding gymnostomy. Triple ostomy it is.
Triple tubostomy.
And other thing, especially serosal patch also important, because in trauma, there will be second and third part of the duodenal perforation occurs. In that condition, you can put a serosal patch of the jejunum. That is also one of the treatment for duodenal perforation, not only acid peptic disease, even trauma also, you have to treat in different way.
When do we add an antral vagotomy to these patients?
Say antral vagotomy, if it is large perforation, you can think of, but if you have taken the patient early, we can do it. If patient is in sepsis, the time duration is most important. Whatever is that time limit, you have to do it. Nephrectomy and Bilrat 2 also you can do it. But I don't know whether you do GJ and vagotomy, because we are doing vagotomy, you are mobilizing the esophagus. The infection may carry out to the mediastinum. That is the one thing, whether do GJ and vagotomy in this condition, it is questionable. But you can do Bilrat 1 and Bilrat 2. And even sometimes very difficult, because posterior duodenal perforations are most important, because they have very minimal signs and symptoms initially. Very difficult to diagnose, even posterior gastric perforation also. So these are the treatment aspect for duodenal perforation. And
Someone wants to add on regarding the indications for antral vagotomy?
As Suresh sir had rightly told, most of the time patient will be in septic shock. So such cases we have to do something like damage control surgery. You have to relieve the peritoneum from the septic focus and do as minimal surgery as possible. Provided patient condition is stable, you have got enough time, anesthetists are happy with your procedure, and anesthetists are confident enough to give more time of anesthesia. At that time, you can add definitive surgery in the form of vagotomy with antectomy, etc.
Thank you. Few points about H. pylori eradication. Dr. Suresh?
immediately after post-op, we can give H. pylori eradication. At least minimum for 4 weeks you can give, or 6 weeks, whatever. So you have to do after surgery, you can give H. pylori eradication treatment. And one thing, gastric perforation, always you take biopsy, because malignancies can cause, gastric malignancy cause perforation, and you have to take biopsy if it is gastric perforation.
Let us move on to the next case scenario. Here we have a 69-year-old female who came with the history of pain abdomen since 4 days, colicky in nature, relieved by medicines, and with a history of fever since 15 days and a Vidal test positive. On X-ray, the patient has air under the diaphragm. Can you please tell us the differentials, Dr. Anupama?
Since the patient is already Vidal positive and the patient is in an acute abdomen, so unless until proved otherwise, it should be thought of typhoid perforation. But otherwise, even other causes are there in typhoid perforation in the terminal ileum, but there are other causes for terminal ileum perforation like tuberculosis, radiation enteritis, Crohn's disease. But the problem, those are all present in a, tuberculosis present in a more chronic way and then perforates. But here it is a very acute condition with typhoid viral positive. We'll go ahead with the entry.
So here on laparotomy, this patient had a 2 mm ileal perforation. How do we manage this?
So this is a simple single perforation and surrounding bowel looks okay. In this patient, except some of the flakes which are there, so you might have to take a biopsy from the edge of this ulcer and freshen up the edges of the ulcer and 2-layer closure of the perforation. Along with that, a proper peritoneal lavage should be given to control the peritoneal, whatever peritoneal soiling has happened.
If these perforations are multiple, so how do we do that?
If perforations are multiple and they are close together, better to go ahead with a resection of that part of the ileum and then do a primary ileo-ileal anastomosis. And if there is risk of anastomotic leak, if you think, you can do a diversion ileostomy in those patients. And along with that, again, peritoneal lavage is important.
Yes, the take-home message is, in case of too much of a contamination, a diverting ileostomy is very important. So moving on to the next scenario, we have a 20-year-old male who came with history of abdominal pain and a fever of 3 days with loose stools. On examination, he had tenderness at guarding present in the right iliac fossa. The lab showed increase in the WBC counts with the neutrophils of 88%. The USC is as shown in the figure. Can you please tell about this, sir, Dr. Manjunath?
The young patient of 20-year-old male patient coming to us with complaints of mainly pain abdomen, sudden onset. We have to elaborate this pain. Where did the pain started? Most of the time, looking at the ultrasonography picture, it looks like a inflamed appendix. So history have to elaborate. Initially, pain will be around the umbilicus, periumbilical pain. Later on, pain shifting towards the right iliac fossa. That classical history is suggestive of acute appendicitis. Moreover, patient has got history of fever and loose stools. This loose stool history, in case of appendicitis, can be because of its position. You know that the pelvic position or pre-ileal, post-ileal positions, many a time patient will present to us with complaints of loose motion. We have seen pediatricians treating acute appendicitis patients thinking that patient is suffering from gastroenteritis. There where comes the important symptom of pain. Whenever patient complains of pain first followed by loose motion, think of surgical condition. And if patient complains of loose motion first followed by pain, think of medical condition. So this condition goes in favor of acute appendicitis. So
intraoperatively, when we opened, he had an appendicular inflammation. So patient was subjected to a appendicectomy.
Yeah, ma'am. Since patient has acute appendicitis, the treatment of choice is obviously emergency appendicectomy. And provided if a surgeon is good enough in handling by laparoscopic surgery, we can try laparoscopic appendicectomy also, or else if a surgeon is not trained, you can go ahead with open appendicectomy. Suppose the perforation is there. The patient has got perforation at the tip of the appendix, you can do simple appendicectomy. Nowadays, we are not doing the stump closure by the pursing or jet manner. If the perforation is there at the base of the appendix, there comes sometimes a role of limited resection. Though if suppose surrounding the base of the appendix, cecum is also not healthy, and that there are more chances of the stump leakage. So better to go ahead with, in such conditions, with appendicectomy along with the limited resection of the cecum.
So the take-home message is acute appendicitis with perforation at the tip, appendicectomy, lap or open. Appendicitis with perforation at the base stump, cecal mobilization, if possible, a primary cecal closure. And some cases we may require a limited right hemicolectomy in conditions like severe appendicitis with an adherent cecum, appendicular carcinoid more than 2 centimeters, or if the mass is present at the base, and in certain cases of IBD. Our next case is a 10-year-old child who present with a complaints of severe abdominal pain with 3 episodes of non-bilious vomiting and low-grade fever, pulse rate of 118 and a temperature of 100.8 degree Fahrenheit. On abdominal examination, he had rebound tenderness present in the right iliac fossa and bowel sounds are absent. What are the differentials to this, sir? Dr. Manjunath.
Again, looking at the case scenario, young patient, 10-year-old patient with pain, vomiting, fever, classical clinical triad of Murphy's triad. Again, the symptoms goes in favor of acute appendicitis, but thinking the possibility of other conditions, we can go ahead with some investigations in the form of ultrasonography of the abdomen.
So this patient, on subjecting to an ultrasound, showed free fluid with thickened bowel loops and a CT showed a thickened terminal ileum with a suspected Meckel's perforation.
Yeah.
How do you go about
Yeah,
this?
many a times in such acute conditions, if CT scan facility is not there, we directly go ahead with emergency appendicectomy. But in this case, luckily, we have got done CT scan also, and CT scan has definitely pointed out the perforated Meckel's diverticulum, that is Meckel's perforation. My theory is, if we have not got done CT scan, you are going to take the patient for emergency surgery with the only ultrasonography finding. Many a time we know that Meckel's diverticulum with its complications like perforation, they are intraoperative diagnosis, provided we have not taken CT scan. And intraoperatively, if appendicitis is inflamed, you can do appendicectomy. If appendix is found normal, it is our bounden duty to look for Meckel's diverticulum. If appendicitis, if there is inflamed appendix with perforation, we need no need to search for a Meckel's diverticulum. If appendix is found normal, definitely we have to search for Meckel's. And in this case, definitely preoperatively we have diagnosed as Meckel's diverticulectomy, Meckel's diverticulitis. So our procedure is laparotomy with peritoneal lavage. If the base of the Meckel's diverticulum is healthy, we can do wedge resection of the Meckel's diverticulum. If the surrounding, the base of the Meckel's ileum is not healthy, you can do again limited dissection of the ileum. And one more point I want to tell to the postgraduates here is, when we do appendicectomy for acute appendicitis, and many of the older surgeons, they are in a habit of searching for Meckel's diverticulum. And you know that the incidence of Meckel's is very high to the extent of 2%. Out of 100 individuals, there 2% will be having Meckel's diverticulum. Whether to do this Meckel's diverticulectomy or not, it mainly depends upon the width or base, at the base of the Meckel's and length of the Meckel's. If it is too wide with a short length, we need not do Meckel's diverticulectomy. It is a short, narrow base with a long length of Meckel's diverticulum. When it is normal, you can substantiate by doing Meckel's diverticulectomy.
Thank you, sir. So we should keep a habit of checking the distal ileum even in case of an acute appendicitis. That is the take-home message sir wanted to put it. So this is our last case scenario. Here is a 62-year-old male with complaints of abdominal pain since 2 days. Started in the left quadrant and progressed to become a generalized pain. He had 3 to 4 episodes of non-bilious vomiting. He also gives history of chronic constipation that has worsened in the last 3 months with a history of weight loss and not passing stools of flatus in the last 24 hours. He has no history of hematochezia or melena. On examination, he has an abdominal distension with guarding and rigidity, and bowel sounds are absent. On per-rectal examination, the rectum is empty. So, differential diagnosis, sir.
The elderly patient who presented with abdominal pain and altered bowel habit, and also gives a history of weight loss, and on examination there are signs of peritonitis. So considering this, on the left side pathology, you have to think of either the descending colon or the sigmoid colon, and the most common pathology would be either diverticulitis or malignancy in this age group. So better, as considering the vitals are normal, patient can be further evaluated by CT scan.
Yes, further evaluation was done. An ultrasound showed a free fluid with dilated bowel loops, and CT abdomen showed a sigmoidal mass with perforation. How do we go about this?
So in presence of peritonitis, the condition as here mentioned, the sigmoidal mass with perforation, it is always better to explore depending upon the surgeon's experience. If he is able to manage lap approach also can be done. But as here postgraduates are there, so better would be the open laparotomy, and we have to explore. So the going to tell?
So findings is there is a sigmoidal mass.
Okay. So on examination, on intraoperatively, we find there is a sigmoid mass with the perforation, and there is a fecopurulent fluid which was present in the peritoneal cavity. We have to do the peritoneal lavage, and then at the considering the pathology, either it could be a malignancy or an infective pathology, you have to resect that pathology, and then considering there is a fecopurulent contamination of the peritoneal cavity, it is always better to do the Hartmann's procedure, and the diversion, proximal diversion colostomy has to be done. And before taking up such patients for surgery, and when you are suspecting there could be a intraoperative decision of doing a colostomy, the preoperative consent from the patient regarding the stoma has to be taken, and also there could be 2 or 3 stage surgery which patient may require. That also has to be explained to the patient preoperatively.
Thank you, sir. In the growing era of minimal invasive surgery, can someone throw some light on role of laparoscopy in peritonitis?
Of course, currently, as you know that now appendicectomy, the appendicectomy has become the gold standard, even the cholecystectomy, the laparoscopic approach, and nowadays even the postgraduates are being exposed to the all lap surgeries, and now hernia, earlier it was considered as an advanced surgery for the inguinal, now even it has become almost nearer to the gold standard. So considering now the role of laparoscopy in acute surgical condition, especially in the peritonitis, as we know, the clinically the postgraduates are losing the making the skill of diagnosis about the peritonitis. Secondly, now they are dependent on the imaging. And next is the intraoperative laparoscopically we are able to diagnose many of the conditions where dilemma is there. Especially earlier days, as Madam mentioned earlier, difficult to differentiate between either it is peritonitis following appendicitis or appendicular perforation or duodenal perforation. We used to take a periumbilical incision, superior, inferior, depending upon the pathology, we used to extend the incision. Now with the scope, we will be able to identify where is the perforation, which pathology is the cause, and even whatever the other causes of the peritonitis are there, that can be diagnosed initially. Best peritoneal lavage can be done, and some of the condition, depending upon the expertise of the surgeon, he will be able to manage even the definitive, the surgery can be done with laparoscopy.
So as rightly mentioned, the laparoscopic management offers benefits such as a reduced trauma, faster recovery, and increased diagnostic accuracy compared to the traditional open surgery. However, it has its limitations in peritonitis in presence of a severe inflammation, extensive adhesions, and however, in a hemodynamically unstable patient, it is not right to take it for a laparoscopic surgery. So this is my concluding slide. Diffuse peritonitis, when treated with modern methods, carries a mortality rate of approximately 10%. This rate is influenced by several factors, including the extent and duration of peritoneal contamination. The patient's age and fitness and the underlying cause of the infection also is of utmost importance. I thank all the panelists and the scientific committee of the KSC-midCON 2025 for giving me this opportunity to be the moderator for this first session of the conference. Thank you one and all.
An incredibly comprehensive discussion. The real-world perspectives shared today are bound to leave a lasting impact on all of us.
May I now request Dr. Savita Kalwad and our panelists to proceed towards the photo booth for a photograph, and I request Dr. Harish Chandra, Professor and HOD, Yanapoya Medical College, to hand over their certificates of appreciation.
Before moving on, I would like to welcome all the delegates who have joined us today, and I request all the delegates to start occupying the drome from the center. Moving forward, we now have a topic of utmost relevance in today's surgical practice, surgical site infections and antibiotic stewardship.
To deliver this enlightening lecture, we are honored to invite Dr. Chandrasekhar N., a professor, Sri Devi Medical College, Tumkur, a leading authority in surgical infection control, whose evidence-based protocols have set gold standards in perioperative care.
To chair this session, we welcome Dr. Professor PSM Amir Ali, Dr. Abhinandan B. Vandakudri, Dr. K. Spurti Kamath, and Dr. Suryakant Mandolkar to the dais.
The next session would be a lecture on current concepts in wound healing by Professor Anand Peter Ignatius. To chair this session, we'll have Dr. Shivaram HV, Dr. C.G. Sunil, Dr. Shiva Prakash, and Dr. Lingaraju. I request dear delegates to be ready for the next session.
So, with the permission of the chair, shall I start? To everyone. At the outset, I thank the office bearers of KSCASI and the organizers of midCon 2025 for giving me this opportunity. Topic which is given to me as an important, I would like to say, a must-know topic for all the practicing surgeons, irrespective of specialty, and especially for the young surgeons, resident surgeons who are going to start surgical practice. It's not happening. Back. Back. Put it back. Which one? So the topic is surgical site infection and antibiotic stewardship. Surgical site infection, objectives of my talk, another next 15 minutes, I'm going to talk about when you call it as a surgical site infection, what are the different types of surgical site infection, the risk factors associated with infection, and define the management strategies for surgical site infection, explore the preventive measures and the guidelines to reduce surgical site infection, and the important one, understand the role and impact of antimicrobial stewardship program in control of surgical site infections. Surgical site infections is one of the most common postoperative complications what we come across. They accounts for about 20% of all hospital-acquired infections, about 0.5 to 3% of surgical patients develop surgical site infections. The below lines will tell you the magnitude of the infection and the burden on the patient and on the healthcare system. So definition of surgical site system, when you call it as a surgical site infection, CDC, that is Center for Disease Control and Prevention of Infection, has defined surgical site infection as infection related to surgical procedure that occurs near or at the surgical site within 30 days of surgery or within 90 days of surgery when you use an implant or a mesh. This timeline is very important when you are evaluating a post-operative patient. Classification, so basically CDC classified surgical site infection into superficial incisional, deep incisional, and organ or organ space infections. What exactly is superficial incisional is when infection involves the skin and subcutaneous tissue. Most of the surgical site postoperative infections are superficial infections. So diagnosis is very simple. When you find signs and symptoms, inflammation of surgical site with oozing pus at the site. Deep incisional, when soft tissues deeper to deep fascia, that is muscle planes or the facial planes are involved. Diagnosis, when you find wound adhesions, or sometimes you deliberately open the stitches to find when you have an evidence of abscess, or evidence of an abscess are found when imaging or during direct examination. Organ or organ space infections, any organ or anatomical space beyond the incision site, but deeper than the facial planes or the muscle layer. So presence of pus, how do you diagnose that presence of pus at the drainage site, or when you clinically diagnose or with the help of imaging that there's an abscess intraperitoneally. What are the risk factors? So the risk factors for development of surgical site infections are basically classified into patient-related, wound-related, and microbial. Patient-related includes age, obesity, malnutrition, metabolic diseases, immunocompromised status, smoking, and poor perfusion because of peripheral vascular disease. Local factors, what type of wound you are dealing with, whether it's a clean wound, clean contaminated, or dirty wounds. Intraoperative contamination when you encounter enterostomy or when the bowel is opened. Inadequate antibiotic prophylaxis, prolonged procedure, hypoxia, hypothermia, and local tissue necrosis. Microbial mainly depends upon the virulence of the organisms, prolonged hospital stay leading on to cross-infections and development of multi-drug resistant organisms. These are the list of organisms that come across in the post-operative surgical site infections. What are the source for surgical site infections? Either it could be endogenous or exogenous. Endogenous, which is on the patient, either it depends upon the procedure that you are going to perform. You have encountered an enterotomy, or sometimes mucosal carriers or the skin carriers. Exogenous, mainly acquired, airborne. So either it is in the OT or in the wards. Post-operative wound infections are diagnosed clinically. Most of the time, you require imaging when you suspect deep organ space infections, and all the post-operative wounds needs to be assessed. So these are the scoring system. Why we need to assess? To know the wound healing and the severity of surgical site infections. Management. So management basically depends upon an established case of surgical site infection. Management depends upon the procedure that you have performed, the type of microbes that are involved, and anatomical consideration and patient characteristics. So if you look at the superficial and the deep incisional, simple management of drainage of the abscess, debridement, and use of antibiotics, either parenteral or oral. But when it comes to organ space infection, so image-guided drainage of the pus or re-exploration. In some of the special situations, when you have done surgery, when you have used an implant or a mesh, if such wounds are infected, if the infection is at the plane of the mesh or the implant, that needs removal. Most important part of a surgical site infection is prevention. Always it is said prevention is better than cure. You always concentrate on preventing measures rather than thinking of curing once you develop the infections. Preventive measures, CDC guidelines of 2025. So basically it is divided into pre-procedural and perioperative. Pre-procedural is need to optimize the patient. That means any elective case you are posting, so you need to optimize the patient with respect to chronic health issues, diabetes mellitus, nutrition, anemia, all those things should be corrected before you post the case for surgery. Perioperative includes pre and post-operative measures. Preoperative includes pre-op antiseptic showers, preoperative proper skin preparation, antibiotic prophylaxis, pre-op hand hygiene. Post-operatively, it is the dressing change and how you are going to take care of the post-operative wound. Most important is intraoperative. Most of the surgical site infections can be minimized or can be managed with intraoperative measures, that is gentle handling of the tissues, preservation of blood supply, strict aseptic technique, minimal tension across the sutures, accurate tissue apposition, obliteration of the dead space, and maintaining of the hemostasis. What is generally said is when you operate, you need to respect the tissues. That's what my sir used to tell, always respect the tissues, they in turn respect you, otherwise the tissues will start crying, that cry you see, the tears what you see in the post-operative period as the pus. Why we talk about this surgical site infection? Because there is a rise of antibiotic resistance, rise of multi-organ, multi-drug resistant organisms. Antimicrobial resistance has been identified as one of the major threats by a WHO due to a lack of new antibiotics in the pipeline, and the infections caused by these multi-organ, multi-drug resistant pathogens are becoming untreatable. If you look at this rule of 30%, that is 30% of all the hospitalized patients at any given time receives antibiotics. Over 30% of antibiotics are prescribed inappropriately in the community. Up to 30% of surgical prophylaxis are inappropriate, and 30% of hospital cost is mainly because of antibiotics. And this will tell you the abuse or misuse of antibiotics. What we should do for this? To combat this antimicrobial resistance, WHO has recommended a 3-pillar approach, that is optimize the use of antimicrobials, prevent the transmission of drug-resistant organisms, improve environmental contamination. How to achieve this? To achieve this, an integrated stewardship program has been advocated, which is described as antibiotic stewardship program. What is stewardship? Stewardship is, in simple words, it's a careful, responsible management of the resources. So what is antibiotic stewardship? That means we need to manage, because you take the antibiotics as a resource, we need to manage these antibiotics carefully and responsibly. Antimicrobial stewardship is an organizational healthcare system-wide approach to promote and monitoring judicious use of antimicrobials to preserve their future use. In toto, you can tell it as the right antibiotic for the right patient at the right time with the right dose and the right route, which causes less harm to the patient and the future patients. So why you need to adopt this antibiotic or antimicrobial stewardship? Is there any evidence? The answer is yes. The global survey has been done across different countries, has clearly shown there is a 70 to 90% reduction in the use of antibiotics. There is significant increase in the mortality and morbidity with respect to the sepsis, and there is a significant decrease in the hospital-acquired infections. What are the goals of antimicrobial stewardship program? There are 4 main goals, that is improve patient outcome, optimize patient safety, reduce resistance, and control healthcare cost. How do you look upon this? This is improve the infection cure rate, reduce the surgical site infection, reduces mortality and morbidity, reduce the duration of hospital stay without increasing the mortality, reduction in the multi-drug resistance organism in cultures, and change in the antibiotic prescription rate. How to implement? These are the key 8 steps in the implementation of antimicrobial stewardship program. Assess and motivate, you need to, this is the implementation of this antimicrobial stewardship program is done at different levels. You can do it at the individual level, you can do it at the healthcare system or an institution, you can do it at the national level, or you can do it at the global level. So what I'm going to tell you is at the institution level what you can do. assess the motivation, we need to assess what is required for your institution, what are the problems that you are facing in the institution, needs to list out all those things. Ensure accountability and leadership. That means some senior person in the institution, preferably a clinician, should take the leadership and he should be made accountable for whatever the positive and negative outcomes of this procedure. Set up the structure and organization. This implementation program is not done by one person, it is a teamwork. So you need to set up the structures and the organization, define the priorities and how to measure the progress and success. Identify the effective interventions for your setting. There are the types of interventions which needed for your settings you need to adopt. Identify the key measures and implement. There is always a said, if you can't measure, you can't progress. That means every progress you need to measure. Educate and train and communicate, the important part of stewardship program, because as I said, it is not done by one person, it is the community or the institution as a whole should activate in this part. We need to educate the prescriber, we need to educate the paramedical workers, we need to educate non-technical people, all should be educated and trained what exactly we are doing. And communication is very important. Communication in what sense? That means you have to assess in the short term, whatever the goals you have done, whatever the progress you have done, you need to communicate. Always it is said that when you have positive outcomes, you have the enthusiasm to continue the program. So that is why communication plays a major role in the stewardship program. Who are all going to do this? I said it's a teamwork. Who are all should be there in the team? As a core team members of a stewardship program, you should have an IDs physician, clinical pharmacist, clinical microbiologist, infection control professional nurse, hospital epidemiologist. How do they work? They work by surveillance or close observation of prescribing practice and clinical outcomes. They have to design and implement the interventions aimed at the optimal use of antibiotics. Interventions, I'll tell you the two types of interventions. One is a core interventions are nothing but strategies. Core interventions and supplemental strategies. Core strategy is front end and back end. In front end, you are going to do the restriction or there is a formal approval for prescribing antibiotics. In back end, there is already approved, there already antibiotics are started, but we need to assess at the day 1, day 4 and day 7. Day 1 for the dosage, day 7 for the routes and day 7 for the number of days. Both have got their own advantages and disadvantages. In supplemental strategy, what we do is formally restriction of the antibiotics. They are going to design the treatment algorithms, clinical guidance, education, de-escalation depending upon the cultures, pharmacodynamics, and switching from IV to oral antibiotics. Thank you. And antibiotic cycling. So if you look at this antibiotic stewardship, these are core elements of antibiotic stewardship, that is leadership, accountability, drug expertise, action, tracking, reporting, and education. Each one has its own explanations. I think the time is not there to explain everything. So always we should put a question to all the clinicians that are antimicrobials are really indicated in my patient? If yes, what is the drug of choice that I'm going to use? And next question is important, how I can limit the social impact of these antimicrobials use. And the golden rules for antimicrobial use always remind me, that is microbiology guides the therapy. Indication should be always evidence-based, narrow spectrum of antibiotics required, dosage appropriate to the site and type of infections, minimize the duration of therapy, ensure monotherapy rather than putting multiple drugs. To conclude, my take-home message is SSI is the most common preventable cause of post-operative morbidity and mortality. SSI imposes a triple burden, clinical, economical, emotional. So prevention is the key. The right antibiotic for the right patient at the right time, in the right dose, and for the right duration. Each prescription should be a calculated decision and not a reflex. This is always, I say, when you start prescribing, that means stop unnecessary antibiotic use. So as a clinician, we should think before we prescribe. As a chemist, they think before they give, and as a patient, they should think before they take. Thank you very much. Thanks for your patience here. Any questions?
Thank you, sir, for that eye-opening session. The fine balance between antibiotic use and resistance was explained with great clarity.
The floor is now open for questions. Delegates, please feel free to engage. Kindly raise your hands and we will reach you with the microphone. Any questions from the delegates? I now request Dr. Chandrasekhar N and our chairpersons to proceed to the photo booth.
Hello, good morning all. Myself Dr. Sunil Joshi. Chandru here. Good morning. Wonderful presentation. Just wanted to ask, the usual problem as a practicing surgeons we feel is, what is the appropriate antibiotic for prophylaxis? Many people say so many things. It's about your hospital flora. We don't have a hospital flora. We don't know what organism is prevalent. How do we choose what we choose? I think it's the question from, it will be from the whole of the, all the forum.
Antibiotic prophylaxis itself is a big topic. So how you choose? Usually what we start as an empirical antibiotics. So they say it's a broad spectrum antibiotics which can cover aerobics, anaerobics, gram-positive, gram-negative, everything. But you start thinking what type of procedure you are doing. Are you are going to encounter the bowel, are the enterostomies are there, is it laparotomy, or is it only the skin and subcutaneous tissue infection? So depending upon the type of procedures, so you can choose your antibiotics.
Okay. All right. Thank you.
Sir. Chandu sir, Chandrasekhar sir. Sir, here sir. Sir, Abhinandan. Sir, it was a nice presentation, sir. Two questions from the point of PG, sir. PGs. Sir, role of surgical drains, what we put in causing surgical site infection. And one more is role of culture sensitivity before starting antibiotic.
Thank you, sir. I now request. Thank you, sir. I now request Dr. Chandrasekhar N and our chairpersons to proceed to the photo booth for a photograph and to collect their certificates of appreciation. I request Dr. Bhagwan, Professor HOD, KSCASI Medical Academy, to kindly do the honor.
A warm welcome to the delegates who have joined us now. Our next session focuses on a topic that defines the very essence of surgical success, current concepts in wound healing.
To deliver this crisp and informative lecture, we are privileged to invite Dr. Anand Peter Ignatius, Professor, AJ Institute of Medical Sciences, whose research in wound management is widely acclaimed.
To chair this session, we call upon Dr. Shivaram H.V., Dr. C.G. Sunil, Dr. Shivaprakash D.S. and Dr. Lingaraju onto the dais.
Our next lecture would be on post-operative rounds by Dr. K. Rajgopal Shenoy. To chair the session, I request Dr. Vidyadhar Kinhal, Dr. Sriram Bhatt, Dr. Dayanand Nuli and Dr. Gopinath Pai to kindly be ready.
I want this one. Good morning to one and all. I thank the organizing committee to give me an opportunity. It's not working.
Can you use that label?
No, I want to change the slide. Yeah. It works. Okay. Today's talk will be about, the sequence of the talk will be introduction, older concepts, newer trending issues, treatment strategies, and last of all, the acknowledgements and take-home message. Now, before we start, awareness is the first step in healing. If you're not aware, you do not know what you're doing. Especially in wounds and management or something, you should be aware of all the things which is going on there. Most of the surgeons have got these things that we can treat and manage most of the possible things. There is nothing called as a magical dressing. There is nothing called as something which is, I know my dressings there. Everybody has to have their own things. They're required to know about the concepts, following which you can implement as and when it is required. That is why the artificial intelligence came into vogue, and now we have what is called as a smart wound dressings there. Now, before we introduce into any of the smart wound dressings or something, it should be a structured hospital infection control policy, which sir has already told you, surgical site infections are most common, and that is where we are required to inculcate and habits there. Now, before we look into an ideal environment here, Now, we know the basic things about hemostasis, inflammation, and proliferation remodeling. I am not going to go in depth about this. Older concept says that it should be a moist wound environment, infection, nutrition, blood supply, age, and health-related condition. Yes, it is there. It is obviously there. If you're looking at a surgeon who comes back tomorrow morning after a wound debridement or something, you will like to have a wound which is somewhat look like this. It's an ideal wound. Everybody thinks it wants that, and every surgeon wants its wounds to be healed, healing well, have a good prognosis and a good rate, and patients will come back to him for further treatment and management. Now, if you look into these things, the most compatible thing which we are looking is biocompatibility as well as cost effectiveness. In Indian scenario, we have problems. We do not have an ideal wound care practices. We have practices which is called as applicable the situation demands. In my hospital, in my tradition, in what I have been done and what I have learned or something, those things require to go. You require to inculcate. You're required to be a smart surgeon. You're required to be an AI surgeon. You're required to be an older surgeon, and you're required to be a change surgeon there. You cannot be saying that I will do what I will be there. This is what I've been doing. Yeah, you're right. You are doing. But the situation demands more things to be done with this. Now consider with all those things put together, we have theoretically an idealistic approach. This is exactly given by a therapeutic wound and skin infection cleaning management, Wounds International. That means you are supposed to do a therapeutically clean wound bed, the wound, the surrounding with all aseptic precautions and so on and so forth. But the last line, assess the individual, the wound and the environment. Don't treat the reports. Reports does not fetch you anything, only the wound. So if you are having to look at the holistic approach here, now if you are standing in the optimal wound care here, you are the surgeon who is standing in between, all the rest of the things revolves around you. Now, are you looking for a ideal wound dressing? It's very difficult, but we will not be able to do. If the situation demands and if you get a good one, it will be the best option which is available there. Now, when we look at an ideal wound, do we have an ideal healed wound? Is it a myth or a reality? I have not put any photographs here because we don't find a wound which is ideal there. We are striving, we are thriving, and we are continuously being on the forefoot or something to achieve what we wanted to achieve. Now, being a surgeon, the first thing what happens is wherever you put an incision, you look into what is required there. How well my wound can heal. Are we looking at something which is beyond than what is required? Yes, we are looking at newer concepts here. What are the newer concepts which are going to be there? It is a better understanding of the wound dynamics. I put the new word here, it's a wound dynamics. It's not the wound situation there. You're required to have a smart wound dressing and you have a smart responsive there. Now for that, you require integration, artificial intelligence, and multidisciplinary approach. Now what does a surgeon wants and what he needs to get? You have many scenarios which are being put together, but the surgeon who's here, who makes an optimal decision based on research, clinical data, and patient evidences, is the one who's going to succeed in the near future there. Now when you look back into the recent advances, what do we have? We have accelerated wound healing, we have research opportunities, we have advancement in digital platform, and we have evolving better techniques. I said techniques, not technologies. If you are using a technology, you should be having a good technique there. If your techniques are good, integration of an AI along with your good techniques or something is going to fetch far more than what is required. Your expectation is far more beyond that. So in order to be there, you're required to understand the wound balance and management there. The first and foremost things are biomarkers. Why are we required biomarkers? We never studied about biomarkers. We never looked at metalloproteinases. We never looked at cells which are in the biochemical level or in the submolecular level. These things have been concentrated here for wound healing and management. So the holistic assessment, clinician experience, and evidence-based intervention are the gold standard for wound healing here. Now, if you're considering without this, it is very difficult to treat any wounds there. So our aim is to find and identify and provide early intervention there. How do we provide? We have something called the TIMUS framework. Here we take into wound care, the patient care, and the clinical care. We are not only based only on the wound care per se. You have to look at the patient. You're required to look at the patient care along with whatever is there in this pocket there also. If the pocket runs out, your wound care also stops at between there. Now with that tissue, with that framework, we have tissue, inflammation, moisture, edge, and repair. Now we as a surgeon are very good in surgical department. We want a good debridement. Before we jump on to the next thing, if the wound is not involving, we have different strategies here. We are good in skin graft, we are good in this, we are good in this. But what about these? Do we ever think about this? We never think about this because we don't want to go out of a comfort zone there. Can we inculcate such habits? Yes, we can. Only thing is require a good motivation from the patient, following which you have a good research and development there. Now, looking into the recent advances of what we have in the wound management, the emerging advances technology includes your 3D bioprinting, exosomes, and stem cell therapy. With all these things, we already come across hydrofoam gels, dressing, antibiotic, or whatever it might be, and growth factor. Right now, what we are looking at this ones, radiofrequency, ultrasound, and magnets in wound healing there. Are we forgotten nanoparticles? No, we are not forgotten. We have inculcated those things. Now, when we have a smart wound dressing, what do we do there? We have magnetic stimulation, biochemical dressings, which have 3D printing and self-repairing wound dressings. These are the ones which you require for you to concentrate here. Now, the next generation of sequencing which is going to come there is called as self-monitoring wound dressings. These are in the pipeline. They have not come to the market. These are all in the biochemical things. They are just going on into the lab, and it will be there outside in the next 5 years. Now, if you are thinking to start where the real practice takes place only when you work together. If you're working together, you should be smart together. And if you're smart together, you require everybody's help. That is why we are taking what is now called as an artificial intelligence here. This intelligence is integrated everywhere. You name the thing, it is not there. Your mobile has got, you sit there, you want to prepare a PPT, ask for a thing, it will give you a PPT there. Everybody is there. Now, question only thing which I ask is, the rest of the treatment depends on the surgeon there. The surgeon requests to go and meet the patient, talk to him, tell him what is the problem. You may get so much of AI and so on and so forth, but nothing is going to work. Only when a healing hand sits on the patient, that is the thing which comes. You can give him a good amount of a mobile or something, keep pressing, he will work, but the wound will not heal. You have to make a decision there. How do we make a decision? We require to integrate ourselves into the AI. Now, if you ask me about 20, 35 years or something, my boss used to do open surgeries. Then the generation of laparoscopic came, said, who wants to learn? If you do not learn, you're outcast. You learn, you're in the race. If you're in the race, you succeed. If you succeed, you will climb where you require to go there. Looking into that, that is where we require to analyze that. Are we taking this for granted? No, we are using as much as possible in order to treat such wounds. Can we do it? Yes, we can do it. How exactly magnets are doing that? Magnets are faring well, but these are all in the pipeline. It has to come into the market. There are many problems related to that. Most of them are mainly because of biocomposites, because these things require all FDA clearance, which is not very so easily obtainable. But if you look into the biomarkers, when you stimulate this, what happens to all those things is the wound tissue heals. How effective is it? These all things require real-time monitoring. This can be done only by doing an AI. You cannot sit there with the patient and keep looking at the wound every day and say, this is probably okay, fine. No, we require targeted evaluation there. Once you get a targeted evaluation, then only you'll be able to do what is required then. Now, we have some problems with cytotoxicity, lack of substantiative evidence. That doesn't mean we should not proceed by looking at this. There are many other things which is possible there. You may be there in a thing where you can maybe coming back out and then saying that, okay, we do not want to have a thing. But on the contrary, if you are going to be a good wound expert or a thing there, you require to understand the wound microbiome. As Sir said, we have surgical site infection there. Yes, we have. How do we treat that? We not only treat the patient, we treat the normal commensals which are present and around. We require to study them, we require to analyze them, we require to type them, we require to indicate them individually as per each patient per se. It is not that you apply everybody the same principle there. It's not going to work. Now you are going to have something which is there wherein you harvest the microbiota which is there in the wound commensal. Currently they are used for treating wounds. How do we do that? They are going to stimulate the normal commensal which helps in growth of granulation. Sometimes what happens, you get bacteria which are not good there, you suppress them. That's where the balance comes in the wound microbiome. Now if you are looking at what we want to study about, now the thing is, how do we deliver such things then? We can deliver by either probiotics, prebiotics, or phage therapy. These things are already in the market. Why do we don't use it? We don't have an inclination to use it because we always think, what will happen if I use it? Every single step which has been taken there requires the first step to be the hardest step there. You have to make a decision. Even if it goes wrong, tomorrow you will be successful because these things are going to be inculcated next times. Now, for looking into that, if you are looking at a clinical management of debridement, antibiotic, glycemic control and dressing, look into the delivery system. They are also going to be good. They're going to help you out. They're going to make sure that you are having a wound which is healed very well. Now, looking into the other side of the thing spectrum there, we have 3D designs. Previously, when he said, how do you have a 3D dressing over there? Now, 3D design can be used for reconstructive surgery now. Now, it has already been used for wound. Now, how are we going to deliver it? We are going to have customized scaffolds, personalized drug delivery, skin substitute, and smart wound dressings then. Now, what is the future for that? We have a 4D printing which is coming on the pipeline there. It's already come. Only thing, implementation takes some time. Are we ready? Yes, we are ready. We have so many patients with us. We have all the thing. Only the costing is a problem. We don't have that much of cost or financial ability. But can be done? Yes, it can be done. You require only to make sure that you know what is the wound. This is the traditional dressing. This is how we look into all the other biomarkers, the biome and everything. Then you start printing and you have a customized dressing for the patient there. Depends on where exactly the wound is, whether it's in the foot, the leg, or anywhere. Whatever may be the site, you're required to do a customized thing. Now, once you come back there, what is the next line of treatment, what are you looking for? We are looking at what is called as theranostics. These are the recent advances which is going to be there. What exactly do we mean? We are therapeutic as well as diagnostics. What do we diagnose? We diagnose the ulcer, the biome, and all the microbiota, following which you employ this for a diagnostic purpose and then give the therapeutics for the patient. You're delivering the right drug to the patient at the right time, at the right dose. This is the take-home message. You cannot put your own antibiotic and say, increase the dose and do all those things. We are calculating, we are assessing, we have a proof, we have a documented thing, we are then implementing it. Don't be delayed there. Don't rely on your system for too long. If your debridement is coming there, make sure you do the debridement, don't wait for the reports to come back. It will take minimum 48 hours. It may take more. That doesn't mean you lose the patient by losing your clinical skills. Clinical skills are more important there. Now, before you come back to genetic modification here, let me tell you that previously genetic modification was done only for small people with genetic disorders. Right now, these things have been inculcated into wound healing there. Are we there? Yes, they are there. We have used stem cell therapy for peripheral wound disorders, yes. How are we doing it with mesenchymal, pluripotent, or anything? Whatever the thing mechanism may be, the thing is paracrine signaling, direct differentiation, and modulation there. That helps in wound healing better. The next block on the kit on the block is this. We have even a smart light system there which heals chronic wound. Here they have put the confidential data there. This is the probe which is used here, and this is the statistical analysis what has come, and this is the real-time imaging which is taking place there. Can it be done? It is being done right now. It's there. Then future is there. You will get a band-aid of the future. You just cut the patient, put the band-aid, go off, you don't require to open it up. Are we there? Yes, we are there. How do we do all these things? See, before you start inculcating wound healing and management, you're required to assess the patient, bring in multidisciplinary, control the treating and underlying barriers, decide appropriate treatment, and then evaluate. If it's required, then reassess once again there. Now, this is an algorithm. What's your take-home message, what I can give you there? You are required to be updated with the older concepts. You cannot ignore them. You're required to understand the patient, the history, and so on and so forth. You should have a structured clinical examination. Nothing surpasses a good surgical debridement. You cannot say, I don't want to do a debridement and put all those things. No. First come first. Treat the wound, look into the next, treat the next later. Clinical examination and detailed history is very important. Don't treat the reports of the patient there. You are required to examine what is required. Emerging new technologies are there. It has to be inculcated, and you're required to know about all those things then. It might be sounding like it might be a dead subject, which is not very much there. Ask an opinion of an experienced surgeon. It is more important there. He may not know about the recent advances, but he would have treated the patient previously. He will give you a clue what exactly to which research work you require. The importance of effective patient communication should not be ignored for any reason there. Now, what exactly do we have in future of wound management? There are many. You have genomics, you have proteomics, and you have molecular pathology. This is what we are looking into, potential biomarkers for that. These are the references for the talk. And thank you for your cooperation. And I hope you have an integrated AI. Thank you.
Thank you.
Questions?
Thank you, Dr. Anand.
You're
I think
welcome,
that
sir.
was a wonderful talk. Such a dry subject. You have made it very, very interesting, including the artificial intelligence. I think it is amazing talk. And for youngsters, it's lot to learn how to make a talk very, very interesting. So now coming to the questions, please. Postgraduates first. Postgraduates, this is for you. Nobody wants to ask questions? Somebody is raising the hand there? No. Okay. Then faculties, please.
Yes. Thanks for your wonderful lecture here. I have a small clinical doubt. See, you have a patient, you are treating a patient on some antibiotic, and during you have a wound infection there, and accordingly broad and spectrum antibiotic has to be started.
Now be short and ask a particular question.
Yes, sir. I have started an antibiotic. We have sent for culture sensitivity. Culture sensitivity said that antibiotic is not sensitive, and the wound is healing well. Where do I stand?
Sir, if the wound is healing well and you don't have the problem, I think you may have to speak to your microbiologist or the person who collected the swab.
Okay.
Because that's exactly what I'm trying to. I'll just give you a practical example.
You are absolutely right, sir. I have taken swab for certain thing. I have really
That means
taken
technical issues has been ruled out. It might be that the patient, when he came, there is something that he was sensitive. Right now, he may not be sensitive there. There are always changes. There will be the change. There will be drug resistance. There will be microbial thing. And we do not even look into that. If you ask me, sir, at that time when he spoke about that, antibiotic stewardship, I do not understand why a surgeon cannot undergo a stewardship. Why do you require a microbiologist over there or something to tell us what exactly you require to do? You are the surgeon. You are knowing the antibiotic there. You are putting and you are doing the debridement and anything there. At the end of the thing, you are taking their help. But we don't want to learn anything about the stewardship. We don't want to have an eye hygiene. We don't want to look into that. We don't want to do a clean dressing. But we blame the system.
Yes.
We can't blame the system. See, we are the system. First, improvise ourselves, then look into the system.
Thank you. Thank
If you have a good one, we will have a better
Yes, sir. Thank you, sir.
Sir,
Got it.
concern to that, same continuation, we sent a culture, it is coming as a resistance.
Yes, sir.
What's the role of tissue culture there?
Sir, there is. Before
yes.
you start antibiotic, there is a role for tissue culture. It requires to be sent. But if you're dealing with acute wounds, I may not be anything, but if you're dealing with chronic wounds where you require to put antibiotic, change antibiotic, look into the microbiome, you require a tissue biopsy first before you put an antibiotic on such patients there.
That's in the chronic ulcer.
And most of the time, if it's a chronic ulcer, you don't require invasive antibiotic or something or IV, you require only a topical thing. That is main because of the biofilm which is there. You require to scrape off the biofilm and send for analysis, which we do not do. We tell our PGs that you go and debride there.
And especially in diabetic food, I think the pus culture and the tissue culture makes a lot difference.
Sir, diabetic food.
Sir, 1 minute. Sir.
Sir, please highlight us about cost factor of this 3D print dressings.
Sir, in Mangalore, it's done in KMC. Cost-wise, I have no idea about it. We do not inculcate it. I know only it is being done there. The first case was done in KMC only. If it was for a restructuring for a maxillary fracture there. But any cost, whether the wound is required for the type, the size and everything, you better have to contact anybody person who's doing that because it depends on them. Because I have no first-hand information of dealing with such things because I have not been there. I have been only in touch with them.
Dr. Anand, one basic question for everybody.
Yes, sir.
Every surgeon, when they do dressing, uses some ointment. So what is your take on that and what is the use of these ointments? If you go abroad, you never see anybody using any ointment.
I agree with your point, sir. You don't exactly require an ointment. You're actually my plastic surgeon, the late Leo Theobald Menezes, who was there. He was my teacher. You said, if you do not know about wounds, don't treat them. You require only a moist environment. If you can give a moist dressing without any medication or something, it's more than enough. He used to put plain Vaseline gauze on that along with the main thing and just put the thing there. And I used to always question him, why is he doing that? He said, the day you understand wound, you will do what exactly I'm doing right now.
Thank you. Thank you so much.
Anand, I really appreciate you have made it a point that the good debridement and then followed by whatever the highlights you have mentioned. The infection starts in a surgical wound. Infection starts at the time of the surgery. So be careful. Accordingly, you should start your surgery.
No, before
That is
that
true,
we
sir.
should give prophylactic antibiotic and then cut. Thank you.
Thank you, sir.
Thank you, sir. I now request Dr. Anand Peter Ignatius and our chairperson to kindly proceed towards the right for the photo booth for their photographs and to collect the certificates of appreciation. I request Dr. Anand Prabhu, Professor, Yenapoya Medical College, to kindly do the honor.
Next, we move on to a session that emphasizes the importance of meticulous post-operative care, post-operative rounds, and evidence-based approach.
To enlighten us on this, we invite Girish Rao, Dr. Leo Francis Toro, Dr.
City branch of surgeons. With this background, take you to some very much fun. I don't think any coaching class can give you what you experience or what you get in the post-operative rounds. Remember, it's the time for you to communicate well and show your compassion and care. And that's the small aim of my talk, to stimulate the postgraduates with your interest. So remember, studies have proved beyond doubt that more than 41% of the complications in surgical patients can be prevented if you can take a thorough post-operative rounds. This is an important statement. Now, as you see here, you can expect that a patient has some temperature there. Release one stitch, temperature has come down. But if you don't put your hand and examine the wound, what else you expect? So that is what is happening here. Look at the pain of the patient, position, personal hygiene, periphery, and pump. That's it, just quickly to nutshell about the post-operative period. So as I mentioned, it's a very complex process, and I'm going to introduce a small term called as SOAP. We'll talk about that SOAP, which is a very structured method. While the healthcare professionals, you need to document. There's nothing but subjective, objective assessment and the plan. You can see patient says, my tummy is full. Yes, you measure it, take a girth, put a Ryle's tube. You know how to drain it. There's a patient there. There's a temperature, third picture of CT showing. You have done a surgery, anastomotic leak, and you can see their liver abscess. Patient has gone for pyemic abscesses. That's what you prove there. And DVT is there, suspected. So subjective, objective, and assessment, and the plan, that is what is SOAP. Each one I have given one example. I won't read everything. Postgraduates, just make a documentation of this. Patient says, I am better than yesterday. That's what is subjective. Somebody, patient says, no, yesterday I didn't sleep. So look at the parameters and look at the wound and look at what are the labs. Patient has temperature, counts are elevated, wound is showing infection, you approved it, you with a duple, and then you proved that there's a DVT. So every patient, you can manage this. Patient has got neck dissection, something is coming out there. So this is the concept of SOAP. So as we start the rounds, as you know that we come And first thing you know, always we look at the face. Face reflects. You can make out by looking at the face that whether patient is comfortable or not. You record the vitals there. Look at the nostrils. Accessory muscles are started working more. Oh, that means there is some hypoxia is there. And the patient is anxious, restless. Look at all the tubes. Surgical patients have plenty of tubes coming. One in the neck, maybe one in the drain, polytrauma patients. So every tube you look and feel also the periphery. You go periphery may be also cold. I heard you know very common. The patient has been catheterized, skin has not been put back, and there's a paraphimosis. So these things should not happen. Ultimately, it is the consultant's responsibility. So in the ICU setups, we use the term called a fast hug. That's a feeding analgesia, sedation, thromboembolic would not happen. And again, the consultants will be held responsible. Postgraduates are not responsible. So this is how you look at the tubes, vitals, catheters, pain. You have a pain control, pain ladder. You have wounds you inspect. Of course, wear a glove, we'll come to that. And drains. Nowadays, the drains are closed drains. You don't smell fecal matter. You don't smell urine. You don't smell. Very often, you see that something is coming out. Whereas we used to tell a urinary leak from entering to the ward itself. So these are some of the issues which are occurring in the post-operative patient. So common questions, when you do the rounds, you ask the patient has pain. My question is, did you ask him about his sleep? So that's a question which I ask. So that patient who is not able to sleep means he has got a severe pain. Patient is febrile. Did you examine his chest? Post-operative period itself is some kind of inflammatory period. So next question, is he disoriented? That's important. Have you checked his electrolytes? Sir, blood pressure is only 100. Okay, but that is not the point. Did you examine his pulse? For a person who is 70-year-old, 100 is also a problem. Patient was slowly going for hypotensive shock. There's no guarding. Don't expect any guarding in the post-operative patient. As I mentioned to you, you will not get the guarding. Hiccups. Oh, very important. Did you see the abdomen? Tummy is distended, there's a gastric distension. Put a nasogastric tube, hiccups disappear. Simple things. Sir, patient has passed 6 times urine whole night. I was surprised. What is this? Did you check his suprapubic region? Bladder is distended. But no, sir, patient has passed 6 times urine. Whole night he was in the washing room because he was having overflow incontinence. So these are so much important things, small things. As you do the rounds, please make a note of this. Yes, too much of morphine, that's called a morphine's Ondine curse. There's a mythology you can see there, is from the European, yes, correct. So if you give too much of morphine, you have a nicotine patch and you give tramadol, and there could be a respiratory arrest. Little be careful about this in the post-operative period. Yes, there are some important things where we call red flags. RT showing the massive bleed after a pancreatic necrosectomy. Another patient which is having breathless there. So hypoxia, hypertension, nasogastric tubes. These are some of the important red flags. Just keep an eye on them. Yes, you can see there. Does the video play? Yes. So that just to we are talking about antibiotics, stewardship, etc. Keep it in mind always hand infection, because what happens is you transmit. You do a diabetic foot dressing, and next patient who has got a hernia, you just remove the dressing and you contaminated the infection from one patient to other. So please remember to wear this, wash your hands properly, and of course how you take care of these wounds, which are very important. One important thing which you observe in the post-operative rounds is this, ischemic changes, the flaps, there's a mastectomy. I'm not talking about the method of how you prevent and all that thing. I just want you to bring the rounds in which you see the flap there. Third picture, patient had fever for 4 days after APR, and that was the colostomy site was slowly becoming gangrenous, left colon, and that was the resected specimen there. Intra-abdominal segment was gangrenous. It was missed. That's because you have a bag there and you don't know cause of fever. So looking at this post-operative period teaches you a lot of experience. Look at the second picture, the classical pig fluid coming out is the impending burst abdomen. Don't get worried about burst abdomen. just take him to the theater and suture. That is more important. You don't worry about that. So you see another picture there. Fourth day, there's one small, that one. That's actually a Foley's catheter there. It was a feeding jejunostomy. One hole was in the abdominal wall, caused extensive necrosis of the abdominal wall, CT showing a muscle there. It's almost became like a Melanis gangrene. That's the necrotizing fasciitis of the abdominal wall. So there is so much here, compartment syndromes, and how you are going to look into the compartment syndrome, and massive irreducible hernia coming there. So how will you suspect it? These are various gradings of the abdominal compartment syndrome. So there is so much a post-operative rounds can teach you over a period of time. Some of the common post-operative complaints I will take up because of the time important here. And one common thing is a fever. So just because there's a fever, please don't change the antibiotics, don't start anything. It's basic basal atelectasis to start with, and you know that's very often. So give a good incentive spirometry by the time everything comes down. As you know, the typical 5, wind, water, and wound walking wonder drugs. We'll talk about it. Yes, initial is the first 48 hours is the basal atelectasis. Then later a small early pneumonia and then the patch. You don't treat it, it goes for a full-blown patch and consolidation. So very important is for you postgraduates, there initially you give extensive good nebulization and physiotherapy. You can prevent this complication. Yes, you can see the wound infection, release the stitch, it comes down. So just use your hand gently. And next, you have see how the temperature is shooting there. When we say water means urinary infection or central line catheters, or there it is the central lines, urinary infection, and you see I don't not only say DVT as the cause, then you also look in the upper limb for a thrombophlebitis. So causes of the fever, yes, unilateral lymphedema in the post-operative period, all these are the causes. And most importantly, after this one important question you ask yourself, that is the next W is nothing but what I have done anything wrong. I am not telling that everyone does, it's unintentional. If I have done anastomosis, my important thinking is first anastomosis, has it given way? That is the cause for the fever. Anyway, some of this hypoxia and desaturation, that's a very important thing. Massive hernias, there are so many causes of desaturation, starting from the anesthesia, recovery, to airway obstruction, allergy, asthma, etc. But when saturation drops, that's very important here, that we start with the nebulization, start with the oxygen, then 20 minutes of oxygen therapy, then you do the ABG analysis, and then you need to also know, postgraduates, about the ABG, to read about it. It's a little bit of complicated in the sense if you don't follow. So that's how you make a diagnosis. I'll just go to one or two quick case capsule. 25-year-old boy, first post-operative day of lap appendicectomy. It is like this, patient had some fever, elsewhere referred. He was on treatment, all these antibiotics have been given, construction worker, some things were missed, and ultrasound said counts are elevated, there's a rebound tenderness, so diagnosis acute appendicitis. And look at that heart rate, first post-operative day 100, and then you see the SpO2, how it is coming down, and look at the ABG there. So as it is, within no time, this is his lung, so second day itself. So that means something we have missed. It is not that here, it is what probably might have had was a polyserositis syndrome. It's quite common during the seasons of dengue and leptospira, etc. Irrespective of where was the patient initially treated, who was treated is different. But you see that already my earlier speaker told, treat the patient, not treat the ultrasound report. So there was rebound tenderness. Counts were elevated. When you deeply palpate, yes, there is a peritonism part of the polyserositis syndromes. This is a quick piece for you, for the postgraduates to know that where this is not a surgical abdomen. These are all the medical abdomen. And of course, post-lap cholecystectomy leaks, as you know that to suspect very early, how they desaturate, how they become breathless, and saturation was 78%. You can see the consolidation and how importantly, look at the parameters, what you really ask here. See look at the D-dimers. So much is there in the post-operative patient to realize that, oh, this is a leak, I have to check his saturation, I have to do this, look at the amylase and C-reactive protein are also done. I'm not talking to you, ultimately you do, that's a post-operative management is different. No doubt you stent and the leak subsides and the patient recovers. So these are few other examples of anastomotic leak where, it's a real nightmare for every one of us, that we all pray that my anastomosis should not leak, because if it leaks, this is what happens. But our duty is to identify it early. That is the whole purpose. When a patient is breathless, when the patient has got temperatures, you have to diagnose it early and ask for a relevant investigation. That is what is SOAP. So it's a subjective, objective, get an ultrasound done, put a tube, pigtail insertion, then of course treat the whatever cause, and that is how we manage it. Cesarean section, last case capsule. And fourth day, that's the CT picture, gynec reference. Sir, don't operate, but I am referring to you because RT is showing 1200 ml drain, RT. Patient is in septicemia 110, CT says no perforation. Within 3 hours, it became 140 pulse rate, and there was a Ogilvy syndrome, that is nothing but, most importantly, it is a small cecal perforation. So there was no obstruction, but cecal perforation. This is another patient who had a massive compartment syndrome, and this is the patient who went in for type 2 respiratory failure with that pH 7.29, and after that patient improved up to 7.42. That was the respiratory acidosis. Yes, to conclude, we need to do a well-conducted post-operative rounds, and please follow SOAP, subjective objective assessment in the plan. And again, fundamentals are always important. That brings your foundation stone to the success, individualized approach. And last line, this post-operative complications or post-operative round can tax even the best consultant in spite of best possible investigation and equipment. Sometimes we are in a fix what to do. Thank you very much for giving this opportunity.
Thank you, sir. It was a very insight on the rounds. It's a very essential thing for postgraduates. Of course, many times the problem begins after surgery, because we'll be always worried. Do a laparotomy, then all problems comes, more stress. These rounds makes really different to the patient, surgeon, and team as such. This is very, very important. Most of the things are very nicely in a short period. SOAP and other things, most of the postgraduates should learn these things. Most important, very important thing actually. Rounds, everything sir has discussed very nicely. Thank you, sir.
Hello.
Sir, who all should be there in the team? When you take the post-operative rounds, who all should be there in the team?
Team, sir. Yeah. ICU only we go 3 ICU. Otherwise, the entire team. Assistants.
When you say entire team, sir, who all are there in that?
My 2 assistants and postgraduates.
Because when I went to Edinburgh, sir, there what happens is even a microbiologist or radiologist is also they are close when we are dealing with a complicated patient.
Now we have many others in the routes.
So
pharma, sorry to say, pharma interns are also there. That is a different.
Any question from postgraduates?
Yeah.
Thank you, sir.
Thank you.
I now request Dr. K. Rajgopal Shenoy and our chairperson to kindly proceed towards the right to the photo booth for a photograph and to collect their certificates of appreciation. I request Dr. Preetham Rai, Professor, Srinivas Institute of Medical Sciences, to kindly do the honor.
Ladies and gentlemen, parathyroid surgery is a realm that demands both precision and artistry. Our next lecture is on approach and tips to parathyroid surgery.
We are honored to invite Dr. Santosh Chikkareddy, consultant oncosurgeon at CG Hospital, Hubli, and expert in endocrine surgeries, to deliver this highly anticipated session.
To chair this session, we welcome Dr. Hima Girish Rao, Dr. Prashant Tubachi, Dr. Leo Francis Toro, and Dr. P. Saithamurthy Aital to the dais. Our next lecture would be on trauma initial resuscitation, the first golden hour, by Professor Dr. Rahul Bhatt, and would be chaired by Dr. C.S. Ranjan, Rajan, Dr. Sunil Krishna, Dr. Sampath Kumar, and Dr. Rajashekhar Mohan. I kindly request the delegates to be ready.
Good morning, everyone. We all know that parathyroid glands have posed a lot of challenges to surgeons, be it in identification and the management. So my job today would be to bring some insights into parathyroid surgery, and I have tried to make it as simple as possible for the benefit of PGs. So I will be discussing the anatomy, types, evaluation, techniques, and at the end wind up with two small videos. Coming to the embryology, parathyroids develop at 6 weeks and migrate quarterly at 8 weeks. Superior parathyroid glands develop from the 4th branchial pouch and are generally consistent in position.
Excuse me, sir. Sorry to interrupt.
Yeah.
All the delegates participating in the paper and poster presentation, I kindly request you to go to your respective halls. Rest of them can be seated here.
So the inferior parathyroids develop from the 3rd branchial pouch and descend along with the thymus into towards the mediastinum. That is why the inferior parathyroids are found to be more variable in location. As you can see here, most of the superior thyroids are consistent. That is 80% are located somewhere near the upper pole of the thyroid, while around 50% of the inferior parathyroids are found at the lower pole, either in the anterior or the posterolateral aspects. But there is a lot of variation in the inferior parathyroid. They can descend up to the mediastinum. Coming to vasculature, most of the blood supply is derived from the inferior thyroid artery coming from the thyrocervical trunk, but at least 20% of the blood supply to the upper glands are derived from the superior thyroid artery also. So there is anastomosis which prevails at the upper pole of the thyroid between the superior and the inferior thyroid arteries, and it is drained by the superior middle and inferior thyroid veins. So another important structure which comes here is the recurrent laryngeal nerve. So all of us should be aware of this, and it's a very important structure. In a cross-sectional view, when you see the superior parathyroids are situated dorsal to the recurrent laryngeal nerve, while the inferior parathyroids are ventral to the nerve. So usually the superior parathyroid is very consistent. Usually it is present around 1 centimeter above the junction of the recurrent laryngeal nerve crossing the inferior thyroid. So it is generally located 1 centimeter above this. But the inferior parathyroid, as discussed, has variable locations, which will be discussed later. So we should really understand the spectrum of hyperparathyroidism and when surgeries are indicated. So we have the primary, secondary, and tertiary hyperparathyroidism. Primary is basically when a single gland is enlarged either due to adenoma, hyperplasia, or carcinoma, and results in increased production of parathyroid hormones. Though in some rare cases we also see multiple glands here. In secondary hyperparathyroidism, generally it is due to overproduction secondary to chronic abdominal stimulus of varied causes. Tertiary is something where an autonomous hypersecretion occurs due to a chronic secondary hyperparathyroidism. So basically in the first and the last types, we treat those patients upfront with some surgical intervention, which will be discussed later as to what type of surgery is involved. For secondary hyperparathyroidism, generally it starts with the primary medical management as the first line therapy. So coming to the types of parathyroidectomy, we have 4 types. The focused or the minimally invasive, which is recently introduced and being done today. It is usually in cases of well-localized solitary adenomas, where a limited incision is taken with direct exposure to the parathyroid adenoma. So bilateral neck exploration is second type of surgery where it's done in a case of unsuccessful preoperative localization of the gland. And here there is an exploration of the full neck is done with identification of all parathyroid glands and the removal of the adenoma. So these two basic procedures are done for primary hyperparathyroidism. Whereas for secondary and tertiary, we do something called as a subtotal parathyroidectomy, where it is usually resulting due to parathyroid hyperplasia. So we can't detect which single gland is enlarged. So 3 largest glands are removed, and of the smallest gland, a small remnant is left behind either in situ or transplanted. The last one is the total parathyroidectomy, where all parathyroids are removed. So basically these are only for salvage procedures in case of recurrent cases. So what is the surgical evolution? So it has progressed from open to laparoscopic, endoscopic, even recently robotic through transaxillary approach also. We also have the radio-guided approach where a technetium is used and a gamma camera is used intraoperatively. So all this holds good, but even in today's era, even open surgery also holds good as far as parathyroid is concerned. So coming to preoperative evaluation, this is the most important step before any parathyroid surgery. So how do you localize and diagnose? So one is the endocrine diagnosis. PTH assays are very important. and other investigations related to secondary and tertiary hyperparathyroidism also need to be done. So the most important aspect of any surgery is the pre-op localization, which is the standard of care in today's era. So a lot of investigations have been mentioned, so which includes the following. So these can be divided into non-invasive and invasive. So earlier a non-invasive was considered to be standard. The most reliable is still selective venous sampling of the parathyroid hormone assay. But because it is invasive, nowadays more and more non-invasive tests are being considered. So we use the combination of ultrasound as well as cystoscopy scan, which is available in most of the places. So cystoscopy scan costs around 7,000, so it can be done in most of the places. So we do it has been standard of care that 2 concurrent examinations have to be done for definite localization. So we follow something like this. So ultrasound is used. A normal parathyroid gland is usually not seen on ultrasound, but a parathyroid adenoma can be seen. It is hypoechoic, round, homogeneous, and extrathyroidal in location. So combination of ultrasound and cystoscopy scan is very good for preoperative localization, and hence should be considered the standard of care. Coming to surgical approaches, 2 approaches are mentioned depending on what type of surgery you are going to do. One is the anterior approach, which includes medialization of the thyroid gland and possible bilateral neck exploration. So this approach is used whenever a bilateral neck exploration is considered. The second approach is the lateral approach, where the dissection is done medial to the SCM and the carotid sheath. This is only done in cases when a minimally approach is used for a single gland adenoma. So whatever surgical approach is used, it is very important that in these cases meticulous hemostasis is the most important factor in these type of surgeries, because identification is reliant on subtle shades of color and consistency. So what should be done? Be calm, be meticulous, so don't mess up and don't cause a lot of bleeding there. So meticulous hemostasis is a very critical point to be remembered. So salient steps include for anterior approach, an incision followed by subplatysmal plane should be raised. A dissection should be done between the strap muscles and the anterior surface of thyroid, followed by ligation of middle thyroid vein, identification of superior and inferior parathyroids. So these will be explained in one of the video. So how do you confirm successful removal? So there are certain, again, features of confirmation. Most important is clinical. We all know that normal parathyroid is golden tan in color, but adenomas are usually rounded, darker and fleshy in nature. It is easy to mistake adenomas with fat, lymph node and thymus, which are pale yellow in color. Frozen section again is useful to diagnose whether it is parathyroid or no, but it can't differentiate an adenoma from hyperplasia or malignancy. So, but the most important is again intraoperative PTH assays, which are being done nowadays. So many studies have mentioned that a 50% drop in PTH levels post-excision up to 10 minutes is the standard of care, and it improves the accuracy of more than 90%. So what has to be done? 10-minute PTH has to be sent intraoperatively. It takes usually half an hour to get the reports at our centers. So 50% drop in levels confirms the diagnosis and a good surgery. Persistently elevated levels necessitates further exploration for further adenomas. So again, if exploration fails and we don't get it, then what should be done? So in these cases, if all 4 glands have been found and it is found that there is no adenoma, then it is a case of 4-gland hyperplasia. Subtotal parathyroidectomy has to be done. If we are seeing 3 normal glands and there is a missed gland and we are not able to find it, exhaustive search is required in the following places, which are because these are the places for ectopic glands. So basically, these are more common in inferior parathyroids where they can be found in all these places. Coming to even after all this, we don't find a gland, what to do? So this probably is a case of missing a gland, an intrathyroid parathyroid. So we go ahead and do a hemithyroidectomy in these cases. Sometimes it is situated deep into the thyroid, so this should not be missed. So I'll be going with the anterior approach where the 4-gland exploration was done in this case. Video please. No, please come back. Yeah. So this is a case where a right superior parathyroid adenoma was found and a systemic scan was done. But systemic scan showed a left lobe thyroid enlargement also and a small left side parathyroid adenoma also. So 4 gland exploration was done, planned along with left hemithyroidectomy. Again, so subplatysmal flap should be raised from thyroid cartilage to the substernal notch, and the dissection proceeds with this elevation of the flaps and the dissection between the straps and the thyroid, like any case of thyroid surgery. So it is very important to, again, as discussed, maintain a meticulous hemostasis and go into correct plane so that we should not be causing bleeding here. So this plane is elevated in the midline. So once we reach the thyroid, we need to go into the plane, avascular plane, so and make sure that small vessels may be here. So coagulate them with the bipolar. So this is the thyroid gland here, and it is gentle traction is done. So peanut can be used, it's a very good instrument here. So with gentle medial traction on the thyroid, you can see the IJV here and a pulsating common carotid. So this is the parathyroid adenoma in the right superior part. So right superior parathyroid adenoma was found, which was highly vascular. So again, a gentle dissection has to be done and made sure that the thyroid is retracted medially properly. And bipolar has to be compulsorily used here, monopolar should be avoided. So either the dissection can go both ways, either it can be retracted from the thyroid and then move to the main blood supply of the parathyroid, or it can come the other way around. So here we started with dissection from the thyroid and moved ahead with slowly isolating the small vessels and then coagulating them with the bipolar cautery. So as you can see, the parathyroid adenoma is darker in color compared to a normal thyroid, which is golden tan in color. So the adenoma was released and a wash was given, and then we proceeded with the examination of the other parathyroid glands. So this was the inferior parathyroid, which was found to be normal. So because the patient was planned for a hemithyroidectomy on the left side, the superior pedicle was ligated, and then we proceeded with the identification of the left superior and inferior parathyroids. So there was a small lymph node here in the inferior aspect which was removed so that identification would be better. So this is the superior parathyroid which is identified and preserved. So again, this was found to be normal. So here in the next photograph, we can see that how to differentiate between a normal fat and a parathyroid. So this is superior parathyroid, which is golden tan in color, and this has to be differentiated from the fat which is surrounding that. So as here you can see, this is the parathyroid and this is the surrounding fat, which is pale yellow color. So these can be confused. This should to be separately seen and preserved. So in this case, so left lower parathyroid was also enlarged, so we removed it. So after identification, I'll take just one more minute. So this was the parathyroid gland. So again, coming to the lateral approach, minimally invasive or focused, this is done in a case where we go for a pre-surgically identified parathyroid adenoma. So this 69-year-old male, this is just a 1-minute video. Severe osteoporosis, low back pain and lower limb numbness, calcium of 11 and PTH of 153. Parathyroid scan showed a right inferior parathyroid adenoma. So this was the ultrasound. Here is the parathyroid adenoma. So this approach involves taking a small incision with a minimal invasive approach. So this is a parathyroid adenoma which was diagnosed in ultrasound. So again, a small incision is used at the lower aspect of the neck. So dissection proceeds by lateralizing this sternocleidomastoid as well as the carotid sheath. So here you can see that we are lateralizing the carotid artery and the IJV, and then dissection proceeds on the middle aspect of them. So this is the parathyroid adenoma. Gentle dissection is done after medialization of the thyroid. So undue traction should be avoided in the minimal approach. So small vessels are coagulated. So this was a smaller lens compared to the previous case, around 2 centimeters in diameter. So again, care should be taken to not to damage the rectal laryngeal nerve. So this is the parathyroid adenoma which was excised. So in this case, all other parathyroid glands were found to be normal. So complications of parathyroid are varied. So temporary hypercalcemia occurs in 20%, while permanent occurs in only 1%. So nerve injuries are also rare compared to thyroid surgeries. To conclude, it is very important to understand the spectrum of parathyroid disease. Accurate preoperative localization is very important. Surgical treatment still challenges surgeons, whether it is due to localization or it is performing the surgery. Thorough anatomy and meticulous surgery is a must. Meticulous hemostasis is therefore critical in these surgeries, and we should also be ready to appropriately manage the post-op complications. Thank you.
Yeah, thank you very much, Doctor. Fantastic presentation. Very nice video too. Here, Himgirish. Yeah. Did you do intraoperative PTH?
Sir, we have sent, sir, in 1, 2 or 2 cases, we have just started with the procedure now.
Okay.
But we generally do it at 10 minutes, and it takes, in our labs, it takes 30 to 45 minutes to get the reports, but we have done it for 2 cases.
What was the fall?
A fall, it is, one case we got a 30% fall actually,
okay.
But probably we might have sent at a later point of date, later time of 50 minutes, 20 minutes, maybe the fall would be better. But in one case we found around 60% of the fall. So, but in standard as per the data, they show that at least 10 to 15 minutes of fall of around 50% is expected.
What might have happened is when you were dissecting, you probably took care of the vein.
Yes.
You took care of the vein.
Yes.
So maybe if you had taken another sample just after dissection, just before you take out, once you lay open the gland, then you take another sample, a second sample. That will probably be higher than your preoperative sample because you are manipulating the parathyroid. That will drive the PTH more into blood. So you take that, and 10-15 minutes later you take another sample.
Yes, sir.
Nice presentation, Santosh. Any questions from audience?
Yeah, it was a nice video. 2 things. One, it is better to have a focused parathyroid culprit gland before you plan for any parathyroid surgery.
Yes, sir.
Like earlier days where 4-gland exploration was practiced in the past when there were no investigations, and nowadays it doesn't hold good. So you have to find out the culprit gland first. Second, that Miami criteria, it is better to do 5, 10, 20 after excision of the gland. Because you already diagnosed, remove the tumor, 5, 10, 20, 3 samples, it has to be less than 50% of the earlier value. So these 2 important points.
Yes, sir, agreed. 3 samples. One is on table at induction. Second, during dissection. Third, 15 or 10 or 20 minutes or whatever your criteria is, post-excision.
And one 24-hour post-surgery also we generally do, sir.
You can do that, but generally that will be in the single digits.
Yes,
Once generally it falls. If it doesn't fall within 10 minutes, it will not fall.
Yes, sir.
The other thing is this selective venous sampling. You said it's a gold standard.
No, it has
gold
been
standard, but it is not very commonly done.
Yeah, because it is invasive now. It is not being.
Unless it's extremely difficult to localize, unless you've done that patient, some patient has, if it's been a failed exploration elsewhere, they've tried to do it, they've not located it. You do an ultrasound, you don't find out anything. You do a cystectomy, it doesn't tell you anything. Because cystectomy is only 70% sensitive, mind you.
Yes, sir.
It's not very sensitive.
So now the gold standard would be to have two sets of investigations. Generally, we follow ultrasound with cystectomy. So both will give us reasonably good preoperative localization, sir.
So we are short of time. The thing is only once you identify with USG and cystectomy, once we take out that particular gland, no need to explore the other glands.
Yeah, no need to explore. So if you have identified it clearly preoperatively, if there is a doubt in identification, or if in the first case the cystectomy showed there may be two different adenomas, so sometimes some cases present us with a dilemma, then we go ahead with the 4-gland exploration.
Thank you. Thank you very much.
Thank you, sir.
Thank you, sir. We now request Dr. Santosh Chikkareddy and our chairpersons to kindly proceed to the photo booth on the right for their photograph and certificates of appreciation. I request Dr. Clement D'Souza, Professor of Father Muller's Medical College, to kindly do the honor.
To conclude this academic block, we now delve into one of the most critical aspects of trauma care, initial resuscitation in the first golden hour.
We are privileged to have with us Dr. Professor Rahul Bhatt, Professor KMC Mangalore, whose expertise in trauma management protocols is truly exemplary.
To chair this session, we invite Dr. C.S. Rajan, Dr. Sunil Krishna M., Dr. Sampath Kumar K., and Dr. Rajashekhar Mohan to the dais.
Good morning, everybody. Today I will be talking about that thing that we see most often in our daily practice. And last but not the least, but trauma is such a thing that when we enter into surgical wards, or even when we start our surgical practices, this forms, amongst the most of the cases, this forms one of the main bunch of the cases. One we find diabetic foot, the other we find malignancies, and then we have the trauma. So how to go about with the resuscitation of trauma? Now many generations of thought has gone into, and currently now it has come down to systematic guidelines that has been set by ATLS. We in our own college, we have certain guidelines which we call critical care guidelines, which we even involve the trauma cases. So the key concept, the initial assessment is a systematic and rapid approach to treating injured patients. The initial assessment stays in the forefront, and it has a key elements over here. The elements is first preparation. The preparation starts from the time when we come to know that such and such a place the trauma has happened, or when the trauma patient is wheeled inside the casualty. Then the initial bunch of group of the medical professionals who meet, they must be prepared enough to deal with such a case. So that will be the preparation aspect. Triage is a place where when we have clarify whether this patient requires a kind of immediate care, or it can be delayed upon looking into some another patient which requires a higher amount of care. It means a way of resource management, both manpower as well as the other resources that we are available to give to the patient that deserves the most. Then we start with the thing that we have learned over a period of time, that is involvement of airway breathing circulation. We call it as the ABCDE. And what should be instituted along with ABCDE? That means, are we dealing with the investigations, or we are supporting with the management at the same point of time? We call it as the adjuncts to the primary survey. Then there is a time when we consider that, okay, we have stabilized so much, we may not be able to deal with the real problem over here. In such a scenario, we must be able to send the patient to somewhere else. Now that will be the consideration of transfer. That will be the teamwork, and the team decides like, oh, whether we can manage or whether we need to send this patient to somewhere else. The last but not the least, once everything is over, then it's a time to take a, once the patient is stabilized with the resuscitation, it's a time we take a survey where we might have missed certain aspects which we wouldn't have thought about during our initial primary survey. And the definitive care. The definitive care will be that thing that the patient needs in order to come out of the hospital. So considering the concept of golden hour, this a very simple graph over here. We see 3 lines. The first line, the green color, is regarding the heart. The moment the heart stops, the mortality rate by at around 5 minutes to 8 minutes is almost 100%. That is what the green line tells. Similarly, if you see at the blue line, and we see that the respiration stopping at 0, and at around 1 to 1.5 minutes the curve starts, and by 15 minutes majority of the patients who have where the respiration has stopped, they pass away. The third line is the line that we are dealing with in today's topic, that is the golden hour line. So initially for first 15 minutes almost nothing happens, and from 15 minutes the actual morbidity and mortality starts with the loss of blood, and it peaks by at around 1 hour. Like if the massive blood loss has not been controlled, this patient may not make the day. So the concept of golden hour is a critical window of opportunity where we as medical professionals can significantly impact the morbidity and mortality, and the timeliness over here, when we act over here, that is the key over here. Now coming to the preparation, we have a pre-hospital phase and hospital phase. So I am considering pre-hospital phase over here for those bunch of patients which we see in the say a person who has met a road traffic accident, and it's in the, and this is instituted by the people who are in the ambulance. So majority of the time in our country it is the paramedics. So they must be adept enough to understand that what causes mortality immediately. I mean the basic airway, and if they are able to cater to airway and the hemorrhagic aspect over there, then it can save a lot of effort when the patient actually comes to the hospital. So not only that, this team, nowadays we have mobiles and we have other methods of communication with the team, though that team must be able to communicate with the team which is there in the hospital and explain, like, we are dealing with this casualty, these many casualties, and we may require this much resources, so that the party which is back in the hospital must be able to get all those resources with the team leader at that point when the patient is wheeled inside the casualty. This happens to be what we called as the pre-hospital phase. Once the hospital patient has arrived to the hospital, since we know that there are so many casualties, we must be having an enough large place in order to triage the situation, and then the team, within the team there must be a person who must be able to cater to the basic, the airway, the breathing, the circulation in the team, so that it can be instituted. During this process, the standard precautionary protocol measures, because we don't know the HIV, HBsAg or any infective status of the patient, all the people who are there in the trauma, it's more or less, it's they have to protect themselves. So the standard protection protocol is should be followed. Now considering the triage. Now triage, the most important person, the person who requires the most care, who has the highest degree of morbidity and mortality, should receive the highest preference over here. But there are situations where the idea or the principle can change. For example, if we call it as multiple casualties, when our setup in where we are working are able to deal with all the casualties with the resources that we are having, both manpower and the other resources that are required. Then But mass casualty is a place where we give the opportunity to the person who has the maximal survival capacity. If a person is already brought in wheeled dead, wheeled in with in a dead on arrival, so in such cases, the attention should be more towards the person who is likely to lose his life. Coming to the primary survey, this is the most important thing, because as I put in the previous golden hour slide, I put a line of red color and before the line of green and blue color, the respiratory, because if something had to happen and he had to pass away, he would have passed away by that time. But the next most important thing becomes the airway. Now, airway is to be managed then and then itself, not when the patient is brought to the hospital, when the patient is first seen in the periphery. So what is the first thing that a person can, a medical professional can do with the patient? He can ask the patient, like, what's your name, what happened, where are you from? If the patient is able to answer, it more or less is evident that his airway is clear and he is coherent. The coherence tells that he has got enough cerebral perfusion, telling that at least there is he may not be having a brain injury, he might be having a hypovolemic shock, but still the brain perfusion is good enough. At the time of airway management, it's necessary that the first thing is to see for airway patency. Airway patency, if anything is there in the mouth, in the throat that needs to be suctioned, aspirated, should be performed, with emphasis on the cervical spine stabilization, so that our attempt to save should not damage the patient himself. So, and with this thing, if there is, we are having opportunity to for oxygen saturations, then we can give, we can start oxygen then and there itself, and with this, and if there is any ongoing bleeding, we can control the bleeding and bring the patient to the main hospital setup. So we are surgeons. We don't do endotracheal intubation on a daily basis. So what can we do? So we have an opportunity to do a bag and mask ventilation. Bag and mask ventilation with say a non-breathable mask with an oxygen reservoir and a 10 or 15 liter flow of oxygen can bring, if given properly, if airway is patent enough, can raise the oxygen saturations to 60 to 80% for definite. And once the patient is wheeled in, and if he is not conscious enough, then if there is a person within our team, most of the time it is the anesthetist, they must be able to perform the endotracheal intubation if and when required. Otherwise, for us, a bag and mask ventilation with a simple jaw thrust which opens the mouth and an oropharyngeal airway, which popularly called as the Goodell's airway, is more than enough to for a surgeon to save the patient's life for some period of time. Coming to breathing and ventilation. Breathing, the next thing, once an airway is established, the next thing we need to say is whether the patient is breathing properly or not. We can see whether the patient's excursions and incursions with every breath, whether it is happening properly or not. Or sometimes we can see a flail chest with a paradoxical respiration. The neck veins we can check for, because sometimes if there is a cardiac tamponade, we can see the raised JVP. But I agree that if there is a lot of blood loss, this JVP might not get raised. Yes, but that is the way we can assess for a breathing. At the same point of time, put a pulse oximeter, see for a capillary filling time. This may tell us whether there is enough blood flow to the periphery or not. If we in the trauma team, if we have a good nurse, she must be able to put two large, or a good anesthetist, they must be able to put two large IV bore lines of gauge 14 or gauge 16 and start fluids immediately. Fluids, we need to be little bit diligent enough. Yes, the protocol is we push 500 to 1000 ml of crystalloids almost immediately. But if we don't know about an old patient who has come with a cardiac and we put a large amount of fluid and the patient may go into pulmonary edema, which is a possibility, So if we are suspecting that cause, or if the patient has a bystander who is able to tell us that info, then we can give somewhere between 5 to 10 ml per kg body weight. Otherwise 20 ml per kg body weight is not a real issue. But we cannot overdo with the crystalloids. The problem is if we do overdo, it will cause hemodilution. Then there is always a problem with discoagulability. So it's better off to give a blood in such a canal. We have to order for blood almost immediately. Putting two IV bore line at the same point, we can take out blood and send for necessary investigations, blood grouping, cross matching, and order for blood immediately. The next thing we have to think about is the disability and exposure to environment. Disability, two things. One is the cervical spine disability, another is with the Glasgow Coma scale. If the patient is able to talk, he must be around 13 or 15. It is mostly with the reduced perforation. But Glasgow Coma scale between 8 and 13, yes, this is a time where we have to think about intubation. Cervical spine needs to be stabilized with a cervical collar, or the patient might be locked in. The next thing is exposure. When we expose the patient might develop a hypothermia. Better to not have it in a AC environment where the temperature is around 22 degree. Better to switch off the AC. It is not for our convenience, it is for the convenience of the patient. And when we are pushing in fluid, better to push warm saline instead of cold saline. The choice of saline, it will be better that if it will be a ringer lactate, since it is physiologically much better when compared to normal saline. Now, what can help us along with in the primary survey? An ECG and echo monitoring can tell us about the heart, pulse oximetry and ABG. ABG tells about the partial pressure of the dissolved oxygen in serum, whereas SpO2 tells about the deoxygenated and oxygenated ratio of the blood. Capnography will tell us about the amount of carbon dioxide that is coming out, which tells whether the person is able to respire properly or not. X-ray and fast can be kept at a later time once the patient is completely stabilized. If we are surgeons and we don't have an ultrasound backup, we can always go for a diagnostic peritoneal lavage. Urinary and gastric catheters should be need to be given with some amount of respect, because patient with pelvic fracture might have a urethral injury. And while putting gastric catheters, we have to be careful in a case of head injury. The orogastric tube might, the nasogastric tube might go through the cribriform plate, causing injury. So that needs to be given some amount of importance. Coming to the secondary survey, we have to head-to-toe examination is being considered.
1 minute.
Yes.
1 minute more, please.
Yes. We think about allergies, medications, and previous past illnesses and pregnancy, the last meal, and the events which happened related to the injury. We need to take that's a time when we take about history about how the entire things happened. Regarding head-to-toe examination, we need to be careful about the head and maxillofacial injury. I told about the nasotrauma, especially the Lefort 2 or 3 types of fractures. The cervical spine injury, if it is below the level of severity, it's okay. Above the level, it can cause diaphragmatic palsy. Chest needs to be auscultated and checked for any open pneumothorax. The abdomen and pelvis, the pelvis needs to be checked for, because any change in the pelvic fracture can lead to recurrent bleeding and patient may go into hypovolemic shock. I'll take half a minute. Yeah. So it's a process where we evaluate and reevaluate whether our whatever we have instituted, we have done it properly or not, and that is the principle that the entire ATLS runs about. And we need to have a team leader who coordinates the entire process, and we need to have a team which does this. So timely decision is the most important thing. We should not do any harm in the process. If it's not possible in our harm, we always need to refer the patient outside. And key takeaways is preparation saves life. The primary survey focuses on life threats. Reevaluation and communications is continuous, and teamwork is essential. Thank you.
Thank you, Doctor. It was a wonderful talk, a simple talk which all the PGs can easily understand. Thank you very much.
Yeah.
And the trauma to survive the patient, to help him outcome well. Two things are very, very important. Resuscitation, assessment plus treatment.
Resuscitation.
Yeah, these
They
are the
should-
two. Together it should go. Otherwise we
Yes,
lose the
yes.
patient.
They should be happening simultaneously.
Simultaneously.
A very informative session indeed. Thank you, sir, for guiding us through the life-saving strategies of trauma resuscitation. I now request Dr. Rahul Bhatt and our chairpersons to kindly proceed to the right to the photo booth for a photograph and to collect the certificates of appreciation. I request Dr. P. Satyamurthy Aital, Professor, Kanachur Institute of Medical Sciences, to kindly hand over the certificates.
Thank you, delegates. We have now concluded our sessions with the lectures, and now we'll be proceeding with the trauma paper presentations. The judges for these sessions are Dr. Nash Sheikh, Dr. C.S. Rajan, Dr. Dinesh, and Dr. Rajagopal Shenoy. I kindly request the judges to please take their seats.
Very good afternoon. We have concluded with the morning talks and the lectures. This is the first time in the MidCon we have introduced especially a trauma session and a trauma poster session. It's a competition. I think all of you know that trauma is an integral part of our, you can call it a surgeon's life, because you know that you day and night you see the trauma cases. That's one of the reasons we introduced the trauma. Just you concluded the initial assessment. I have one small thing to do here. That is my dear friend and one who has worked for the secretary for the Karnataka state also, and treasurer, active surgeon. And there you can see him standing this side. I don't have the, that's late Manjuna Shanai, professor of surgery and HOD from the JSS Medical College. So as he was working for the association as a secretary, he met with an accident and he's not with us since a long time now. So we, Association of Surgeons of India and KSC, we had a departmental meeting, not departmental, EC meeting, and we approved this session today, to go in his name. And there's also special awards given to this. I'm taking, madam, please come here, Dr. Lavanya Shane, and Dr. Abhishek is there. Yeah, please, Abhi and his, please. So this session we are actually named in late Manjuna Shane Memorial Session, and for today, and special prizes. That's the reason I invited and we welcome trauma papers, particularly for this conference. Madam, just want to say.
Good morning. Thank you so much, sir. Thank you so much for doing this for our family. Yeah, indeed, I am so happy that this particular thing is happening in a place where Dr. Manjuna Shane was born. And it is exactly after almost 9 years of after his demise, this something is happening, and that is, you know, I immensely thank the South Canara ASI and of course KSCASI first, and also Dr. Rajagopal Shane and Naz and Sarvesh. Thank you so much. And yeah, I would also like to, from our family, give a small token of appreciation and thing as a prize to the today's competition. And I want sir to accept that. Thank you so much, sir.
Thank you. Let's start. I think we'll start.
We will now be beginning with our trauma paper presentations. The first presenter is Dr. Soumya S. Judges, please note UID for the presenter is TPP5. Delegates to please note the first bell will be rung at 6 minutes and the next bell at 8 minutes. So it is 6 plus 2. Tea and coffee have been served on the ground floor. Dear delegates, please feel free to help yourselves. First presenter is Dr. Soumya S. TPP5. UID TPP5. Next presenter would be Dr. Akshata Thakre. Please be ready with your presentation.
Good afternoon, everybody. My name is Dr. Soumya. I'm a second year resident from Emma Medical College, Gulbarga. Before starting, I would like to pay respect to Dr. Manjunath Shenoy sir and my guide, Dr. V.S. Kapikeri sir, who's a professor and vice dean. Without whose support, this would have not been possible. My topic is the role of mangled extremity severity score, that is MES score, in deciding whether to carry out amputation in patients with mangled extremities resulting from the road traffic accidents. Next. Okay. Before starting, let us know what is mangled extremity first. Mangled extremity is a severely injured limb where at least 3 out of the 4 systems are injured. The 4 systems are bone, soft tissue, nerves, and blood vessels. These are significantly damaged, threatening the limb's viability and function. These are the pictures of our own casualty, where we had an RTA and a crushed limb. Mangled extremities resulting from road traffic accidents, they pose a significant challenge to the surgeons because of the extensive damage to the bones, soft tissues, nerves, and blood vessels. These injuries demand urgent decision making regarding whether to salvage the limb or to carry out an amputation, which can significantly impact the patient's quality of life, recovery, and healthcare costs. Thus, the mangled extremity severity score was developed to aid surgeons in making this difficult decision. This study aims to retrospectively evaluate the effectiveness of the MES in predicting the need for amputation in patients with mangled extremities due to RTA. Thereby, it will help in our clinical decision making. Now, let us move on to the score proper. There is a mnemonic to remember the score, that is ELISA. E stands for energy, LI stands for limb ischemia, S stands for shock, and A stands for the age. Moving on to the individual components. First is the energy component. It is divided into 4 scores. First one is the low energy trauma, that is stab, simple fracture, or pistol gunshot wound. It is given a score of 1. Next comes the medium energy trauma, that is open or multiple fractures and dislocations. The next is high energy, high speed motor vehicle accidents, rifle gunshot wound, given a score of 3. Last one is the very high energy trauma, that is a high speed trauma, and there is gross contamination, which is given a score of 4. Next component is the limb ischemia. In limb ischemia, first, if there is reduced pulse or absent pulse, but the perfusion is normal, then it is given score of 1. Second, there is pulselessness, paresthesia, and diminished capillary refill, then it is given a score of 2. Last one is the cool and paralyzed limb, which is given a score of 3. But the catch here is that if the patient presents to the casualty, if more than after 4 hours, then the score needs to be multiplied by 2. Next component is the shock. Shock, there are three entities. First one is the systolic BP is always more than 90. Then it has given a score of 0. Transient hypotension is given a score of 1. And persistent hypotension is given a score of 2. Last component comes the age. Age, if it is less than 30 years, then it has given a score of 1. 30 to 50 years, then it has given a score of 1. And more than 50 years, then it has given a score of 2. We can see here that the maximum possible score will be 14. 1 to 6, usually it is considered as the limb can be salvaged, and 7 to 14 is that there are possibilities of amputation, the limb unlikely to be salvaged. A MES score of more than 7 is generally associated with higher risk of amputation. Next is the materials, patients and methods. The study design, the study is a retrospective observational study. It was conducted by reviewing the medical records, imaging and operative notes of the patient aged more than 18 years who presented with mangled extremities at a tertiary care center. This study included 3 years, that is from 2022 to 2024. Total number of patients included in the study were 30. Inclusion criteria was patients more than 18 years presenting with mangled extremities because of RTAs. Exclusion criteria was non-traumatic injuries or incomplete clinical records. MES was calculated at the time of arrival of the patient, that is at the initial presentation. Patients were grouped based on their MES score into two groups. That is, the first group is MES score less than 7 and the second group is MES score equal to or more than 7. This is my data. It includes the age of the patient and which limb is involved, that is the right limb or the left limb, and what energy trauma it was, and what grade of limb ischemia it was. If the patient would present to the casualty more than 6 hours, then it would be multiplied by 2. Then comes the shock, age and total count. We can see here that the scores equal to and more than 7. It was seen that the limb was amputated. And the score 1 to 6, it was seen that the limb was salvaged. Total of 30 patients were included in the study. Results. First, let us see the true positive cases. What is a true positive? That is MES more than or equal to 7 and the limb was amputated. False positive, MES more than or equal to 7 and salvaged. True negative was MES less than 7 and salvaged. False negative was MES less than 7 but amputated. We can see that true positives were 20, false positives were 1, true negative was 6 and false negative were 3. Further calculating the sensitivity, specificity, positive predictive value and negative predictive value, it was seen that sensitivity was 6.96%, specificity was 85%, positive predictive value was 95.24%, negative predictive value was 66.67%. This is a graphical representation of my study. This reinforces we can see that this study shows that MES score has a high positive predictive value, that is of 95.2%. This reinforces us that MES is an effective tool in predicting the need for amputation, especially in confirming high positive predictive value, rather than ruling out negative predictive value cases. The area under the curve also came out to be 1, indicating a good discrimination between patients who needed amputation and those who did not, based upon their MES score. Observation. Higher MES scores correlated significantly with the decision to amputate and poor limb viability outcomes. Patient with score less than 7 underwent successful limb salvage, and patients with MES score more than or equal to 7, majority underwent primary amputation. Conclusion. This retrospective study assessed the correlation between MES and actual treatment outcomes to evaluate the scoring system's reliability and predictive value. The mangled extremity score is a practical and reliable tool for early decision making in patients with severe limb injuries caused by RTAs. A score of more than or equal to 7 demonstrates a high predictive value for amputation and can help surgeons in situations where time-critical decisions are necessary. While mesh should not replace the clinical judgment, it serves as a valuable adjunct and should be used alongside clinical judgment and multidisciplinary team input. The limitations that I found that were found through the study was the mesh score could not be applied to upper limb injuries, sir, and it has poor predictive value in pediatric age group. It may not reflect the advances in microsurgical reconstruction techniques. So further, a large-scale prospective studies are recommended to validate mesh and refine its applicability across diverse population. Thank you.
While it was a good paper, congratulations, you shot your time.
Thank
Now
you.
this is a competition, this is a judgment.
Yeah.
You had the good material. One question, who does the mesh score? Who is the person responsible?
Sir, the initial evaluator, sir, who
Is it a
comes to
doctor, the paramedic, or the
if
head
the-
of the trauma team?
if the patient comes to a trauma center, sir, the head of the trauma team, sir. If it is on the site, like then the paramedical team can also.
It is a vital decision. It's only by the trauma team chief. Okay.
Okay.
Thank you.
What's your opinion about high volume center and low volume center in reconstruction of these limbs?
Sir,
You have to answer because that's where the marks are there.
Yes, sir. This is one aspect where skilled and experienced surgeons are required, sir. It requires a lot of meticulous anastomosis and all you have to take decisions.
Any questions? Any others? One or two?
Is there any, because it's a retrospective study, whether you got any chance to put it in a prospective, personally you witnessed few cases?
No, sir. Yes. Thank you, sir.
Thank you, judges. Up next, we have Dr. Akshata Thakre. Judges, please note UID is TPP4. Dr. Akshata Thakre, TPP4. The next presenter would be Dr. Ramaprashant, MP. Kindly be ready with your presentation.
Good morning, everyone. Today my topic for my paper presentation is traumatic foot reconstruction with microvascular free tissue transplant, and my guide is Dinesh Kadam sir, who is head in plastic surgery. Traumatic foot injuries, especially those caused by high velocity road traffic accidents, often involve severe damage to both the dorsal and the plantar aspects, which are the weight bearing aspects of the foot. Such injuries frequently result in complex soft tissue loss, skeletal exposure, tendon and neurovascular damage, and along with that contamination. Goals of foot reconstruction are not only to preserve the limb, but also to be able to restore the function and provide durable and aesthetically acceptable coverage. Due to the paucity of the local soft tissue and the functional demands of the foot, microvascular free tissue transfer has emerged as a cornerstone in limb salvage protocols. This paper presents our institutional experience with various free and regional flap techniques and highlights their indication, functional outcomes, and utility in the staged reconstruction of traumatic foot injuries. Materials and methods. This is a retrospective review of traumatic reconstruction cases performed at the Department of Plastic and Reconstructive Surgery at AJ Hospital, Mangalore. Sample size is total of 120 patients with severe traumatic foot injuries requiring major reconstruction were included, ranging from 18 to 60 years. Mechanism of injury was 85% were road traffic accidents, 10% were industrial accidents, 5% were crushed injuries by heavy machinery. All patients underwent a multi-stage reconstruction protocol which involved initial management, including the aggressive debridement of the devitalized tissue, stabilization of the fractures, soft tissue reconstruction using various flaps, and secondary procedures including the skin grafting and the tendon or nerve repair. Based on the location, extent, and the depth of the defect, following microvascular free flaps were used. Most effective flaps which was used were the anterolateral thigh flap, It is versatile and long vascular pedicle used for dorsum of the foot and composite defects. Gracilis muscle flap was used for giving contour to the part which required the flap. Fibula osteocutaneous flap was used where skeletal loss was noted. And latissimus dorsi flap was used for extensive plantar and posterior foot defects. This is the use of gracilis graft in case of heel injury. In this you can see that because we are using the gracilis graft, the contour of the heel is maintained. This is the skeletal loss in which we are using the fibula graft. This is the anterolateral flap. In the first case, you can see there is extensive traumatic damage to the foot, and just by using the ALT flap, we are able to maintain the aesthetic and in this case, we are not salvaging the limb. Immediate amputation is not done. In place of that, we are using a flap to save the limb. This is the Hansen's ulcer. Reconstruction is done using the radial artery flap. Post-operative recovery. Most patients underwent 2 to 4 stage procedure. First was the flap, and the flap success rate was 95%. In 5% cases, partial flap necrosis was noted. Average time to weight-bearing ambulation was 3 to 6 months. Use of customized orthotics in plantar reconstruction cases were done. Functional mobility and gait training started in the 3rd month post-op. Follow-up period ranged from 6 months to 2 years. 85% of the patients returned to independent ambulation, and 10 patients required minor secondary procedure like flap thinning or contouring. Microvascular reconstruction has evolved as a management of traumatic foot injury. The foot presents unique challenges due to the limited soft tissue padding, functional requirement for the weight bearing, high risk of infection due to proximity to the ground, and the free tissue transfer provides us with adequate bulk for the coverage, vascularized bone for skeletal defects, functional restoration when combined with tendon and nerve repair. Among the flaps, the anterolateral flap stood out for its adaptability and length of the pedicle. The fibula flap was used in reconstructing long segment skeletal loss, whereas the gracilis and the latissimus dorsi flap was very useful in maintaining the contour of the graft. Microvascular free tissue transfer is the gold standard for complex traumatic foot injuries as it allows durable and vascularized coverage and early rehabilitation, limb salvage in scenarios where amputation would otherwise be necessary. With appropriate surgical planning and multidisciplinary collaboration, functional and aesthetic outcomes are significantly improved, making microsurgery an essential pillar in modern foot trauma reconstruction. In this case, by doing microvascular foot reconstruction, we are avoiding amputation. And it is very important for any patient to be able to save his limb. So with the help of microvascular foot reconstruction, we are avoiding many amputations which would have otherwise happened.
Thank you, doctor. 2 little points. One is the screen in front of you is here. Face us and speak. Don't show us your back. Yes. We're judging you, okay? We like you got a good smile. We would have loved to see it. Secondly, compliments to your plastic surgeon. He has done an excellent job. So a lot of credit goes there. Please follow up these cases.
Thank you.
Did you have any incidences of flap necrosis whenever you have taken a free flap?
They're not always, because in our institution we are doing a thorough post-op monitoring of the flaps. So in case if there are any cases where we suspect the flap might go for necrosis, we take immediate precautions for that. So not many flap necrosis cases have been noted.
I just wanted to know if there were any necrosis.
5% we noted that there was necrosis, but 95% were proper.
And how did you check for the flap viability?
We check for flap viability by pin prick test. Like when post-op day 1, post-op day 2, post-op day 3, by using a pin, if there are pinpoint hemorrhages, that means the flap is okay. And the color of the flap and the temperature of the flap.
Thank you.
What do you think the nature of your study is?
Nature of my study is just
What is it called as?
Retrospective studies.
Is it have you written there? Is it
Yes,
retrospective,
yes.
prospective?
Retrospective, sir.
No. Then what else?
Retrospective observational studies.
Observational. Did you compare with
We are
any
not
other method?
comparing, sir.
Okay, thank you.
Thank you, sir.
Thank you, judges. Up next, we have Dr. Ram Prashant MP. Judges, please note, UID is TPP2. Dr. Ram Prashant MP, TPP2. The next presenter would be Dr. Tripti.
My name is Ram Prashant and I'll be presenting the paper titled Fish hook injuries and their management. Though the fish hook injuries are uncommon at our place of study where it was conducted, fish hook injuries tend to occur as a part of recreational activity or some form of curiosity. Most of the modern fish hooks are barbed and they have a backward protruding spike and which are used to capture the fish and anchor them. But when the same concept is applied to the to accidental trauma to our hands or to any injuries, they are difficult to separate the fish hook from the injured site. So it is imperative to know how to manage such injuries, and our study is aimed at that. Coming to the review of literature, fishing has become a popular recreational activity worldwide, and injuries due to fish hook are also on an increasing trend, largely due to the use of modern barbed fish hooks. A study was conducted by Francisco in 2010 and discussed that the fish hook injuries are sustained from casting, grasping the bait, and also during securing it. So injuries can involve vital organs, delicate structures such as eyes. And a study was conducted by M.G. Gammons and revealed that there are 4 techniques that can be used to remove those fish hooks, and the choice of the method is dependent on the type of hook, location, and depth of tissue penetration. Our aims and objectives of the study include that to know the sex preponderance of the fish hook injuries, the most common site of fish hook injuries, and the most common technique employed for removing fish hooks. It was a brief prospective analytical type of study design from a period of 2017 to 2025. Over these years, an inclusion criteria was an intact fish hook injuries and patients above 15 years. This means that even if patients who came with fish hook injuries but they had removed or they themselves had removed the fish hook were excluded. And other than that, immunocompromised and pregnant females were also excluded from the study. Coming to the results, about 51 patients were included in the study over the 9 years, and they were followed up till 6 months, and all 51 of those fish hook injuries were men, which gives us 100% sex preponderance, and the most common site were hands, followed by forearm and scalp. In about 46 of the 51 cases, the string method was used to retrieve the fish hook from the site of injury, and in only 5 of them, advance and cut method was used. Coming to the discussion, the fish hooks are typically stainless steel and are divided into simple and barbed. Barbed are most commonly used owing to the modernizing the fish hooks. The parts of fish hook include the eye, followed by the shank, the bend, the barb, and the point. The gap determines the size of the fish hook, is usually 2 times the gap plus the diameter of the fish hook. And the management of this fish hooks typically involves 4 methods. Coming to the advance and cut, it is the most versatile method that has been used to remove fish hook, where we advance the fish hook through the same site of injury, and it comes out to the other surface of the skin, and we cut this part. The most important thing is that we should make sure that we have protective eyewear, because the stainless steel fragments might injure the operating surgeon. Coming to the string yank method is also a method that is used to remove fissures which are usually superficial and barbless. In this way, even if there's a few barbed fissures can also be managed by this method, provided that they are superficial. This method involves first disengaging the barb by giving a downwards pressure, followed by a string pull loop around the fissure and pulling it parallel to the shank of the fissure. Simple retrograde method is also very similar to string yank, where it is only employed in barbless fissures, and it is very similar to string yank, where we give a direct pull from the parallel to the shank. Needle cover is usually done in barbed fissures and in a bit of superficial injuries, where a 18 gauge or a 16 gauge needle is inserted along the shank of the fissure and used to cover the barb, and both the fissure and the barb are removed. In our method, the string yank method was the most commonly used method because most of the injuries were superficial, in contrast to the advance and cut method, which is most commonly used worldwide. And the advanced and cut method was only done in five patients. So concluding my topic, it says that not always the most versatile method is the method to be used, and the fissures should be first assessed, knowing what type of fissure and what type of injury and how deep the penetration to the tissues are. And most of the time, the patients usually come with a photograph of the fissure or even another identical fissure, because usually they are bought in sets. So this helps us localize the type of fissure and type of technique that has to be employed to remove it. Yeah, thank you.
Thank you. This is why I love to come to conferences, because I learn so much. This is an absolutely educative paper for me. Thank you very much.
Thanks.
2 questions. How many X-rays do you take, and how many planes of X-ray do you take?
Sir,
is it one view or is it multiple
multiple views, sir. We usually first we take anteroposterior based on the site. Usually, if it is hand, we will try to take an oblique also. And in case of others like lower limb, we might go for epilateral X-rays.
Is there any special treatment for people who come with having removed the hook and only a wound over there?
We have excluded, but per se we still give the same treatment as we give we give antibiotics and TT injection, and we try to assess if there is any functional neurological deficits, whether it has injured a nerve or any other like pulse. We check for if any underlying structures are injured, sir.
Thank you.
Very interesting topic, definitely.
Yes,
one
sir.
question to you is how many had infection related to the hook? Any?
We didn't have any infection, sir.
You did not have any infection. What antibiotic we use?
We started with amoxiclav only. Amoxiclav, and in certain cases of deep injuries, we also gave metronidazole 400 mg.
Nobody had infections?
No, sir.
What made you to choose this topic? Because it's just like any other foreign body, no?
Yes, sir. But trauma due to fissures, though uncommon in our place, they because of people don't know how to handle fissures, that any people who are trying to attempt to catch fish tend to have fissures, sir, fissure injuries. And since it is very rare and even rarer in our place of study, it is we thought it was crucial to know how to manage such injuries, sir.
Because of this shape of the hook.
Sir.
I have not seen any fish hook.
No, it is the difficulty to remove a retrograde barb.
Yes, sir.
Because you cause damage when you come out,
yes,
even especially in the yank method. So your wound of exit will sometimes be bigger than the wound of entry.
Yes. Would an MRI help to decide what are the tissues it is going to?
No, sir. No, ma'am. Because MRI is contraindicated. Even though it's stainless steel, non-magnetic, we tend not to do MRI. Only go for X-rays, ma'am. Thank you.
Thank you, judges. Up next, we have Dr. Tripti SM. Judges, please note UID is TPP3. Dr. Tripti SM, TPP3. The next presenter would be Dr. Sanjana B. Lokesha. Kindly be ready with your presentation.
Good afternoon all. I am Dr. Tripti. I am from Bangalore Medical College and I'll be presenting a comparative study to evaluate the clinical outcome of conventional thoracostomy tube insertion versus thoracostomy tube insertion followed by thoracic irrigation among the patients with traumatic hemothorax in reduction of retained hemothorax under the guidance of Dr. Srinivasa. Now, as we all know that traumatic hemothorax is a challenge in emergency care which impairs the lung function due to the accumulation of the blood. Standard chest tube insertion can be insufficient, which leads to complications such as retained hemothorax. This study compares conventional tube insertion with thoracic irrigation as an adjunct that flushes the clotted blood to assess its efficacy in reducing retained hemothorax and improving patient's outcome. The objective of study are to compare the outcome of thoracic irrigation for traumatic hemothorax following intercostal drainage tube, and to compare the reduction in the secondary interventions such as reinsertion of the intercostal tube, image-guided aspirations, or any surgical procedures such as VATS. This was in prospective parallel arm randomized control trial which was studied in general surgery units of Bangalore Medical College affiliated to the tertiary hospital after getting a clearance from ethical committee from 2024 March to 2025 March. Now the study participants were categorized into group A where the patients underwent the standard thoracostomy tube insertion, and to category B where the similar procedure was carried on followed by irrigation of the thoracic cavity with 1 liter of warm saline, and then it was suctioned out. Now the study parameters were studied under 2 outcomes. Primary outcome being retained hemothorax, which is defined as a pleural blood of more than 1/3 of the hemithorax or the clotted volume of more than or equal to 500 ml persisting more than 72 hours post thoracostomy tube insertion. Now the secondary outcomes which were studied are requirement of secondary interventions such as the reinsertion for the thoracostomy tube, image-guided aspiration, VATS procedure, duration of the chest tube, length of the hospital stay, ventilatory-free days, incidence of pleural infections such as empyema, procedure-related adverse effect. Now this procedure included all the sterile precautions and the tube insertion in the 5th intercostal space in mid-axillary line. The sizes of the tube varied from 28 to 32 French. And in group B, following the insertion of the thoracostomy tube, it was instilled with a sterile saline and was allowed to dwell for 30 seconds and then evacuated using wall mount suction. Now the participant of this study included 88 trauma patients who were equally divided amongst 2 groups, Group A and Group B, equally carrying 44 patients each. Inclusion criteria, participants were more than 18 years of age, blunt or penetrating trauma, which were confirmed to have a hemo or pneumothorax, which was diagnosed in the initial chest X-ray, and the presentation within 24 hours of trauma, indication for the primary tube insertion as well as a written informed consent from the patient side. Exclusion criteria, hemodynamic instability, which required immediate thoracotomy or massive transfusion, ipsilateral thoracotomy within 30 days, need for tube removal because of things like air leak, or death within 30 days from non-thoracic causes, pleural effusion from non-traumatic etiologies, then known coagulopathies where there is increased INR or decreased platelet count. Now the results of these studies are depicted in the pictorial manner using a bar chart. Over the course of this study, the different mechanism of injuries, injury severity score, there's a time lapse between the injury and the chest trauma as demonstrated here, which were consistent across each group. Now, the initial hemothorax value between across the group A and group B was noticed to be 550 to 560 ml each. And the different sizes of the tube inserted were also consistent across each group. Now, immediate post-procedural chest X-ray showed a finding of higher percentage of inadequate drainage in group A and higher percentage of retained hemothorax in group A. Secondary intervention rates were increased in group A. Duration of chest tube placement were increased, higher rates were observed in group A, and length of hospital stay were observed in a longer duration of hospital stay was observed in group A. And complication rates such as infection and other empyema were also observed as in higher rates in group A. The post-procedural VAS score, oxygen requirement beyond 72 hours, and ICU admission were relatively lower in group B compared to group A. And similarly, the duration of ICU stay, readmission rates, and mortality rates were also lower percentage in group B compared to group A. Now, coming to the discussion, this study rigorously evaluated immediate thoracic cavity irrigation after thoracostomy tube for traumatic hemothorax, demonstrating a significant clinical and resource benefits. Findings include a threefold reduction in retained hemothorax, a 78% reduction in secondary interventions, and shortened chest tube dwell time and hospital stay, alongside reduction in infection rates. These benefits were consistent across diverse injuries, severities, and despite common delays with no increase in pain or bleeding. Mechanistically, irrigation dislodges the clots and dilutes the blood, which optimizes the drainage. This provides a strong evidence for integrating thoracic irrigation as a standard adjunct in chest trauma management, improving outcomes and healthcare system efficiencies. To conclude, this is a simple, safe, and cost-effective technique which can be applicable across various patient presentation and practice settings, and should be integrated into the standard trauma protocol. Its widespread adoption promises to improve individual patient recovery to alleviate the systemic burdens on the healthcare resource globally. The limitation of the studies were, it was a single-centered study which limits the generalizability, and there was no blinding carried, and the patient scope, we didn't include the pediatric patient, pregnant patient, and complex patient. There was a short duration for follow-up, where we couldn't assess the long-term complications such as fibrothorax or chronic pain, and limited economics, which lacks a formal cost-effective model, as well as it's an operator dependent, which outcomes may vary with each less experienced staff. These were my references. Thank you.
A nice paper, doctor, well presented, appreciate it. Only question is, who put the first chest tube? Who was the person? Is it the consultant or the residents?
So, as in our college basis, we are
the residents are putting it. And so you are doing your first irrigation.
Yes, sir.
Okay. And what's the wall suction that you use? What's the suction level? Minus how much? What's the pressure that you use?
Pressure level is very low, sir.
It should be low.
Very
Otherwise,
low.
you'll suck the lung up and it will block the tube up. Okay. Thank you.
Sir, can I?
Please.
Just I wanted a clarification for
Yes,
the
sir.
title itself. You have mentioned thoracostomy.
Thoracostomy
Tube.
tubes.
So thoracostomy is an entity where we will have an opening in the chest wall for a chronic infectious disease of the lung.
She is correct.
Thoracostomy tube.
Yes, sir. It is the correct word. It is tube thoracostomy. That's the American terminology, sir.
Okay.
That's it's accepted.
Second, you have mentioned some mortality in both the groups.
Yes, sir.
In both the
But
groups, there are
comparatively-
patients with mortality. What was the cause for mortality only for hemothorax?
Yes, sir, I should look upon that. Based on others, like
Those who were excluded from the study, those who had associated other injuries were excluded.
Yes,
So what
sir.
was the cause for mortality in both the groups? Exclusively for hemothorax.
maybe infection rates.
No, what is the cause? Cause of mortality? That is the question asked. Your patients, no?
Yes, sir.
Yes, tell.
So it could be compression system, hemodynamic instability will be there, sir.
Any other questions?
Thank you, sir.
Thank you, judges and delegates. Up next, we have Dr. Sanjana B. Lokesha. Judges, please note, UID is TPP6. TPP6. Up next, we'll be having Dr. Sahiti Padala. Please be ready with your presentation.
Good afternoon, one and all. Today I'll be talking about my topic, clinical and biochemical predictors of surgical complications in venomous snake bites. Now, snake bites affect approximately 5.4 million people annually, with 1.8 to 2.7 million cases of envenomation. Now, in India, the estimated annual incidence of snake bites related mortality and morbidity, it ranges in 1.4 to 68 per lakh of morbidity and 1.1 to 2.4 per lakh of mortality. Now, in India, 90% of the snake bites are caused by four big snakes, that is Russell's viper, saw scale, Indian cobra, and also the common crate. Now, the envenomation of the cellulitis, the local complications, most commonly caused by Russell's and the saw scale. The local complications being bleeding, gangrene, tissue necrosis, and eventually leading to compartment syndrome. Now, my topic here will discuss about the risk factors for the complications and how we can timely intervene to prevent the complications. So, the first factor being the bite to needle time, the anti-venom snake dosage, the biochemical parameters, which is the serum creatinine, hemoglobin concentration, total counts, and neutrophil lymphocyte counts, and also the length of hospital stay. Now, my research goal is to identify the predictors of cellulitis and compartment syndrome, and to develop a predictive risk scoring system for the compartment syndrome, so that it will eventually help us to get or to intervene, the surgical interventions to be done. Methodology being the cross-sectional study, including 100 patients. Inclusion criteria having more than equal to, the age of the patients being more than equal to 18-year-old, that is adults, and having also informed consent. Exclusion criteria, excluding anyone with any comorbidities like CLD, CKD, or coagulopathies. Why? I'll be explaining in the next slides. And also misguided first aid treatments like herbal remedies and tourniquets, which will again impede my study. Now, the complications that we have faced, maximum of it being cellulitis, and then coming compartment syndrome, sepsis, and the mortality being the least. The key predictors and the definitions. Now, bite, when I said bite to needle time, I meant bite from the snake time until the anti-snake venom infusion started. And then differential limb girth, which is difference in the maximum circumference between the affected and the normal limb. The cellulitis percentage. Now, this is calculated as the surface area, that is the length of the limb that is affected, and the circumference. And the biochemical markers, as said, like hemoglobin, total count, neutrophil lymphocyte, and the PTNR and urea creatinine values. Now, the derivation formula that I have used is SPSS software, and under that, again, by the ROC curve, and also by the logistic regression analysis. These were used to get the formula that you can see here. The risk score was assessed by, this was the formula that we got in the end, that is 10.89 into the differential limb girth, plus 1 into cellulitis percentage, plus 4.5 into the percentage neutrophils, plus 7.8 into the PTINR. The area under the curve we got as 0.87 with optimal cutoff range of 469. So the risk categorization were as follows. The low risk being less than equal to 400, the treatment being clinical observation, and moderate risk is 401 to 469. Close follow-up with further investigation like Doppler and pressure measurements. High risk being more than 469, where emergency fasciotomy or any surgical interventions will be required. Now, these are the results that we have acquired, that is predictors of sepsis and cellulitis when we compared Sepsis predictors were as follows: elevated WBC counts, that is more than 11,000, neutrophils more than 70%, and serum creatinine more than 1.8. Now all these helped us predict the patient being in sepsis, whereas cellulitis predictors were PT-INR and creatinine values. Now, predictors of compartment syndrome. Now, what is compartment syndrome? It is an increased pressure in the closed osteofacial compartment, which will lead to vascular compromise and eventually tissue necrosis and gangrene. So, that differential limb girth was 2.75 centimeter or more predicted fasciotomy with 96% of sensitivity and 77 of specificity. Cellulitis percentage of the limb involved was more than 35.7% of the limb affected. And the biochemical markers was elevated neutrophil counts, prolonged PT, that is more than 13 seconds, and INR of more than 1.2. So coming to the conclusions, the key predictors were confirmed, that is elevated WBC count, the neutrophil values, serum creatinine, prolonged PT-INR, and increased differential limb girth. Predictive scoring system, that again, after the calculation, that also proved helpful and in determining the surgical intervention. But the limitations here is there were larger cohorts and repeated laboratory assessments were needed to see the progression of the patients. These are my references. Thank you.
In what way creatinine is related to your case?
So creatinine, it will again predict the sepsis. So again, when what I mean is that muscle damage occurs, which again will help, will derange the RFT values. Will help reduce the sepsis when the intervention is taken.
The cellulitis, what you mentioned, was it due to the bite itself or due to some applicant what they got? Did you have an analysis of how many had applied something and come?
No, my exclusion criteria was I was not taking in count.
You didn't take them into account. Okay.
I'm not yet sure of how your formula that you produced gives you interpretation on predicting the, you give an indication on predicting of what line of treatment to approach. But does it give you an indication of the related to the compartment syndromes and the loss of limb?
No, that we can take the PT-INR values, which will help to decide the severity of the patient. But as such, the compartment syndrome, that can be assessed clinically. But in these patients, what we try to relate is if we can get a formula or if just the biochemical or the clinical parameters can help us lead to a, not just clinically, but if the biochemical markers will help us decide if fasciotomy is needed or not. That was the main aim of this paper.
Hello. Your predictor for sepsis is creatinine. How much it is advisable to see in sepsis? That to case of snake bite. Because snake bite causes multi-organ involvement, sometimes nephrotoxic, hepatotoxic, and neurotoxic. Understand?
Yes, sir.
That depends upon what type of snake bite.
Yes, yes, sir.
So that's what creatinine, I don't think it is a marker for the sepsis predictor. There are other markers which can give a sepsis predictor.
Okay, sir. Okay.
Can I? Hello. Yeah. What is the type of snake which has bitten that particular person? Was it taken into consideration?
So we asked if, that again was leading to bias, sir, because they were not very sure. Few of them would show us a photo, but few of them would describe. But that was not taken into consideration because the description was not.
Is it important?
It is. It is.
It is important.
That is one that we consider as a limitation.
The dose of the anti-snake venom, how do you decide in different patients?
So based on the bleeding, the clotting time, and the time of presentation, and the bite to needle time, because depending on that, we can decide.
Suppose they bite and you are giving injection time is stretched, the dose differs?
No, so the dose remains the same.
So what's the dose you are prescribing?
Not exactly sure about that. I'll get back to you.
See, the patient has come now. You have to decide on the dose of the ASV, no? So what's the dose you are giving? And how you are giving?
Do you know you can evaluate the volume of venom in the circulation? Is there any test for that?
No, sir, I've not taken that into consideration.
Okay. Recently, in our institute, they have done a study estimating the venom, available venom in the circulation of a given patient.
Okay. Thank you, sir.
Thank you, dear judges and delegates. Up next, we have Dr. Sahiti Padala. Her UID is TPP7. Dr. Sahiti Padala, TPP7. Up next, we'll have Dr. Apurva Harihara, the last presenter. Please be ready with your presentation.
Good morning, sir. I'm presenting a paper on splenectomy in traumatic splenic rupture. Splenectomy in traumatic splenic rupture, a retrospective study on surgical management and patient recovery under the guidance of Rajgopal Chennai. Splenic injuries account for a significant proportion of abdominal trauma cases, with non-operative management being the standard approach for hemodynamically stable patients. However, splenectomy is indicated for patients with hemodynamic instability and failed non-operative management. This study presents a case series of 8 trauma patients who underwent open splenectomy, highlighting the indications of, for the surgery, surgical outcomes, and the post-operative management. Method, this is a retrospective case series. It was conducted at Kasturba Hospital, Manipal from time period January 2023 to March 2025. Patient inclusion criteria, the patients aged more than 18 years and who sustained traumatic splenic injury and required splenectomy. The data collection, the data was extracted from the electronic medical records and included demographics, age and sex, the mechanism of injury, whether blunt or penetrating, and injury severity. According to the CT scan, the splenic injury grade was taken, and hemodynamic status of the patient at presentation, operative details, the operative time, transfusion requirements intraoperatively, and blood loss, and post-operative complications, length of the hospital stay, and mortality. A total of 8 patients were taken with age between 23 to 60 years. All the patients in the study were males, and mechanism of injury is blunt trauma in all of the patients. Now, all 8 patients, FAST was positive in all of the 8 patients in the triage, and all 8 patients underwent contrast enhanced CT scan on admission. The CT scan showed grade 3 splenic injury in 1 patient, grade 4 splenic injury in 5 patients, and grade 5 injury in 2 patients. And active contrast extravasation on CT scan is noted in 5 patients, and moderate hemoperitoneum in 6 and mild hemoperitoneum in 2 patients. All of the patients are males aged between 23 to 60 years with a history of blunt trauma, with road traffic accident in 7 patients, and 1 patient had a history of fall from height. At the time of presentation, 7 patients were hemodynamically unstable and were started on inotropic support in the emergency and also underwent blood transfusions. All the patients had other associated injuries like liver injuries, vertebral injuries, traumatic brain injuries, renal injuries, and the total duration of hospital stay in all the patients was between 7 to 10 days, and no mortalities were reported in this study among these 8 patients, and all patients were vaccinated post-operatively at follow-up. The indication for the surgery is hemodynamic instability in 7 patients, and 1 patient, he was initially managed conservatively. Hemoglobin was monitored, but due to the drop in hemoglobin and requirement of blood transfusions, he also underwent surgery 12 hours later. And the mean operative time was 2.5 hours. It ranged between 2 hours to 3 hours. All patients required intraoperative blood transfusions, and 3 patients also required post-operative blood transfusion due to low hemoglobin. And mean blood loss was 1 liter. It ranged between 800 ml to 2 liters. The minimum was 800 ml and maximum was 2 liters among these patients. Post-operatively, one patient developed surgical site infection, and one patient had pneumonia, and one patient had to undergo reoperation. He developed adhesive intestinal obstruction later, so he was taken up for adhesiolysis 1 month later. And one patient had post-operative ileus, which was spontaneously resolved, and the hospital stay ranged from 6 to 12 days. Discussion. This study supports the role of open splenectomy in trauma patients with life-threatening hemorrhage and non-salvageable splenic injuries. While non-operative management is the standard for many stable patients, splenectomy remains the standard of care in unstable patients. And there is no mortality in this series despite high-grade splenic injuries. And intraoperatively, all patients underwent a midline incision, midline vertical incision extending from the xiphisternum to below the umbilicus. And splenic hilum was ligated, and splenectomy was done. Total splenectomy was done in all of the cases. Post-operatively, all patients had vaccination. 100%. There is a 100% vaccination rate in all of the patients. And the limitations for this study are the small sample size. It is a retrospective study, and limited long-term follow-up of these patients. Conclusion: open splenectomy remains an essential intervention in trauma surgery, and with proper perioperative care and vaccination, it offers excellent outcomes and good survival rate post-splenectomy in patients with unsalvageable splenic injuries. And these are my references.
Any patients less than 18 years in this group?
No, sir.
You excluded them.
Yes,
What would you do?
No patients were admitted below 18 years of age. We didn't get any cases, sir, in this study.
What would you do if a 15-year-old comes with a bad spleen?
Sir, we'll try conservative management, but if the patient is hemodynamically unstable, then we'll have to do splenectomy, sir, initially.
What type of splenic injuries you are thinking of managing conservatively?
Sir,
it depends upon the lesion, where it is there.
Yes,
Understand, spleen is notorious.
No, sir. If the patient is hemodynamically stable and grade 1, 2, 3 splenic injuries, if there is no drop in hemoglobins, then we can try conservative management for those patients.
That also, again, that amount of hemoperitoneum also important.
Yes.
Understand, you have to take care of. If hemoperitoneum is more than 1 liter, then you have to go for lavage.
Excuse me. With your study, do you want to promote surgery for splenic injury, or you want to have a NOM for splenic injuries after your study?
Sir, first we'll do non-operative management, but still if the patient is hemodynamically unstable, requiring if there is a drop in HB requiring multiple blood transfusions, then eventually splenectomy.
No, that is a different. That becomes a failure of NOM and then a definitive surgery. These are two different entities. So what is the promotion from your study?
That if the patients can be saved, even with high-grade injuries, patients can be saved with splenectomy.
Okay. And you have written about vaccination, post-splenectomy vaccination. Yes. All your 8 patients took vaccination, post-splenectomy?
Yes, sir. All of them took, sir.
Okay. Was it the prophylactic before taking for surgery or after surgery? If it is after surgery, after how many days?
After 2 weeks of surgery, sir. At a follow-up when the patients came back.
What vaccination was given?
So pneumococcal vaccine and Haemophilus influenza vaccine was given.
Polyvalent.
Polyvalent.
Excuse me.
See, in NOM,
do you have any international study status of the splenectomy?
No, sir.
Versus spleen preserving operations in splenic trauma?
No, did you have follow-up for these NOM cases?
Yes,
what sort of follow-up you want to know?
For non-operative management.
Follow-up, injuries, yes. Grade 2. What sort of follow-up you want to know?
Sir, at follow-up, we check the hemoglobin levels and all if there are any infections.
No, secondary infections also. That is important in that spleen. When you are treating conservative, you have to follow for the secondary.
The last point is that even if you have gone in for splenectomy, you could still conserve the spleen in what is called splenorrhaphies and spleen preserving procedures. It only depends on whether the pedicle is involved or not, splenic artery. If your pedicle is intact, you can still stave the spleen, whatever the injury you have. Wrap it up in mesh or whatever.
Okay, ma. Thank you. Thank you. Finished?
Thank you, judges. One last is there. Up next, we have Dr. Apurva Harihara. Judges, please note this is the last presentation for this session. It is UID's TPP 10. After this presentation, we'll be beginning with the inaugural ceremony exactly at 1 o'clock. Tea and coffee have been served at the ground floor. Please feel free to make your way there.
Good afternoon. I'm Dr. Apurva and I'm from KSCASI, second year general surgery postgraduate. And my guide is Dr. Vivek Nagappa, a consultant surgeon in KSCASI hospital. My topic it is a trauma paper. As we know, there's a rising number of RTAs that you see day to day. There's a lot of traumatic brain injury that we see in our casualty every day. So the topic is riding flap craniotomy, which has been an effective alternative to your generic decompressive craniectomy, which you do in a traumatic brain injury. It's not it's a prospective study that we have done in KSCASI Medical College in the casualty which has come, under which 53 traumatic brain injury patients were chosen, and out of which 50 underwent riding flap craniotomy, and 3 patients were chosen for decompressive surgery because intraoperatively the inclusion criteria we saw that there was cerebellar edema and brain parenchymal edema, because of which we had done a decompressive craniectomy. The procedure here, what we have done in the case is, after raising the skin flap and the temporal fascia on top of the bone flap has been preserved, after which carefully burr hole has been placed anteriorly in the frontal, temporoparietal and occipital region, and after which using a bone cutter or a craniotomy elevator, we join the bone burr holes, and after which using a craniotomy, the bone flap is raised up and preserved in saline till the evacuation of the hematoma is done after opening the dura. And after opening and closing the dura and using a dural graft placed on with the dural place, we have replaced the bone flap on top. And here, as you can see, 2 overriding sutures have been placed on top. The initial suture has been taken from the inferior aspect of the temporalis muscle, and the posterior sutures, which you can see, have been taken in the pericranium, so that there is an even tension that is put on the pericranial bone flap, and it also helps in even elevation if there is any post-op edema that you notice in the traumatic brain injury patients. So this is the protocol what we decided in the case. The patients were assigned with GCS of mild, moderate and severe with the GCS scores, in which our RFC flap, that is our riding flap craniotomy patients, 3 out of which were mild GCS, 24 were moderate, and severe were 23. And 3 patients intraoperatively, when we noticed that there was a visible parenchymal edema that was noticed, we had converted the case to DC, that is decompressive craniectomy. And later on, this flap replacement we had not done for the 3 patients. But in the riding flap craniectomy, the patients underwent the replacement of the bone. Here, post-operatively, immediate and 24 hours to 48 hours, we had expected the complications, that is infarct or edema noticed post-op, and hematoma expansion and brain swelling expansion, and redo surgery when there is incomplete evacuation or if there is any expansion of hematoma which is noticed in the post-op CT, and post-op EDH which is developed, for which another post-op surgery had to be done. 5 out of which we had separately classified the case of RFC into complication category and non-complication category, in which we can see that with no complications the patient had improved. 28 out of 28 patients had clearly improved, and they still needed ICU setup for the next 48 to 72 hours for monitoring, and 8 patients were observed to be stable and could be transferred out to general ward. And in the, with the complication patients which are above mentioned, in that 3 deaths were noticed and only 1 improved, with 7 were stable condition, which is shifted back to the wards. So the result overview, in which 84% of the patients that underwent the RFC, that is riding flap craniotomy, we saw favorable neurological outcomes, and patients' GCS and GCS is improved and pupillary reflex was improved. Apart from that, 16% mortalities were noted in the riding flap craniotomy. Here, which you can see with the statistical analysis, although there were 18% of complications that were seen, but these complications were actually associated with any post-traumatic cases and traumatic brain injury. And it also showed that the RFC outcomes were not due to chances, and the patient's neurological improvements were associated with the surgery and the effect of reduced cerebral pressure. Discussion of the paper. Since there is placement of the flap right on top of the brain with evenly placed suturing and overriding sutures present horizontally and vertically, there is an option for even elevation. Even if there is a post-traumatic edema present in the brain, there is even expansion for the flap, helping the brain to swell and also not give pressure onto the brain. Just like how a hinge flap, hinge craniotomy that we do, gives you a position that does not allow even the expansion of the flap. Apart from that, if there is a riding flap craniotomy done, there is no need for a secondary surgery done, a cranioplasty to place another bone flap. Also, that puts the patient in another morbidity. This also gives a better cosmetic outcome for the patient, because there is a psychological impact after decompressive craniotomy that is seen in patients. These are a few post-op x-rays. This is POD1 immediately. Here you can see in the first one, there is a frontal hematoma, SDH present, after which there is an evacuation of the FD. This is our flap that is being placed here, frontotemporal parietal flap. This is a follow-up patient which we had seen after 45 days. It was a case of cerebral hematoma with a midline shift present. This is post-op day 1 X-ray, which is after 24 hours. The hematoma is evacuated with a minimal amount of midline shift which is present. After which, this is 45 days post-op CT for follow-up. Here we can see that the hematoma is completely evacuated. The flap is still present, and it looks like it is almost near to normal parenchymal changes. Normal brain parenchymal changes have been seen. This is a 3D reconstruction, which was an expected complication of the surgery. That is, probably a displacement of the flap could be there, but it was minimal displacement noticed in all the patients that we had seen. Conclusion, RFC is a safer and an effective and cosmetologically better option in compared to decompressive craniectomy, and also allows an uniform expansion with the suture, riding flap sutures. So the patient's psychological aspect post-trauma is also taken into consideration and does not put the patient in another secondary surgery or cranioplasty where the patient has to undergo another surgery post-op after 3 to 4 months of follow-up, which is effective. But still, this requires a multicentric study. There are still limitations because the inclusion and exclusion criteria is not very clear. We choose all the traumatic brain injury patients and intraoperatively we decide if there is a massive edema, then in those conditions we have converted 3 patients to DC. So inclusion exclusion criteria has to be more clearer, as these are the limitations I found in my study. Thank you.
What was the number?
So 53 patients we have taken, sir, and in that 3 we found that intraoperative, when we opened the dura, there was massive swelling in the parenchyma. This study from 2024 September to December, it's ongoing, but the statistics which have done only till December. I am still following up with newer patients.
So what are the results?
Results are 84%
You are
neurological.
telling it's ongoing study.
No, these statistical analyses are for till December of 2024. And in that, 84% outcomes are better neurologically, and 1 month follow-up when the patient comes in the OPD.
What was your objective assessment of that?
The GCS improvements are on the, like in the casualty when we evaluate the GCS of the patient. And after 1 week and after 1 month, when we call the patient for review, we see how improvement is there, what all improvements are there, and any seizure, and if the patient's motor functions are coming back to normalcy.
Is difference between your procedure and previously what we used to do, remove craniotomy, keep the flap or the part in the anteabdomen.
Decompressive
What is there? And you are putting that suture. Majority of the time when there is a massive brain bound to get edema.
Brain edema. But then
so that flap and more so over you are putting a suture that flap should not mobilize or that's the reason. What is the exact difference between that procedure and your procedure?
When the flaps are saved, yes sir. The flaps when they are kept in the abdomen or preserved in the low temperature, we are basically waiting for the edema to subside. But that's why we need a cranioplasty after 3 months follow-up. But in riding flap craniotomy, here the suture which we put are not tightly placed, and it allows an even expansion of the bone flap.
That means you are taking care of only the bone flap care. For that you are doing this procedure. Not more than that, you are not having any advantage over the previous procedure and your procedure.
Cosmetically also.
Okay, thank you. Thank you very much. Yeah.
Thank you, dear judges. With this, we conclude the session 1 of trauma paper presentation. We'll be beginning with the inaugural function in another 10 minutes.
Hello.
May I draw your attention, please? Please maintain some silence. Just for 2 minutes, there's a presentation by Team Raichur. We will be having the state conference next February. So I request Dr. Mandolkar and your team, please present the your Raichur presentations.
Hello. Hello.
Sutta.
Sir, now the poster presentation. Award. Award will be given not now. At the for a particular sir, from our end, we are providing a certificate.
afternoon, everybody. I am Dr. S.D. Mandolkar, Professor and HOD, Department of General Surgery from the Raichur Institute of Medical Sciences, Raichur. It's pleasure to tell you all that I am being the organizing chairman for the KSCASI-midCON 2026, which will be conducted in RIMS, Raichur. I wholeheartedly invite each and everyone to come to Raichur, involve in our feast of scientific, academic, as well as cultural imbibement, and make it an enriched experience in Raichur, which definitely will be different from what you have now, till now, in your experiences. It will add to you a new kind of dimensions of thinking, advancing, as well as an conceptual a combination of concept as well as conscience. I assure you that you will have a different kind of a feast, and as you know, the Raichur is rich in his paddy, cotton, and gold. So there is a Hatti gold mines for your visit, and you can have an experience of virtually seeing the gold by your eyes, and a wonderful a valley of Silver Valley is called as, where it enriched cotton is been imported and exported, and what you all are wearing with, it is, Raichur is also involved in your costumes, as well as Raichur is one of the important exporter of rich paddy, where you get a high quality of these things, and one more important spiritual place near in Raichur, that's Mantralaya. And Raichur is also famous for its power supply in all majority of the Karnataka, with this Shakti Nagar is called as, where the thermal power plant supplies its power to Karnataka. So you will have that personal experience of visiting the thermal power plant also. So energy as well as ornaments, recreating original sites are there in your Raichur, and city itself is a growing city. You feel it's like any other advancing cities in the state, and it is well connected with airport. That is nearest is Hyderabad. It's just a 2.5 hours travel. Richly connected with a train. All trains which are going to south, they move to from the Raichur only, and well connected with the bus and transportation. I hope that nobody will have any kind of inconveniences coming to the Raichur city. And Raichur RIMS being a government institute, you will have that a pleasure of how a government institution is growing on its own and advancing in all the fields, and most importantly is you will enjoy the rich, delicious food which is famous for Hyderabad biryani from Hyderabad. Everybody is familiar with. You will enjoy that also in Raichur. And I expect all my colleagues in all the districts will extend their support and cooperation in increasing the number of registrations for the KSCASI-midCON. Okay, thank you, Ansar.
I quote Sir William Mayo, "Surgery is the supreme test of a physician's skill and the ultimate expression of his or her knowledge." Our dear experts, a very good afternoon to one and all present here.
Today is not just a day, it is an occasion of pride, a celebration of surgical intellect, and a symphony of minds coming together for a common purpose, to learn, to share, and to inspire.
On behalf of the Association of Surgeons of India, South Canara City Branch, and the organizing committee of KSCASI-midCON 2025, we extend a heartfelt welcome to each one of you as we embark on to the inaugural ceremony of this 2-day illuminating academic journey amidst the vibrant campus of Kanachur Institute of Medical Sciences, Mangalore.
Light symbolizes knowledge, and knowledge, when blended with humility, becomes wisdom. As we inaugurate this academic congregation, it is only apt that we begin with seeking the blessings of the Almighty.
To render the soulful recitation, I now invite Master Abdul Salam, a student of 3rd year MBBS, to kindly come forward and grace us with the verses from the Holy Quran.
Assalamu alaikum wa rahmatullahi wa barakatuh, which means, may the peace, mercy, and blessings of God be upon you. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم أمن هو قانت آناء الليل ساجدا وقائما يحذر الآخرة ويرجو رحمة ربه قل هل يستوي الذين يعلمون والذين لا يعلمون إنما يتذكر أولو الألباب قل يا عبادي الذين آمنوا اتقوا ربكم للذين أحسنوا في هذه الدنيا حسنة وأرض الله واسعة إنما يوفى الصابرون أجرهم بغير حساب. In the name of Allah, the most gracious, the most merciful, is the one who worships devotedly during the hour of the night, prostrating himself or standing in adoration, who takes heed of the hereafter, and who places his hope in the mercy of his Lord, like the one who does not. Say, are those equal, those who know and those who do not know? It is those who are endued with understanding that receive admonition. Say, O my servants who believe, fear your Lord. Good is the reward for those who do good in this world. Spacious is Allah's earth. Those who patiently persevere will truly receive a reward without measure. Assalamu alaikum.
I request Dr. Sarvesha to kindly present a medallion to our chairman, Dr. Rajagopal Shenoy, Karnataka Associations of Surgeons of India, Karnataka State Chapter.
It is now my privilege to invite on stage Dr. P. Satyamurthy Aital, Vivacious President of the ASI South Canara City Branch, a visionary leader whose dedication towards academic excellence and surgical education has been truly exemplary. Sir, may I kindly request you to grace us with the welcome address and set the perfect prelude for this conference.
Good afternoon to everyone. ಎಲ್ಲರಿಗೂ ಶುಭ ಮಧ್ಯಾಹ್ನ. ಸರ್ವಶಕ್ತ ಭಗವಂತನನ್ನು ಮನಸ್ಸಿನಲ್ಲಿ ಧ್ಯಾನಿಸಿಕೊಳ್ತಾ ತಾಯಿ ಭಾರತಾಂಬೆ ಹಾಗೂ ಜನನಿ ಕರ್ನಾಟಕ ಮಾತೆಯವರನ್ನು ಅವರ ಪಾದಾರವಿಂದಗಳಿಗೆ ವಂದಿಸಿಕೊಳ್ಳುತ್ತಾ, dignitaries on the dais, the chairman of ASI state chapter and also today's president, today's functions president, Dr. Rajgopal Shanai sir, chief guest of the day, Dr. Niranjan Kumar, Honorable Vice Chancellor of STM University Thyroid, and guest of honor, chief of chairman of Kanachur Group of Institutions, our beloved Haji UK Monu sir, Dr. Haji UK Monu sir, and other dignitaries on the dais. Dignitaries of the dais, our organizing committee members are there here, and our respected members of ASI from different parts of Karnataka, and also the professors, teachers and PG students from various colleges in Karnataka, invited guests, our sponsors, students, volunteers, and ladies and gentlemen. I wish you season's greetings, a happy season's greetings to all of you, because you know yesterday we celebrated our Varamahalakshmi Vrata, and today is supposed to be the Raksha Bandhan, an auspicious day with a lot of sentimental value. And in fact, it is a memorable day for us. When he took over the charge of ASI South Canara branch in the last November, we dreamt of conducting MidCon here in Mangalore at our college premises, and we conveyed our desire to the management. And when they hear about that, they readily agreed to support us. And because of their unending support and support by the office bearers of the state chapter, president, secretary, treasurers and everyone, and because of the overwhelming support by you, my dear ASI members, by enrolling yourselves, getting registered yourself as delegates, and making this function a grand success because of your involvement. And I am very happy to say that our registration has crossed more than 600. So I'm very much delighted to see you all here. And now finally we have reached the moment for inauguration is arrived. On the dais, we have Dr. Rajgopal Shanai, Chairman of ASI South Canara, state chapter, and the President of today's function. And he's a disciplined and intelligent, at the same time very friendly personality. And right from the day he came to know that we are going to have the event here, MidCon here at Kanachur, after that, every other day he used to call our secretary, Likit Rai, and giving guidance and the directions how this has to be, and getting updates every day. So we are very proud to have you here, sir, as our president. As a Now I invite or I welcome Dr. Rajgopal Shanai with a warm welcome, sir. Coming to the chief guest of the day, Dr. Niranjan Kumar, Honorable Vice Chancellor of esteemed Thyroid University, and he is also very knowledgeable and soft spoken always, and very good person, nice personality, because I know him as he is my senior, 3-4 years senior to me in KMC Mangalore. So when we asked him or requested him to be the chief guest, he happily agreed, and that is how he is here with us. So on behalf of myself and all of you, I welcome you with a special welcome, sir. Another prominent dignitaries on the dais, Indina Gaurava Atiti, guest of honor. ನಮ್ಮ ಸಂಸ್ಥೆಯ ಮುಖ್ಯಸ್ಥರಾದ ಡಾಕ್ಟರ್ UK ಹಾಜಿ ಮೋನೋ ಅವರು ನಮ್ಮೊಂದಿಗೆ ಇದ್ದಾರೆ, ಸಭೆಯನ್ನು ಅಲಂಕರಿಸಿದ್ದಾರೆ. ನಾವು ಅವರ ಬಗ್ಗೆ ಹೇಳುವುದಾದರೆ ಸರಳ ಸಜ್ಜನ ವ್ಯಕ್ತಿ, ಆದರೆ ಅವರು ಬರೀ ವ್ಯಕ್ತಿ ಅಲ್ಲ, ಅವರು ಒಂದು ಶಕ್ತಿ. ನಮ್ಮ ಈ ಹಿಂದಿನ ಕಾನ್ಫರೆನ್ಸ್ ಹಿಂದಿನ ಆಧಾರ ಶಕ್ತಿ. ಆ್ಯಂಡ್ he is a multifaceted personality because he has earned name and fame and also respect in various fields like education, social service, business, and of course in politics. So, recognizing his service and the dedication in the field of social service and education, our Mangalore University has granted him, awarded him doctorate degree. So he is a Dr. Haji Mono now. ನಮ್ಮ ಈ ಈವೆಂಟಿನ ಬಗ್ಗೆ ಅವರಲ್ಲಿ ಕೇಳಿಕೊಂಡಾಕ್ಷಣ ಬಹಳ ಸಂತೋಷದಿಂದ ಒಪ್ಪಿಕೊಂಡದ್ದು ಮಾತ್ರ ಅಲ್ಲ, ಇಂದು ನಮ್ಮೊಂದಿಗೆ ಗೌರವ ಅತಿಥಿಯಾಗಿ ಉಪಸ್ಥಿತಿದ್ದಾರೆ. ಅವರನ್ನು ನಾನು ನಿಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ತುಂಬು ಹೃದಯದಿಂದ ಸ್ವಾಗತಿಸ್ತಾ ಇದ್ದೇನೆ. Another prominent dignitary is with us is our dynamic director, Abdul Rahman. He is a person who is known for dedication, is meticulous and perfectionist. And to tell you, in fact, he is the person who has looked into all the aspects of the arrangements of today's program. And because of him, that we could see this, he is the one person who brought grandeur to this event. So, sir, I would extend you a welcome with the love and respect. Another dignitary on the dais is our chairman-elect, Madam Naz Jan Sheikh, chairman-elect for the next year, the chairman-elect. So she has come all the way from Hosapete, and she is the first lady to become ASI chairman from a non-medical college area. Because I got the information by Rajgopal Shana yesterday. So, madam, I welcome you, madam. Then, we have with us Dr. Sarvesha Raja Aras, Honorable Secretary. And we have Basamana, Guru Basavana Gowda, Treasurer. Because these are the two persons who actually gave shape to our brochure, fixing up the topics to be covered, and who is to speak the topic, and who are the panelists. So he has given a nice shape to our brochure, and he has worked hard to collect all the data from our speakers and chairpersons. So I welcome you, sir, to this august gathering. We have our respected Guru Basana included. Yeah, so. Guru Bas, yes, I welcome you, sir, Guru Basana Gowda. Thank you, sir. Now we have our respected Dean, Shanawaz Painapadi. So he is also very much has given his service to the this program by giving us timely suggestions and directions. Sir, on behalf of everyone here, I extend you a hearty welcome, sir. Then we have with us Dr. Likith Ray. Though he is one of the hosts, in fact, but he has done the great job. He is the one who coordinated with the management, with the state office bearers, and with so many other speakers and college ASI members. And also he has coordinated with our students, especially all the interns, and our students are there who have worked day and night to bring a shape to this event. And in fact, of late 1 month, Dr. Likith Ray, I think whether he had a good sleep or not, I don't know. So every time he was talking about the conference. So though a host, as a formality, I welcome you, Dr. Likith. Then we have with us Dr. Muhammad Ismail Hajamadi. He's very particular to mention about Hajamadi. So Dr. Muhammad Ismail Hajamadi, Chairman Kalachur Health Sciences. I welcome Dr. Venkatray Prabhu, Member Kanachur Health Sciences, and must be knowing he is a former Dean of KMC and as well Pro-Chancellor of Mahia University. And also I welcome, in the absence, Anjan, our medical superintendent, and Rohan Muniz, who is the Chief Administrative Medical Officer. In their absence, I welcome them to this event. And also I welcome all our Dr. Vinay Alwa, our organizing treasurer, and Dr. Kibran Kumar, our organizing assistant secretary, joint secretary, and Dr. Gopinath. Dr. Gopinath, you are here. Gopinath, next, he is hosting next MidCon. So he is our joint organizing secretary. Okay, all right. And then coming to the audience, I could recognize the presence of Dr. Vijay Kumar, Professor Vijay Kumar, Vice Chancellor, Nitya University. I think he was here, he just, went outside. Also, I recognize our Dean from AJ Medical College, Dr. Ashok Hegde, and almost all the prominent District Surgeon Shiva Prasad, and professors and teaching staff from various different medical colleges of the Karnataka state, and also ASI members from various parts of, who have come from various parts of Karnataka state. So because of your all this support, I think we could put this show in this great, good manner. And I also welcome each one of you, like our sponsors may be there, invited guests may be there, and our students and volunteers, and everyone. If I have left anybody, please pardon me. I welcome every one of you to this function. And with this, I have not included the media persons, photographers, everyone is, I welcome everyone to this event. And with this, I conclude my welcome speech. Jai Hind, Jai Karnataka, long live ASI and Kanachur Institute.
Thank you so much, sir, for that warm and gracious welcome. Your words have beautifully set the tone for what promises to be an enriching academic journey over these 2 days. I now request our volunteer to welcome Dr. Satyamurthy Aital, sir, Organizing Chairman and President of South Canara City Branch ASI.
Light is a symbol of knowledge, purity, and auspicious beginnings. To invoke the divine blessings and to illuminate the path of knowledge, we now proceed to the lighting of the lamp. May I request all the dignitaries on the stage to kindly do the honors.
Thank you, dear dignitaries. It is now my privilege to welcome a distinguished leader in the field of medical education. May I kindly invite to the dais Mr. Abdul Rahman, respected director of Kanachur Institute of Medical Sciences. Sir, we request you to grace us with your address to this august gathering.
Good morning. Assalamu alaikum and namaskara. Our virtuous chief guest, the leadership team of ASI, both state and district, distinguished luminaries on the dais, our remarkable guests and fellow healthcare professionals. Welcome to Kanachur Institute of Medical Sciences. And I must say, we are glad to host Karnataka State's 8th mid-year conference by ASI. It is indeed an honor to address an intellectual audience today, and I have been briefed by Dr. Rohan Monis and also by our Dr. Likit Rai, that this conference has broken few records in terms of attendance and paper presentation entries. Just a remarkable and historic milestone indeed. Congratulations to all the teams. I take this time to recognize our chief guests, Professor Dr. Niranjan Kumar Sir, Honorable Vice Chancellor of SDM University, Dharwad, and Dr. Rajgopal Shenoy, Chairman ASI Karnataka. I am sure these surgeons are illustrious teachers with core values that have been admired and want to be mirrored and have left a notable mark in the lives of the people they have met along the way, both patients and students. But it all started with a dream, a thought, and their hard work with consistency helped their surgical prowess and community grow. Let's applaud their achievements and vigor. On this platform, I would like to share and reflect on the remarkable growth of our institution and the transformative journey we have undertaken together. My father, the founder chairman of Kanachur Educational Institutions, Dr. Haji UK Mono's dream was to create doctors as stewards of health and champions for the community, with shared commitments to improving lives, especially in the regions we live in. A point to note is that giving back was his priority. And so we launched Kanachur Hospital in 2014 and got the permission from the erstwhile MCI in 2016 to establish a medical college. And then we never looked back. Working through the challenges and formations with our core teams. Yes, we are the youngest medical college in the district. I must admit to our learned audience, we are one of the only few education institutions in the Bharat that has KG to PG in one unitary campus. Over the past decade, our medical institutions, that is medical, nursing, physiotherapy, allied health sciences, pharmacy, and now Ayurveda, have evolved from regional care providers to a state-recognized center of excellence. We have expanded our infrastructure with the state-of-the-art facilities that now include advanced diagnostic centers, specialized surgical units, and cutting-edge interventional labs, especially with our team of skilled doctors. This has enabled us to serve a broader and more diverse patient population. These physical expansions are not merely bricks and mortar. They represent our unwavering dedication to accessibility and quality care. For all these achievements are a testament to our ability to adapt and innovate in the rapidly changing healthcare landscape. The growth of our institutions is not solely measured by the numbers or technology, but by the brilliance and dedication of our workforce, the extended Kanachur family. Our teams have been strategically expanded and soon will begin with specialized training programs in the field like oncology, cardiology, neurology, and more. We always empower our staff to deliver care that meets global standards. Moreover, our commitment to diversity and inclusion has enriched our institution by fostering a culture, building teams that reflect the communities we serve, and enhancing patient trust and satisfaction has impacted our patient-centered care model, thus improving walk-ins and patient satisfaction scores over the past 5 years. Growth, however, has not come without challenges. The rising demand for healthcare services, coupled with resource constraints, has tested our resilience. The COVID-19 pandemic was a defining moment for our institution. We were the first in the regions to start private COVID vaccination program. It challenged us to rethink care delivery, accelerate innovation, and prioritize patient and staff safety. Our rapid deployment of mobile vaccination units and drives not only saved countless lives, but also positioned us as the leaders in the public health response. These experiences have strengthened our resolve to prepare for future challenges, including emerging diseases and the impacts of climate change on health. As we stand on this foundation of growth, our vision for the future is bold yet achievable. We aim to establish centers of excellence, grow into the university status. We are committed to expanding our community outreach programs, targeting undeserved and the disadvantaged populations to address health disparities. Additionally, our sustainability initiatives will reduce our carbon footprint by 20% by 2030, ensuring that our growth aligns with environmental responsibility too. To our medical audience, I extend a call to action. Let us continue to push the boundaries of what is possible. Let us collaborate across disciplines. It is the time for collaboration and interdependence, and advocate for policies that strengthen healthcare systems. But in the process, let us not forget that we are treating our own species, yes, the humankind. So grow your core values of connection, engagement, creating trust, integrity, and making an impact. Together, we can build institutions that not only heal, but also inspire hope and trust in every patient we serve with empathy. Do have a great time of learning and networking. Together, we will shape a future where healthcare knows no limits. Thank you. Jai Hind.
Thank you, sir, for your kind words. We are immensely honored to have with us today Dr. Professor Niranjan Kumar, Honorable Vice Chancellor, SDM University, Dharwad, as the chief guest for this conference. A man of wisdom, stature, and simplicity, Dr. Kumar needs no introduction in academic and surgical circles. When we humbly approached him with our invitation, his response was nothing short of enthusiastic. With a warm smile, he said, "It'll be my pleasure to be a part of it." I now request Dr. Likith Rai to kindly escort Dr. Niranjan ahead on the dais. I now request Dr. Vinay Alva, the organizing treasurer, to enlighten us on the remarkable journey of Dr. Niranjan Kumar.
Respected dignitaries honored of the dais. Good afternoon, ladies and gentlemen. It's my honor and privilege to introduce the chief guest of KSCASI-midCON 2025, a stalwart in Indian surgery and medical education, Dr. Niranjan Kumar, Vice Chancellor of Sri Dharmasthala Manjunatheshwar University and Medical Director of SDM College of Medical Sciences and Hospital, Dharwad. A native of Arla, Bantwal, did his early schooling in Mudbidri. Dr. Niranjan Kumar is an alumnus of KMC Manipal and a highly accomplished plastic and reconstructive surgeon with an MCH from Madras Medical College. His professional journey spans across India and the UK, having earned fellowship from both the Royal Colleges of Surgeons of England and Glasgow. His training in craniofacial and microsurgery in Scotland under Dr. Morris and Dr. Stevenson, which laid the foundation for his visionary work back home. He has served with distinction at KMC Mangalore and Manipal Hospital, Bangalore, before founding and shaping SDM Medical College, Dharwad into a premier institution. Under his leadership, the institution now boasts a cutting-edge craniofacial center, a stem cell lab, and multiple health science colleges under the SDM University umbrella. He has personally performed over 10,000 cleft lip and palate surgeries under the Smile Train program and continues to be an active contributor to the advancement of reconstructive surgery. Multiple brachial plexus reconstruction surgeries done by him. Recently, he has performed a foot reimplantation surgery for an 18-month-old child, which is the second in the world. Dr. Kumar has been recognized with numerous awards, including the Bahubali Puraskar, Vidyashri Award, and the Man of Year by Rotary Club of Hubli Midtown. He currently serves as president of KEPRAS, contributing immensely to the surgical community in Karnataka and beyond. A surgeon, a teacher, institution builder, and leader, Dr. Niranjan Kumar truly embodies the theme of this conference, Fundamentals First. So please join me in extending a warm and respectful welcome to Dr. Niranjan Kumar.
It is our profound honor to now invite Dr. Professor Niranjan Kumar, Honorable Vice Chancellor of SDM University, Dharwad, and the chief guest of today's inaugural ceremony to kindly address the august gathering.
Om Shri Manjunathaya Namaha. The dignitaries on the dais, Dr. Hajimono, Director Abdul Rahim, my dear friend Professor Shanai, Mr. Prabhu, Dr. Professor Aital, and I do see quite a few of my own old friends, Professor Srinivas Pai and others, Professor Vijay Kumar. At the outset, I thank you very much for honoring me. I don't know whether I deserve such an honor. However, it's always a pleasure to come back to your hometown. And when you're honored in that place, that gives a different satisfaction than anything else. I started my journey in Mangalore. My surgical started nearly 40 years ago. My professors put a very solid foundation on which I grew. I'm very grateful to all those professors. It's a great honor to be here today among so many bright and committed young minds. And they said I happily agreed to come here, which I didn't really. The Likithrai really persuaded me to come here, so then I had to come. But after coming, I am very happy. So when I always like to meet the people who have built the institutions. So that was one of the main things I had in agenda, to meet Dr. Hajiun Muno. So, sir, you have built an excellent institution here. Even though it's a very young medical college, it's going in the right direction and it has a bright future. So I asked the same straight question. I usually don't mince words. I said, why did you build this medical college? And he told the same thing. I want to give back what I got from the people around this place. And I wanted to build the medical college only here, not anywhere else. That was my intention. I think I really appreciate that, sir. Then I asked Likith Rai, what is the crowd like? He said it's basically young surgeons and the postgraduates. So then when I looked here, I see more gray hairs than anything else. But then I looked the other side. Yes, of course, there are quite youngsters. It's always a difficult thing what to talk to a crowd like this. Because when I go for a conference, when it's the inauguration, usually we just slowly wriggle out of the place, go for a food or other thing. So I can talk anything and get away with it. But when I see here, I see future surgeons, leaders and pioneers in the field of medicine. And it fills me with hope and pride as someone who has walked this path for decades. I want to share not just lessons from the textbooks, but lessons from the life, and what it takes to become a good doctor, a good surgeon, and how to get a balance in the work and life. And a lot of things I learned by myself, and a lot of things have been taught to me by my great teachers. So let's start. I think all of you want to, definitely the youngsters wants to be good doctors. So what makes you a good doctor? What are the things necessary? I think one of the most important character one should have is he should be available to the patient whenever patient needs you. That becomes very important. That alone builds an immense trust. Then of course comes your skill. Just being there is not enough. You should know what to do. So you have to develop your knowledge. So that makes it very important. So you should be in the cutting edge and upgrading yourself all the time. I interview probably thousands of doctors actually. In the last 24 years I'm working there, I definitely interviewed more than 1,000 of doctors. What character I look for when I recruit a doctor? One of the main thing is the attitude. Does he have the humility? Is he approachable? Is he empathetic? Is he a team worker? Because to become a good surgeon now, definitely you need a good team. Then only you can build a good surgical work units. But finally, all this is important, but also important is you should be available to the poor. So affordability becomes very important. To put it something very simply, availability, ability, affability, and affordability. And in this order only. Then what makes a surgeon a good surgeon, a great surgeon, an extraordinary surgeon? To the youngsters, I want to say, you don't become extraordinarily great surgeon by doing extraordinarily big surgeries. It is doing even the small surgery in extraordinary care, extraordinary planning and executing it. That makes it. So what is important is the essence of surgical excellence is precision, humility, and consistency. So what makes you success? What is the definition of success? Itself is a very puzzling. Many chase it, but few understand it. To me, success is not about fame or fortune. It's about doing the right thing in the right way and the right reason. That becomes very important. Why you do it, anything, why you do it is very important. For any institution to grow, the fundamental thing is why you build it. That's why I asked the direct chairman, why you build this. The very reason makes the institution to grow into very big heights. If you have a very strong why, you know how to do it. And doing the right thing is very important. Now, let me tell you an experience of my own. I was called in the night, probably early hours. A patient is shifted from the neighboring center to reimplant the fingertip of the left middle finger. And I saw it and I spoke to her, and even I convinced for terminalization. But then my chief came and he said, look here, this patient is shifted from the neighboring center for reimplantation. So you better do it. So I did the reimplantation. Surprisingly, it worked. And the next day, he told me, look here, always do the right thing, not what is the easy thing. And when I look back, probably on that night I was a bit lazy. So I wanted to do the easy thing, that terminalization, which takes only 15 minutes. Putting back the finger takes at least 2 hours in the middle of the night. But then I realized what he said is so true. This is what success looks like. Quiet, meaningful, and deeply satisfying. Did I say satisfying? Yes. I feel satisfaction is more important than success. Because satisfaction is your own personal. The success is judged by someone outside. The satisfaction what you get when you do a beautiful surgery. Satisfaction you get when a child which you have done or repair of a cleft lip comes back to you and smiles at you. So it comes when you know you have done the best, even when no one is watching you. That is satisfaction. So to continue about the reaching the success in the life, the very important is a passion. You should have a passion with what you do. You should do it out of love, not for the money. Then you can be really achieving the great things. And there should be persistence. You should be really persevere to get the things, especially when you fail. You have to have that guts to perceive it and go on with it. You have to perceive when there's a crap. Crap is where you have criticism and resistance, A for assholes and P for pressure. You have the guts to face the crap, and especially you should learn to face the failures. The surgeons, we face failures every day, but we should learn how to face the failures, which is never taught. Then the persistence is like Likit Rai coming all the way to Dharwad and make me to say, yes, you have to come. Focus. Swami Vivekananda told, focus is very important. You take up one thing in your life, then focus totally with that. Give up all the other things. Your eating, your breathing, your blood, your dream, your night, everything should be focused to that. Then only you can reach the goal. So focus is very important. Become excellent and needs clarity and dedication. Curiosity, inquisitiveness, creativity, these are the optional. These are what fuel innovation. Push yourself beyond failures. Push yourself beyond shyness. Push yourself saying that you can't reach and succeed in life. Push all the negative thoughts you have in your mind. That's where the growth happens. And while you work to master your craft, don't forget the real reason you're here. Why you're here? Why are you studying? What is the purpose of this? And you should know everything when you're doing, why you're doing. If you're teaching, you should know why you're teaching. You should know why you're educating the next generation. I think that's very important. That's where everything starts. That is to serve. The God given you a gift of healing, and you make it to serve and heal the others. The surprising thing is, when you heal others, you heal yourself. The training, this knowledge is not for show. It is for healing. Every stitch, every decision, every work to the patient, it all matters. There is a famous saying, your journey is a long journey. You have to work very hard. There is no other options. There's a Spartan saying, those who sweat more in practice bleed less in the battle. I think that's a fantastic state. You have to get trained very well, and it holds good for the surgeon also. If you get trained well, probably your patient bleeds less in the theater. Train hard, prepare well, and you will perform better when it truly counts and remember. And if you have seen the big planes, they need a long runway. Greatness takes time. Be patient. Trust your journey and develop good habits. And my professor, Professor M.P. Pai, told me the surgical degree MS is given. That is a permission given you to learn the surgery. This is where the journey starts. And also he told me, I still remember, go behind Saraswati, Lakshmi will follow you. And you must develop good habits, the very good habits. You need hobby. Anything could be all right. It may be swimming, it may be singing, it may be photography, or it could be some game or a thing, or maybe just simple evening walk in the middle of the nature. But I recommend you start reading. The readers becomes leaders. Reading opens up many new avenues. Read beyond medicine. Read about people, about the life, about philosophy. Reading expands your vision and sharpness, and it creates new neural networks. To be with the great people, the achievers who started the things, they rub something against you. That's why I'm always keen to meet the people who started the institutions and what was behind them, what makes them to click it. That's why I like to meet these people. But sometimes it's not able to meet all the people, but you have the books which gives an insight into these people's life. I remember when Tata goes to England and requests the engineer to come to India, he was building a steel factory. So the engineer asked, what do you build? He said, I build my nation. I think that's important. We are all part of building this nation. And it was a tough task what Likit gave me. My journey of 45 years to compress it into 5 minutes. Now, I like to give a small contradiction. Satisfaction is more important than success, I told. And in the same way, I'm saying, good is the enemy of great. Many have become satisfied with being good enough. But the truth is, growth begins when you step out of the comfort zone. Most of us, when you reach 50s, you have learned few surgeries, you mastered it, then you start slowing down. Okay, I'm in a comfort zone, I can do this happily, what I should do. Well, that is where you start slipping. Greatness requires you have to jump out of your comfort zone. You have to take a risk. That willingness to stretch yourself, then the magic happens. Lastly, one of the most profound things which I went through years is when my chief asked, I said, I'm going back to my country. He said, good, very good, you go back. So he said, then what's going to happen? I said, I want to be a very good hand surgeon and I want to develop a good micro center. I came back actually and had started the microvascular center in Karnataka. That was the first microvascular center in Manipal Hospital way back in 1992. He said, that's all good. That is your goal. What's your purpose? That really stumped me. And it made me to sit back and think what this guy, this old man, is asking me. Then he said, okay, I'll make it easy for you. See, the goal is, you said, you want to be something. You want to be that. You want to build this. But why are you doing it? That is the purpose. He said, when you do a surgery on a cleft lip child, after the surgery, you should feel that this child should lead a normal life. When you put back a hand, reimplanted hand, think that that may be a hand of breadwinners of the family. You should be able to go back and work and lead a life. If you put back the foot of a child, which I did a few years ago, I want the child to grow, should be able to go back to the school, play with the other children, play with the games, may be able to dance. That should be your purpose. So always your purpose should be bigger than the goal. Dear friends, becoming a surgeon is not just about what you do with your hands. It is about what you do with your hearts. So be excellent be kind, have service in the most important thing, and the money comes. Be balanced. You have to find a balance in life. It's very important. The work and the life balance. And please understand, one is not against the other. One is supportive to the others. I always remember my C.R. Soundarajan, my plastic surgery chief. When I got married, he sent me a very small letter. It says, handle carefully the knife, the life, and the wife. And you have to get a balance in that. Find time for family, your passion, your health. See, probably sometimes you finish your work late in the evening. And when you come home, remember, the whole family is waiting for you. And if your daughter comes and says, Dad, I want to go for an ice cream, tell her, it's an excellent idea, let's go. That is the balance what you have to find. And more than anything, be human. Finally, we are all called as the Homo sapiens. That means we are the wise human beings. Are we really wise human beings? For so many years, thousands of things have been invented. With the invention, we got the knowledge. With the knowledge, we got the power. But the power is not wisdom. With all this, what we invented, we are destroying the nature, the ecosystem. Even now, instead of we all coming together to save this earth, we are fighting with each other. Each country is preparing to kill the other. That's the sad part of it. And more than that, there's a fault in the human nature of inventing the things. If you really look into it, that's a fault in it. We invent the things, then we became slave to it. We invented the money, we became slave to it. We invented the nations, we became slave to it. We invented the patriotism, we became slave to it. We invented the religion and slave to it. Now I just wonder, are we inventing something new, like artificial intelligence? Are we going to be slave to it? This is a time we have to really think very carefully about it. And what really matters is, you be the master of technology. Don't allow the technology to become your master. The mind is a great servant and a dangerous master. With these few words, I like to say that to the youngsters and as well as to the seniors, you have to learn to live without fear. Learn to live without conflicts. Learn to live without comparison. I think these are the very important things to all of us. Thank you. I wish each of you a life filled with meaning, mastery, and deep satisfaction. I thank you again for inviting me.
Thank you so much, sir, for your inspiring words and for sharing your profound insights with us. We are deeply honored to have amidst us Dr. Haji U.K. Monu, founder chairman of Kanachur Institute of Medical Sciences, Mangalore, as the guest of honor for this inaugural ceremony. May I kindly request you to address this august gathering and share your valuable thoughts.
ಇವತ್ತಿನ ಈ ರಾಜ್ಯ ಮಟ್ಟದ ಈ ಒಂದು ಸಮಾರಂಭ, ಇದರ ಇವತ್ತಿನ ಮುಖ್ಯ ಅತಿಥಿಗಳು ಧಾರವಾಡ ಯೂನಿವರ್ಸಿಟಿಯ ವೈಸ್ ಚಾನ್ಸಲರ್, ಮುಖ್ಯವಾಗಿ ಧರ್ಮಸ್ಥಳದ ಕುಟುಂಬಸ್ಥರು, ಕಾವಂದರ ಮತ್ತು ರಾಜ್ಯ ಅಧ್ಯಕ್ಷರು, ನಮ್ಮ ಐತಾಳರು, ಲಿಖಿತ್ ರೈ, ಪುತ್ರ ರೆಹಮಾನ್, ಶಾನವಾಜ್, ಡಾಕ್ಟರ್ ಮೊಹಮ್ಮದ್ ಇಸ್ಮಾಯಿಲ್ ಮತ್ತು ಮೇಡಮ್ ಮತ್ತು ಇತರ ಎಲ್ಲರೂ, ನಮ್ಮ MP ಪ್ರಭುಗಳು, ವೇದಿಕೆ ಮುಂಭಾಗದಲ್ಲಿರುವ ಎಲ್ಲ ಹಿರಿಯ ಗಣ್ಯ ವ್ಯಕ್ತಿಗಳು, ವೇದಿಕೆಯಲ್ಲಿ ಸ್ಥಳಾವಕಾಶದ ಕೊರತೆಯಿಂದ ಎದುರುಗಡೆ ಕೂತಿದ್ದರೂ ಕೂಡ ನೀವೆಲ್ಲ ಗಣ್ಯ ವ್ಯಕ್ತಿಗಳು ಅಂತ ಹೇಳೋದನ್ನು ತಿಳ್ಕೊಂಡು, ಈ ಒಂದು ವರ್ಕ್ಶಾಪ್ ನಮ್ಮಲ್ಲಿ ಕಣಚೂರು ಸಂಸ್ಥೆಯಲ್ಲಿ ಮಾಡುವುದಕ್ಕೆ ಸುಮಾರು ದಿನಗಳಿಂದ ನಮ್ಮ ಇವರು ಹೇಳಿದಾಗೆ ಲಿಖಿತ್ ರೈ ಮತ್ತು ಅವರ ತಂಡ ತುಂಬ ಶ್ರಮ ಪಟ್ಟಿದ್ದಾರೆ ಅಂತ ಹೇಳುವುದನ್ನು ನಾನು ತಿಳ್ಕೊಂಡಿದ್ದೀನಿ. ಅದರ ಬಗ್ಗೆಯಲ್ಲಿ ಈ ಒಂದು ಇಷ್ಟೊಂದು ಡಾಕ್ಟ್ರುಗಳು, ವೈದ್ಯರುಗಳು ಬಂದು ಇದನ್ನು ಚಂದಗಾಣಿಸಿಕೊಟ್ರಿ, ನೀವು ಇದರ ಬಗ್ಗೆ ತಿಳ್ಕೊಳ್ಳುವುದಕ್ಕೆ ಅವಕಾಶಗಳಾಯಿತು. ಆ ಬಗ್ಗೆಯಲ್ಲಿ ಇದು ನಮ್ಮ ಸಂಸ್ಥೆಗೆ ಈ ಥರದ್ದು ಆಗಿದ್ದು ನನಗೆ ಸಂತೋಷ ಆಗಿದೆ. ಕಾರಣ, ಯಾವುದೇ ಒಂದು ಸಂಸ್ಥೆ ಬೆಳಿಬೇಕಾದರೆ ಅದರ ಬಗ್ಗೆ ಜನಗಳು ತಿಳ್ಕೊಳ್ಬೇಕು. ಈಗ ನಾನು ಮಾಡುವ ಕೆಲಸವನ್ನು ನನಗೆ ಗೊತ್ತಿದೆ, ನಾನೇ ಮಾಡ್ತೀನಿ ಅಂತ ಹೇಳಿದರೆ ಅದು ಎಷ್ಟು ಸಮಂಜಸ ಅಂತ ಹೇಳುವುದನ್ನು ನಾನು ಹೇಳಬಲ್ಲೆ ಅಲ್ಲ, ಹೇಳಲಾರೆ. ಆದ್ದರಿಂದ ಈಗ ತಮಗೆಲ್ಲರಿಗೂ ಕಣಚೂರು ಸಂಸ್ಥೆಯಲ್ಲಿ ಈ ಥರದ ವಾತಾವರಣ ಇದೆ, ಮುಕ್ತ ಅವಕಾಶಗಳಿದೆ, ಎಲ್ಲವನ್ನೂ ಒಂದಷ್ಟು ನನ್ನ ಪುತ್ರ ನಿಮಗೆಲ್ಲರೂ ತಿಳಿಸಿದ್ದಾರೆ. ನಾನು ಕೂಡ ಆ ಒಂದು ವಿಚಾರದಲ್ಲಿ ನಮ್ಮ ಸಂಸ್ಥೆ ಎಲ್ಲಿ ಕೆಲಸ ಮಾಡ್ತಿರುವಂಥ ಹಿರಿಯ ವೈದ್ಯರುಗಳು, ನಮ್ಮ ಜಿಲ್ಲೆಯಲ್ಲೇ ಅತ್ಯಂತ ಹಿರಿಯರು ಅಂತ ಹೇಳುವ ವೈದ್ಯರುಗಳು ಅನೇಕರಿದ್ದಾರೆ. MP ಪ್ರಭುಗಳು ಇರ್ಬೋದು, ಡಾಕ್ಟರ್ ಇಸ್ಮಾಯಿಲ್ ಇರ್ಬೋದು, ಇನ್ನು ಅನೇಕರು. ಅವರ ಶ್ರಮ, ಅವರು ಈ ಸಂಸ್ಥೆಯ ಮೇಲಿಟ್ಟಿರುವಂಥ ಗೌರವ, ಅವರ ಕಟಿಬದ್ಧ ಕಮಿಟ್ಮೆಂಟ್, ಆ ಒಂದು ಶ್ರಮದಿಂದ ಕಣಚೂರು ಸಂಸ್ಥೆ ಇಷ್ಟು ಬೆಳೆದಿದೆ ಅಂತ ಹೇಳುವುದಕ್ಕೆ ನಾನು ಮರೆಯುವುದಿಲ್ಲ. ಏನೇ ಆಗಲಿ, ಈ ಒಂದು ಸಭೆ ಸಮಾರಂಭ, ಇವತ್ತಿನ ಈ ವರ್ಕ್ಶಾಪ್ ಅತ್ಯಂತ ಯಶಸ್ವಿಯಾಗಿ ನೀವು ಅದರ ಬಗ್ಗೆ ಯುವ ವೈದ್ಯರುಗಳು ತಿಳ್ಕೊಳ್ಳಿ ಅಂತ ಹೇಳುವ ಮಾತನ್ನು ಹೇಳಿ ನನ್ನ ಮಾತನ್ನು ಮುಗಿಸ್ತೇನೆ. ಜೈ ಹಿಂದ್.
Thank you so much, sir, for your inspiring and thought-provoking address. The Karnataka State Chapter of the Association of Surgeons of India has been fortunate to be guided by such an exemplary leader, whose commitment to surgical education, mentorship, and academic excellence continues to inspire us all. It is our immense honor to now invite Dr. Rajgopal Shenoy, the dynamic chairman of KSCASI, to deliver the presidential address.
जय भारत जननी तनुजाते, जय हे कर्नाटक माते. Very good afternoon to each and every one of you, and my wholehearted appreciation and gratitude to organizers of this 8th MidCon, which is happening at Kanachur Medical College Sciences and Research Center. Sir Haji Bonu sir, for you and your entire team, we from the KSCASI, we are ever grateful to you. I also take this opportunity to each one of you who are on the dais and in front of the dais, not to waste much of my time, my most respected teacher also, and when I was doing my MS General Surgery in Kasturba Medical College, Bangalore, Sir Niranjan sir, I am extremely happy that your real words of wisdom, I hope the postgraduates and the surgeons, every one of you will take. Now at the academic side, as a ASI chairman of Karnataka State, we have been doing lots of postgraduate online teaching programs. Many of the faculty who are associated with that. For us surgeons, we are also keeping a lot of time called as surgeon's time, and which has been happening for the last 5 months, and we are happy that it has benefited many of you. Now today, already we have done the half-day program. It has gone out well, and I suppose it will continue for another half day and tomorrow. And postgraduates, hope that you will make use of this every opportunity to learn here more than the knowledge. It is here the experts who are speaking here. It is the skills that is very important here, and rightly put it, it is the wisdom that we are trying to give you with experience. There is something, you say that everything is available in books, everything is available online, everything you will get, but those practical tips, what we call it as, I think this is the best platform to make use of it. Yes, the aim of the MidCon is for postgraduates, so there were many papers and many posters had come, and this is the record, and I should thank the local organizing secretary and local organizing team, and in addition all of my Karnataka State Chapter of Surgeons, and including of course our secretary, chairman-elect, and everyone who is responsible for this successful, the participation. Now, actually, we also, not only in the education forum, sir, we are also doing service activities. In fact, ASI KSC is also one of the vision is to do a service activity, which starts from the free surgical camps to even the camps at the tribal areas we have already done, and lot of activities happen during the Surgeons Week celebrations of the Pan-India, in fact more so in the Karnataka state also, and including blood donation to whatnot. All our city branch, all chapters are doing extremely good job related to this service activities. I'm just would like to mention only 2 things. I won't take much time. Happy to release 2 important things. Number 1, may I request our Secretary Dr. Sarvesh to help me in releasing our prestigious journal, Karnataka Journal of Surgery first. Karnataka Journal of Surgery started last year. May I request our Vice Chancellor, sir, Dr. Niranjan, sir, please release this. Chief Editor Dr. Venkatesh is taking over as the President of the Pediatric Surgery Association. Right now the conference is happening in Hubli. That is the reason he is not here. I am extremely thankful to the Chief Editor and his entire team. Now we also have one more responsibility, that we are not only doing only surgery, sir, as Professor Niranjan Kumar has already told, that this is now beyond surgery. We have got actually, I think it's the quarterly magazine called as E-Shastra. E-Shastra is basically our magazine, and it has been completely brought about by Dr. Please, Savita Karol God, please come here, and may I request, sir, Haji Monu sir, please release this on behalf of KSCASI, our magazine. So that's already, I have concluded my talk, and at the last is again my sincere thanks to the local organizing secretary and organizing team, and also my dear friend, chairman of, president of the South Kerala Karavali branch, Dr. Satyamurthy, and your entire team, and lots of surgeons from the local for helping to bring this prestigious mid-8th conference at Mangalore MidCon, which is now registered by 600 delegates, which is the record as of now. Thank you. Long live KSCASI.
Thank you so much, sir, for your visionary address. Your guidance and leadership have truly set the tone for this academic conclave. It is now time for us to present a token of gratitude and appreciation to the Karnataka State Chapter ASI office bearers. At first, I now request Dr. Shiva Prakash, District Surgeon, Mangalore, to present a memento to Dr. Rajagopal Shenoy, Chairman, KSC ASI. Thank you, sir. I now request Dr. Harish Chandra, Professor and HOD, Yanapoya Medical College, to present a memento to Dr. Sarvesha Raje, Honorable Secretary, KSC ASI. Thank you, sir. I now request Dr. Gopinath Pai, Professor and HOD, KVG Medical College, Sulya, to hand over the memento to Dr. Naz Sheikh, Chairman-elect, KSC ASI. Thank you, sir. I now request Dr. Kiran Kumar, Professor, Kanachur Institute of Medical Sciences, to present a memento to Dr. Guru Baswana Gowda, the Treasurer of KSC ASI. Thank you, sir. I now request Dr. Satyamurthy Aital to kindly present a memento to our guest of honor, Dr. Haji UK Munu. Thank you so much, dignitaries. To acknowledge and express heartfelt gratitude to all those who have made this event possible, it is now my privilege to invite Dr. Likith M. Rai, Organizing Secretary, KSCASI-midCON 2025, and the Secretary of ASI South Canara City Branch to propose the vote of thanks.
Thank you so much. Respected Chief Guest, sir, Professor Dr. Niranjan Kumar, sir, our beloved State Chapter President, Dr. Rajgopal Shernai, sir, Chairman of this institution, Dr. Haji UK Monu, sir, delegates on the dais, off the dais, faculties, and my colleagues. Very good afternoon to you all. I know it's 2 o'clock and we are hungry. I'll finish it soon. It is with my immense pleasure and humility I'm standing here today during the MidCon 2025, ready to offer a vote of thanks. First of all, foremost, I give my heartfelt gratitude to our chief guest, Professor Dr. Niranjan Kumar, sir, for gracing this occasion with his esteemed presence. Thank you, sir. Sir, your inspiring words and your unwavering encouragement towards the academic endeavors have really elevated the spirit of this conference. Thank you so much, sir, and thank you so much for guiding these many years. Thank you to our chairman, Dr. Haji UK Monu, sir, chairman of our institution. His vision, generosity, and continued patronage. These are the pillars which have made our institution a beacon of medical education. Thank you so much, sir. I would like to thank my director who offered unconditional support in hosting and organizing this conference. Thank you so much, Mr. Abdul Rahman, sir. I'd like to thank the state office bearers, my president of state, Dr. Rajgopal Shernai, sir, his team, Dr. Sarvesh Aras, Dr. Gurubasan Gowda, Dr. Naz Sheikh, in helping me in conducting this conference and shaping a beautiful academic event which is filled with knowledge and expertise. Thank you so much to you and your team, sir. I thank my president, Dr. Satyamurthy Aital, sir, for instrumentally supporting me during this entire 1 year of journey in conducting this MidCon. Thank you so much, sir. I would like to take this moment and privilege to express my heartfelt gratitude to my teacher, my mentor, my guru, Dr. Rajesh Ballal, sir, for giving me the guidance, encouragement, and unwavering conditional pivot who played a pivotal role in my professional journey. Thank you so much, sir. I have to thank a team which was working behind this MidCon, comprising of our Dean, Dr. Shahnawaz Manipadi, sir, Dr. Mohammad Ismail Hajmadi, sir, Dr. Venkatraya Prabhu, Anjan Kumar, our medical superintendent, and our chief medical officer, Dr. Rohan Monis, who gave an unconditional support in organizing this event. Thank you so much, and I'm always grateful to you. Next, I thank my Karnataka State Association, State Chapter, and Executive Committee and Scientific Committee members for organizing this, arranging this conference, and crafting the academic sessions. Thank you so much. With a profound thank you to the management staff of Kanachur Medical College, comprising of Sharmila, Sarita, Dakshayani, Mr. Vittal, Avinash from IT section. Thank you so much. And behind this conference, there is a young brigade of volunteers whose energy, discipline, and dedication have been a silent driving force behind this event. Those are my volunteers comprising of the undergraduates and interns and my postgraduates. Thank you so much, without which this event will be really not possible to happen. I thank each and every one, delegates and faculty being here and participating in this event. Thank you so much for the media partners, sponsors, and housekeeping department for keeping the premises clean. I thank my IT section, audiovisuals. Thank you so much. And lastly, if I have inadvertently missed mentioning anyone's name, it is not, it is purposely. I apologize for that. and your support is always been remembered behind this conference. Thank you one and all. Thank you so much.
Thank you, Dr. Likith, for those warm words of gratitude and for acknowledging every hand that contributed to the success of this inaugural function. Ladies and gentlemen, with this we conclude the inaugural ceremony. I now request everyone to kindly rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
We invite all our esteemed guests, faculty members and delegates to kindly proceed to the ground floor MEU hall for lunch, where a specially curated spread of authentic Bangalorean cuisine awaits you. All the delegates are kindly requested to assemble back in the Dome by 2:50 for the sessions in the afternoon.
Kindly join the panelists.
Good afternoon to all. Welcome back to post-lunch session. We'll move on to the video session. Dr. Samir Ahmad, the stage is yours.
Good afternoon, everyone. Thank you. Thank you, Karnataka State Chapter of ASC, Associations of Surgeons of India, and the Organizing Committee of MidCon 2025 for giving me this opportunity. I represent SDM and bring greetings from the university. My topic today is safe cholecystectomy. Safe cholecystectomy can, for the sake of this talk, can be divided as safe anatomy, safe dissection, and sometimes use of ICG. So then, with the brief amount of time that I have been given, I have chosen the first half of, or rather more than the 70% of the earlier presentation to be for the postgraduates and the young surgeons. So that safe dissection will include safe entry, demonstration of critical view of safety, which is now considered to be paramount, and then safe closure techniques, all of which can lead to complications. And the second half of the presentation will be about acute cholecystitis, gangrenous gallbladders and all. So coming to safe anatomy, a knowledge of anatomy is very important for you to perform any surgery, and the same goes with laparoscopic cholecystectomy. You can see here, this is the gallbladder, here is the CBD, this is the right portal pedicle right underneath the CBD, then this is the ruveus sulcus here. So you can see the duodenum being pulled up. So this is the view. What you should observe here is usually the CBD is in quite near to the gallbladder, and the right portal pedicle is just below in a lily white, what we call a simple gallbladder. So before we understand, we have to understand the line of safety called the R4U line. Here the R stands for the ruveus sulcus. The 4 stands for the base of the segment 4 of the liver, and umbilical fissure, which is the U in it. So anything above it is the cystic duct, anything below it is the CBD. So here it is not so clear. In this, here my suction is the put inside the R4U line. So this will demonstrate the R4U line. This is the reverse sulcus. You can see here the tented up CBD, and you can also see the cystic duct. This simple measure will prevent you from dissecting anywhere down the line. So this is critical view of safety. Critical view of safety is nothing but demonstration of the structures in the hepatocystic triangle. Those structures are the cystic duct here. You can see the reverse sulcus there, the cystic artery here, and then the cystic plate. The lower 1/3 of the cystic plate should minimally be dissected before you clip any structure. This is the lymph node, that is the cystic duct lymph node. This is the hepatoduodenal ligament containing all the important structures. This is the same critical view of safety demonstrated when the artery and the duct are quite close to each other. You can see the lower 1/3 of the cystic plate is dissected. You can also see the traction on the gallbladder, that is the Hartmann's pouch, given laterally and inferiorly. This is the reverse sulcus here. So this briefly is a ICG photograph, wherein this is given, I think, 40 minutes before the procedure. So hence even the liver is showing. So you can see the ICG flowing through the cystic duct, even though the cystic duct is little wider, most probably telling you that there are stones in the cystic duct. This is the lighted up CBD in the hepatoduodenal ligament. So let us start with the video presentation. The most safest entry for the early surgeon is the open Hassan's method, at least according to me, followed by Very's method. Both of them are safer when done properly. I'll just give you a video demonstration of open entry the way I do it, wherein I put 2 alleys on the 2 sides of the umbilicus. So you can slit either the top or the bottom half of the umbilicus depending on where you want the port. If you want the port infraumbilical, you have to slice the lower. Then we go and dissect around the umbilical stalk on both the sides. Then hold the umbilical stalk and retract it upwards so as to pull the linea alba towards it. See, this is how I'm holding the umbilical stalk, which is nothing but the skin. And after that, we are now retracting both the edges so that we can get a better vision. You can now see the linea alba getting pulled up. We'll dissect, identify the linea alba little clearly, then make a nick in the linea alba and insert our primary trocar, that is just the port and not the sharp trocar inside it, so as to prevent injury. So now this is for better vision how the thing. So once we take the nick, okay, we should only incise the anterector sheath and nothing below that. Then using a blunt artery forceps, we just puncture the peritoneum and if at all there is a little bit of peritoneum left, and enter into the peritoneal cavity. This easy passage and little dilatation with the artery. The artery is never clamped while it's inside, and then a ribbon retractor is inserted, and then this is a port without the trocar that is being inserted to prevent any injury to the any bowels. So this is how we place a primary port. Now coming to the safe dissection aspect, here we can see this. I'll have to fast forward in. Okay, so here once we place down the secondary trocars under vision, so what we can do is, so we retract the gallbladder using the retractor port, that is the third port, that is the anti-axillary port, and then once retracted properly, so you will have a better vision. So after that, we hold the Hartmann's pouch, pull it laterally and inferiorly. Now we will be showing you a little bit of the anatomy. So I usually make a peritoneal small incision there and start with the dissection with a hook. I personally prefer hook. See, this is the anatomy, this is the R4U line in clear demonstration. Anything above the R4U line will be the cystic duct, below that will be the CBD. The preference of the instrument is surgeon's choice. Okay, I usually incise the peritoneum over the gallbladder, both anteriorly and posteriorly, or rather medially and laterally, however you want to say it. So on either side of the, I believe the posterior dissection is crucial for elevation of the gallbladder whenever the cystic duct is not as long as this case, which we will show you in a while. This posterior dissection actually frees up the gallbladder and makes it a little mobile. Okay. So after that, we can see we have dissected out the hepatocystic triangle completely with only two structures either coming in or going out of the hepatocystic triangle, one being the artery. This is the arterial line being demonstrated, the photograph that I used earlier, so that we can start clipping the duct. So this is the demonstration of the artery, duct and we are now clipping the artery. I usually prefer 3 clips whenever there is space. So 2 on the side that remains and 1 on that. So always cut the artery first, so that the duct, once you cut the duct, then there might be a swing on the gallbladder that might tear away the artery. So once we have cut it, so then the matter of cystic duct clipping. So we always clip with the cystic duct thrice, and then we go ahead with cutting of the cystic duct. Now this is mobilization of the gallbladder. You have to see the position of my left hand forceps that usually pulls the part that I am giving. That is traction and counter traction. By this method, we can do a safe cholecystectomy in a simple gallbladder. So now coming to the extraction of the gallbladder, I always believe in extracting every single gallbladder through a small endo bag. We just take an endo bag. This is a standard technique, just without using the reducer in a 10 mm, just pass in the endo bag. Okay. Then what we do is to place the gallbladder into the bag, and then once we retrieve the bag, so we pull out the bag so as to form a small cup-like thing so as to contain the bile that comes out of it. So at this point, we puncture the gallbladder with a scissor. The bile doesn't drip onto we can still use it. The plastic bag is nothing but the one that comes with the drain, the closed suction drain. After that, we put a suction into the other and we remove the gallbladder. So next is closure. Closure is also an important. The way we entered, we cut the linea alba open using just an artery forceps, and lifting the artery forceps, we can actually take the bite of the lower part of the fascia, and then the same technique is done on the upper aspect to take the bite on the upper aspect. You can see the cut edge of the fascia very clearly. So once we have tied down this, we always insert our little finger and see whether the thing is snug, whether the closure is snug, and shouldn't admit even the tip of your little finger. So in acute cholecystitis, sometimes we prefer fundus first method or dome down approach, where we take down the dome of the gallbladder, and in the end, where mostly for post ERCP cases or when the callus triangle dissection is quite problematic. So at this point of time, so we can either put clips on this gallbladder or we can loop the gallbladder. So here you can see I am putting a loop and then clipping on top of it. So this is the loop that is being tightened there, and then this is the clip. So this is for so now coming to partial or subtotal cholecystectomy when it's a Mirizi syndrome. This is again the dome has been completely mobilized. You can see a large stone, which will be, that part is a large stone. I'm just ligating or looping the gallbladder distal to it so as to prevent leakage of bile proximal. And then after that, we'll cut open the thing to extract. See, so this was nothing but a large stone. See, once we cut open, that was a large stone. So we can see actually inside that there were small other stones also, and there is a lot of additions there. So at this point, you can either continue with the dissection, or if there is a fistula between the gallbladder and the CBD, you can choose to close it with the sutures, just like I do it in this case, where we close the stump with sutures. That is subtotal cholecystectomy, where only the part is. Even in an empyema gallbladder, the same thing can be done. So we dissect the empyema gallbladder by being close to the gallbladder. The plane very close to the gallbladder is very important, being very close so that you can see the patchy area of necrosis and the pus. So once we have identified and totally identified the gallbladder, we make a small nick. This is the Japanese technique called the SS plane technique, or rather the subserosal plane technique, where we make a small incision only in the serosa. SS means subserosa. Then we enter the subserosal plane, wherein the anatomy is, this is an empyema gallbladder, the wall is full of pus. So you can see the dissection goes along with the same principles that we showed earlier. Only thing is we are above the R4U line, so I can actually see after a little bit of dissection, I basically use just my suction to pass the suction in and around. So we have gained access to the subserosal plane. So even for the lower aspect, so we clip the entire thing just like we do for any other surgery, then hold the gallbladder. Just here we sparingly use any energy source, and we just dissect the gallbladder using a
Dr. Samir?
Yes, sir. So that is how we proceed. Thank you.
Thank you, Dr. Samir. Quick one or two questions. Are the clarity from the younger? How many, Dr. Samir, in your practice, the gallbladder is known for the anatomical variations.
Yes,
how many variations, percentage?
So one of the commonest is the cystic artery variations, where there can be a duplication of the cystic artery, or there can be an anterior and posterior placed cystic artery. Then apart from that, the commonest is Moynihan's hump, that caterpillar hump. And then we have even seen duplicated cystic ducts, and sometimes cystic duct is going low down and might be inserting low down into the CBD. So, but we still remain quite higher up and go safe.
So in case of frozen callots, what is the safest method of cholecystectomy?
Safest method would be depending on how much expertise you have with the procedure. So basically, if it's a frozen callots and you are unable to identify the anatomy well, so you have to do what we call, you have to hold the Hartmann's, cut the Hartmann's, and take out all the stones, and then do a suturing of the, that's why you need to be very good at suturing if you want to try acute cholecystitis.
Samir, good videos. Always you go with the fundus first in the empyema?
I don't, sir.
We did not see anywhere the gauze dissection or using the gauze during your procedure. Is it not required?
I don't do gauze. Suction, the suction is a very good instrument in acute cases, sir.
ICG or somewhere,
no,
sometime?
We do not recommend regular use of ICG, only where there has been documented problems. That if somebody has earlier tried a laparoscopic cholecystectomy, closed it, or if there is a lower down CBD calculi, I base mostly on my LFT. If the LFT is elevated, alkaline phosphatase is elevated, then ICG might be used.
In selective cases, you use ICG?
Selective, sir, very selective. Sir.
Thank you, sir. Thank you, Samir, sir. Thank you so much.
Thank you, sir, for that insightful and practically enriching session. Moving forward, we now have a video session on laparoscopic TEP and TAP hernial repairs, a topic that blends anatomical precision with minimal invasiveness.
To guide us through this video session, we are pleased to invite Dr. Rakesh Rai, HOD Professor, Father Muller's Medical College, a renowned laparoscopic surgeon known for his meticulous techniques and surgical finesse. This session will be chaired by the same chairpersons, Dr. Dinesh Echen, Dr. Raghuveer, Dr. Sangamesh, and Dr. Likhit Rai.
Good afternoon, everybody. I must thank the entire Association of Karnataka State Chapter for giving me this opportunity to speak about TAPP. I cannot be speaking about TEP also because it's really short time. So let's go with TAP. Now, I'm going to run through this really fast. Transabdominal pre-peritonic endoscopic inguinal hernia repair is a procedure in which the approach to the inguinofemoral region is transabdominal, and the final placing of the prosthesis is extraperitoneal. The advantages, I think most of us know, it is the dissection, the pain, everything, and return back to normal activity. The disadvantage is learning curve for the procedure. The position is the Trendelenburg position. We use a 10 mm port and two 5 mm ports along the horizontal line of the umbilicus, along the linea semilunaris. These are the instruments which we use. So generally we prefer an optical trocar for the 10 mm port because it makes it really safer, and 2 5mm ports. The first step, I will come to this as I'm going through the video. So this is the 3 areas which we need to see. That is the medial area, the central, and the lateral. Lateral will have the nerves and the iliopsoas. The central is where the vas, the spermatic and indirect sac is. And on the medial side, you have the pubic bone, the Cooper's ligament, and the direct hernial sac. So it's a curvilinear incision which is made. All that we need to remember is 2 things, the triangle of pain and the triangle of doom. Together they form a quadrangle. That's what we need to remember. And the inferior epigastric vessels. We'll see that in the video. So this is what is important, critical view of myopectoneal orifice. So these are the steps which you have to go through before you go ahead and place the mesh or probably go about with your doing a TAPP repair. Can I go to the video? I have the video on, not that. There's another video. Yeah. Right. So, and that is the video where we're going to see. One thing I want you to be able to understand is the clarity of the vision also. Okay, because it's beautiful. So if you see, this is the inferior epigastric vessels you're seeing, and there is a content going through. This is a direct defect which we are seeing. And once the defect is identified, we obviously see the opposite side and also do a diagnostic lab to see anything else is in the abdominal cavity. Once this is done, reduce the contents. You will see it will be reducing the content soon. The dissection is started from medial to lateral or lateral to medial depending on the convenience of the surgeon. I prefer to start from medially, going on to about 2 centimeters above the anterior superior iliac spine. So these are the structures which you're going to see. That is the medial umbilical ligament which you're seeing, and there's a small incision made. One needs to be extremely careful about the inferior epigastric vessel at this line because you don't want to be injuring it. We use energy devices. I mean, we've started from many, but I think I prefer a sonic incision today, which makes things much more safer. That is the contents which are reduced. Below you would see the vas difference and the testicular vessels. Initially, we would make this incision much higher up, but now we have started going a little lower down because it makes suturing so much more easier later on when you want to close it. I firmly believe in suturing these defects than tacking these defects. So as you start coming in, especially when you start doing a 3D laparoscope, I realized the amount of space which we need to create laterally becomes less and less. And the whole idea about creating this would be more medially than laterally because most of the recurrences are medial recurrences. And something I want to point out at this point is the peritoneum is a single cell layer, so make sure that it's really only the peritoneum you're taking. Fat belongs to the abdominal wall, everything else needs to go up. So you would see this, there's a nice sac which is going all the way, and this was in fact a recurrent hernia which we were operating on. And somehow for recurrent hernias, this is definitely a better surgery to do. We are seeing the pseudo-sac that is being reduced. The pseudo-sac is being reduced, and we're going to be already, I think we're seeing the lighthouse sign, that is the pubic bone which is coming in. This was a large sac going all the way down. What I want you to appreciate is in between all that, even though we have created a smaller space than the traditional space which people create, we can work in pretty beautifully. The idea for all of you to understand is to be able to go past the midline. There's no 2 ways about it. We have to cross the midline. The mesh needs to cross the midline. So, and that is the space of Ritzy. Now, one small thing here is please don't rub against the bone. It can cause torrential bleeding in that area. Now, that is one of the few contents and everything is reduced. So you would see that is the previous sutures also can be seen and there. The entire sac is reduced. Those are the small vessels which I said. So I would say a good vision and a great camera makes a lot of difference, you know, especially if you have a bleed, I think it would make so much more things so much more comfortable. So yeah, that is the space of Ritzy. You can see we have crossed the midline there. Now this is the peritoneum. This is the triangle of doom, what we say. Now it is in fact, you can see the triangle of doom. You can see the third limb of the triangle of doom, that is the peritoneum is reduced below, and that would form the third limb. You can see the iliac vessels below. And now we go on to start to see for another important structure, which is going to be the psoas muscle. I would say it's the iliopsoas component, psoas medially and iliacus laterally. So once this is done, little more medially, you're going to see all the nerves. The idea is not to see the nerves. The fascia above it has to be preserved. Patients do, do come back with neuropraxia. Definitely, we're going to see the three nerves here. That is, you're going to see the lateral cutaneous nerve thigh, and then you're going to see the other two vessels. That is the genital branch of the genitofemoral nerves. That's the genital and the femoral branches. Now, once this is done, the sac is totally dissected off the cord. The landmarks here would be the vas turns medially and the plexus turns laterally. So that is where you stop your dissection. So that would give you an adequate space. The idea is you don't want the mesh rolling here at any point. So make sure that this space, even if you spend some more time, is worth investing in bringing it down as much as possible. This is something, again, which we've seen in 3D. It makes it so much more better. I prefer to use the 3D mesh. Does help in a couple of things. It does have a huge advantage. I'm sure a lot of people agree here. One is the placement of the mesh. There's a nice marking there. Second thing is all the corners are cut and kept ready for you. Third, it's a lightweight mesh. Fourth, you also see these patients responding. The amount of weight of this mesh is so much more lighter, so they're so much more comfortable post-operatively. This is the only areas we use tackers, and I believe in using absorbable tackers everywhere. No non-absorbable things inside the body, so we would go ahead with using an absorbable tacker. Initially will be the tacker to the Cooper ligament. As we all know, that is a mesh sitting in so beautifully. In fact, we did not have to do much of an effort at all. It's sitting in really well. So that is the superior flap. Probably we might have, since our incision is lower down, the superior flap, we might have to work on it a little to make things, the mesh to sit well there. That is going on to the Coopers. We do add another, generally closer towards the bone. And this is more for demonstration. I had to put, in fact, otherwise only 3 tackers are more than enough, basically. So yeah, it is absorbable tackers, no doubt about it. That is the contour of the mesh sitting right above the cord and the cord structures. This is suturing with a barbed wire. There are many, all the companies have, and I feel all of them are pretty good. This is something I think everybody should do, because we did tack a lot initially, but off late we have started suturing, and we find there's a huge difference in the amount of pain than using tackers in that area. Patients do really well when we probably suture. And when you begin off, I think it's great to use barbed wire, which makes suturing so much more easier. And I don't know how many of you have noticed, in fact, if you use 3D here, suturing also becomes so much more easier. I mean, this is a 2D, but I feel initially I think even a 3D makes your life easier. So that is suturing the peritoneum. We're closing that. One thing, again, you need to be careful here is not to take the inferior epigastric vessel on your bites there. There are different ways of suturing which people do, but you can come from lateral to medial or medial to lateral, depending on what you're comfortable with. And also one key step I feel is to bring down the pressure at this time slightly lower. Does make suturing so much more easier. In fact, when you're tacking, most of them do bring, even for suturing, I felt it does make life so much more easier. And in the end, put a suction and try to remove the carbon dioxide from there. And that you would see is the end of the dissection. We do close with a medicated port closure for the 10 mm defect, and the 5 mm are left behind. And please do another diagnostic lap at the end of it and make sure things are fine. And in fact, at this point, as us, we do use a gauze sometimes if it is required. If there's some oozing or bleeding, it does make life easy inside. Run and see the opposite side too. In fact, we did see a small defect on the opposite side, but we had not taken consent to do it here, and the patient wanted only one side. Thank you.
Thank you, Dr. Rakesh. Nice presentation, nice video. Invariably, you will take a consent for the bilateral repair if it is not obviously, it's not there on the clinical examination.
Oh, yes, sir. I mean, I firmly believe generally, but we cannot be giving them a prophylactic bilateral, but most of the patients do agree we do tell them, we do a diaglap, and if we find, we'll go ahead. This was one of the scheme patients, so they were a little worried about it.
No, what I wanted to emphasize is the consent.
Consent, definitely make sure
even
you
though
please.
they have a
Yes, yes. In fact, I think most of the new schemes put us in a trouble. They want the ultrasound to show it. And if the ultrasound is not showing a hernial defect, I mean, they say we are not going to give you a thing on the opposite side. As such, people presume to be me to be expensive. This adds on to the cost. So I would say, but you're rightly, as you said, bilateral would be the consent to be taken.
Any specific port position you advocate while suturing, sir, the lower layer?
I found the same to be quite comfortable, but I think the monitor needs to be adjusted because a lot of people I have seen either they're on the head end. We don't do that. We do it on either sides, and we make sure that we shift the monitor to the opposite sides. We do keep since I'm extremely tall, I do keep a very high stool, so my hands are quite well to be suturing.
Thank you, sir, for simplifying such a complex procedure with absolute clarity. May I now request Professor Dr. Sameer Ahmed and Dr. Rakesh Rai, along with the chairpersons, to kindly proceed to the photo booth and for a photograph. I also request Dr. Leo Francis Toro to hand over their certificates of appreciation. Our next session is a video presentation on laparoscopic appendicectomy tips and tricks, focusing on nuances that every budding laparoscopic surgeon must master.
To take us through the session, we are privileged to invite Dr. Naz Jahan Sheikh, whose surgical expertise in minimally invasive techniques is widely acclaimed.
To chair this session, we are honored to invite Dr. Ramappa, Dr. Bharat S.V., Dr. Ashok Hegde, and Dr. Mohammad Arif. We request you to kindly join us on the stage.
No slide, no video.
Our next video session would be on fillets by Dr. Venkatachala. To chair the session, we would have Dr. G.V. Ravikumar, Dr. Shrikant Aital, Dr. Harsha Kodli Vadman, and Dr. Guru Basavangauda Y. I request you to be ready.
Just a minute. Okay. Yes. A very good afternoon to all of you, respected chairperson, and all the delegates, respected seniors, teachers, and all my dear students. Laparoscopic appendicectomy is one of the easiest surgery which we consider often, but then it sometimes lands up in a big soup. And these are my own videos, and if there is any comment or advice, you are free to give me at the end of the presentation. Okay. So these are the common ports which we use. That is the umbilical port, and there's the extra ports whenever you have difficulty, and especially the suprapubic port when there is a retrocecal or retrocolic appendix. Do a thorough diagnostic laparoscopy to see if there is any other problem in the abdomen, and then once you trace see the appendix, go to the bowel and come up to the DJ flexure, because sometimes you might get surprises in the abdomen. And then once you reach the appendix, at the mesoappendix, when you are coagulating, be careful because the bowel is very close. Keep the focus on the entire distal one-third of the instrument. And we prefer to put, initially we used to put 3 loops, but now, and milk the appendix so that there are no fecolids there, and divide, and the division should be closer to 1 centimeter. And whenever there is a bulky appendix, you can divide the mesentery and bring it out. You can alternately do by dividing the mesentery closer to the appendix, and the loop is applied to the base, and we usually use Vicryl. Sometimes you find the appendix very close to the iliac vessels. So lift the appendix and use bipolar only, never use monopolar. And once you do that, once the appendix is thoroughly separated from the iliac vessels, then you can go ahead and do the routine appendicectomy. And very often you find this mesenteric fold, and sometimes you think that you have come to the end of the appendix and you land up leaving a stump of the appendix, especially when it is inflamed. See that you see the elephant head like you see at the trunk of the elephant, like you see in the gallbladder, and ensure that you have reached the base. Whenever there's an edematous base and the thickened cecum, in those cases, a transfixion suture is better. This is a fecalith which has perforated the base of the appendix, and that is a totally gangrenous appendix. So whenever you're dissecting, as Dr. Gurshantappa pointed out, use gauze piece. It comes in very handy in these situations. Don't panic and go for a conversion very early. So because the vision is much better with the laparoscope than in an open surgery. And once you have see here, especially when you look at this amount of bleeding, just pack it for some time, and most of the times the ooze stops. So we have delivered that fecalith, and then we did a retrograde appendicectomy, and there was a totally gangrenous appendix adherent to the bowel there, ascending colon. So see that you take the appendix only, and you can leave some amount of it rather than take the cecum and colon along with the specimen. Suture the base. You can either put a continuous suture or an intermittent suture. And we use the omentum to pack over it for our safety. We think so. And whenever there is a perforation and the fecaliths are lying outside, make sure you pick up all of them. Otherwise, these could lead to abscesses, and all of the time we use a endo bag, especially in bad cases, or we remove it through the port if it is smaller. So then in cases like this, better do a good mobilization of the cecum so that you can take good bites on the cecum when the perforation is close to the base of the appendix. And we can use that mesenteric fold to cover it up. So we have used that mesenteric fold to cover it up. Sometimes you find that even when you're suturing, it is not adequate. Don't hesitate to take multiple bites lower down and see that you have adequately closed it. In appendicular abscesses, laparoscopy is a good instrument for you to go into any corner, and if you can find the appendix, just go and remove it. But in cases like this where there is totally organized, don't go in search of the appendix. Drain the abscess, put in a wide bore drain, and come out. Because by the time you try to dissect out and start looking for the appendix, you might create an iatrogenic fistula. So we have tried to, whenever there's a perforated appendix with peritonitis, like Dr. Savita pointed out this morning, use of laparoscopy is very good, where you can avoid the wound-related morbidity in these patients. You can reach every corner of the abdomen, do a proper thorough peritoneal lavage. And again, this is another case wherein you drain, and why I mentioned this here was, look into all the pockets. You are likely to miss out some pockets because the tactile feel is not here. And this is the final incision final picture after the patient has healed. So you have avoided wound-related morbidities. sometimes you find some bowel adhesions as you enter in, and we can't go through some pockets, some windows and do it. And there is another situation wherein you find a bowel loop attached distally. It is better to divide this and go further for an easy access to the appendix and for good dissection. Here this was an auto-amputated appendix. So the base had already healed. We just took a bite at the base and then we did the rest of the appendix. And in this patient, the appendix could not be separated at all. In such cases, do not go and try to dissect out because nature is trying to heal it. So in these cases, just put in a wide bore drain and you can come out. And in this patient, the appendix was completely absorbed. There was no appendix seen. In such cases, go behind the cecum, medial to the cecum and up to the iliac flexure to look if there is the appendix there. And we couldn't find anything, so we just sutured the base and we came out. This is a totally gangrenous appendix, and if you will be lucky if you get a slight amount of, a little base so that you can suture that. And in this patient, a totally gangrenous appendix and with a punched out hole on the cecum, and we couldn't do anything. Probably nature has sealed it, we couldn't see anything coming out, just took a suture there, and then we put in a omental patch. We took the omentum and wrapped it around it. So my presentation ends here just to show you that during an appendicectomy, you go in for an appendicectomy and you find that actually there are some other surprises for you. So this is the abdominal tuberculosis what you find, and then sometimes you find these are the torsion of the epiploica presenting with pain and you think it's appendicitis, and that is the torsion of the ovary, and this was the torsion of the appendicular appendage. And this was on perforated cecal diverticulum. This was not mine, given by Dr. Anup Kupsat to me. Just to say that you may go in for appendicitis and you may have something else. Just keep your mind open for another procedure if you have to do. Thank you so much. Thank you for the opportunity.
Thank you, ma'am, for this extensive video and your explanation of the conditions about the appendix and with its tips and tricks. The floor is open for questions.
Good videos, all varieties of appendicitis. Two things just I wanted to add to this. One is position of the patient before you start inflating. See that the head low done. And second, once you start the procedure left lateral, definitely these two positions will help a lot in difficult cases. And I did not see using suction irrigation. You have used only suction. If you can use irrigation along with that, you will have a clear field while operating.
We do use ample amount of irrigation. And most of the times we do it under spinal anesthesia. Only if the patient is very obese, uncooperative, or if there's generalized peritonitis, we do it under spinal. And we, as you said, we do it, the insufflation starts with the head low position. Yes, I didn't, yes.
If you encounter, because morning session they told,
yes.
If it is the appendix is normal, go for Meckel's diverticulum, what you will do? Means
Sir, if the appendix is normal, appendix is normal, and the criteria what were mentioned, if it's a middle-aged or an elderly person, I would not do anything, sir. And if the appendix is normal and you find that this has a narrow base and it is longer than there is a 2:1 width, that is what criteria what we take. In that case, we can leave it. But one patient I did an appendicectomy, and when I was tracing up, I found that the appendix was, the Meckel's diverticulum was inflamed and it was sitting on the gallbladder and liver. So I had to remove that. So if I find that there is a pathology, I'll definitely do that.
Have you any time used staples?
No, sir.
Okay.
We work in a very resource constrained places.
Okay. Then have you any time done right hemicolectomy?
No, sir, I didn't have any situation. I have told the patient that we might have to go in if there is a leak, but so far in all these cases, whichever I had, I didn't have to do anything further, sir.
So what about drains?
Drains, I put the drain and leave it for about 7 to 8 days in very bad cases.
Yes. Thank you very much, madam.
sir.
Thank you very much for
Thank
this
you.
exhaustive.
Thank you, ma'am, for that beautifully structured and informative session. We now request Dr. Naz Jahan Sheikh and our esteemed chairpersons to kindly proceed towards the photo booth for a group photograph, and I request Dr. Likit M. Rai to hand over their certificates of appreciation. Ladies and gentlemen, we now continue our academic journey with a video session on phyllodes, a rare and fascinating breast tumor that often challenges surgical judgment.
To present this topic, we are pleased to invite senior oncosurgeon Dr. Venkatachala, an expert known for his depth of understanding and clinical acumen in surgical oncology.
To chair this session, we now invite Dr. G.V. Ravikumar, Dr. Shrikant Aital, Dr. Harsha Kodli Vadmat, and Dr. Guru Baswana Gowda Vai onto the dais. Our next video session would be on ilioinguinal block dissection with the same chairpersons.
Thanks to KSCASI and the organizers for giving me an opportunity to talk today. I was told to talk on phyllodes tumor. Phyllodes is not very common as breast cancers. So in phyllodes, effectively what we do is a lumpectomy with 2 centimeter margin for benign and borderline phyllodes. For malignant phyllodes, most often it is a simple mastectomy, total mastectomy with reconstruction, followed by adjuvant treatment based on the extent of the disease. So I thought by showing this video of breast conservation surgery and sentinel node biopsy with oncoplasty in early breast cancer, you could get to witness both a lumpectomy as well as the management of breast cancer. So the lady was a 79-year-old patient with invasive breast carcinoma. So, and it was hormone receptor positive, HER2 negative, and Ki-67 score was low. So age is not a criteria for mastectomy. This was the breast lump. Unfortunately, in this view, I can't show it properly, but there was the very clear mammogram picture showing the breast lump with no nodes. Just 1 second, I have to adjust this. Okay, now we will be able to see this. Yes. So you can see digital mammogram, how it would give a better picture. And as you can see, we have marked the area of the lump in the upper quadrant. This is the lump, 2 centimeter into 1.8 centimeter tumor, and then axillary skin crease. Because the video, first part of the video was recorded by me, and then the next part of the video was recorded by the technician, so there was a difference in the way he held the phone for recording. So we started with the methylene blue was already injected, as you could see from the blue stain at the lumpectomy site. You could see the blue stain there. Intradermal and peritumoral injection of 4 ml methylene blue. 15 minutes later, we go to the axilla after giving some gentle massage to the breast so that the lymphatics pump the methylene blue to the lymph node. So the small incision is enough, just like you do a node biopsy. Yeah, what happens is, this is a faint lymphatic. In our mobile we could see it better, and for a naked eye it was like 0.2 millimeter. So you won't be able to appreciate that better because human eye can see more colors, better colors than the phone camera. So then it goes to the lymph node here. So we pick up the lymph node, dissect around without damaging it. As you can see, this is the lymph node being picked up. We take up the lymph node. Also, we clamp the lymphatics so that there won't be any lymphoria. Even with a sentinel node biopsy, there is 1 to 2% chances of lymphedema. So we don't want that, so we clamp the lymphatics and tie them. It is very important. Even when we are doing axillary node dissection also, we clamp all the lymphatics and ligate them on lateral and inferior and superior aspect, so that there will be less lymphoria and less lymphatic leak. The moment that this is done, then we will send it for frozen section. If the frozen section is positive, you know that the latest guidelines are that American Cancer Society guidelines that if there are less than or equal to 2 sentinel nodes positive, we don't do axillary node dissection. Anything 3 or more nodes positive, we do axillary node dissection. So the blue node will be sent for frozen section. Frozen section actually showed that the lymph node was negative for tumor. So this was in a place where isotope or ICG was not available, so we had to do only with methylene blue. Otherwise, we use a combined technique. One of the intercostal nerves, the third intercostal nerve was next to the lymph node. We have carefully preserved it. This is the benefit of doing sentinel node biopsy. Now that we have marked the area, that is a parallelogram incision. I will go at a higher speed now. So you can see that we have marked the incision, measured it, and then we proceed with the lumpectomy. You can start at the inferior border or the superior border, wherever you are comfortable. So we finish on one side first, and then we go to the upper side. Undermining of the flaps will be needed for some distance, because later on you can do good oncoplasty with that undermined flaps. The corners are also incised so that you can raise the flaps on one side better. So the skin hooks are applied. We normally keep 4 skin hooks and then undermine the skin flaps. Then we start going deeper on medial, lateral and inferior aspect. 1 centimeter margin for even a 1 cell margin is enough for a breast conservation surgery in malignancy. 1 millimeter is enough, but we try to keep it more than 5 millimeter, ideally 1 centimeter. And if there are any suspicious areas like DCIS or any invasive small foci of tumor nearby, we have to take extra margin. Whereas for phylloids, I told you 2 centimeter is the minimum margin because of the invaginations microscopically which extend into the breast tissue. So we go up to the pectoral fascia, take the pectoral fascia also, because whenever we have avoided taking the pectoral fascia, the base will be closer to the lump. Now the upper incision is being done. Again, we start raising the upper flaps. Again, undermining, as I told you, as we are undermining, we also keep some breast tissue ready for oncoplasty. Again, we go up to the pectorals. You can see the blue stain caused by the methylene blue. In elderly women, the methylene blue as well as the isotope or ICG will not reach the lymph nodes quickly because of the atrophy of the lymphatic vessels. So generally we have to wait for a longer time compared to younger women. Again, you go deep to the muscles, take up the pectoral fascia and then grab the whole lump, and then now this is the point where we orient the specimen for the pathologist. Lateral long silk, superior short silk and base double silk. So superior short silk, lateral long silk, S for S, L for L and base double silk. Then the base double silk. Pectoralis fascia is actually a fascia. If you have taken, it is extra 2 centimeter margin. Periosteum is 3 centimeter margin, bone is 5 centimeter margin if you take a margin of bone. So we sent it for frozen section. Margins were all clear on frozen section. effectively, and when we put 2 clips or 3 clips like we are doing for the lumpectomy cavity, because the radiation oncologist must know where to boost it, and these clips are placed before you start closing the breast lumpectomy cavity, means doing the oncoplasty. Before that itself you have to place the clips. So this is the orientation of the specimen: superior short, lateral long, and base double silk. So I told you that this came as negative, so the sentinel node was negative, we are closing the wound. Again, we close it by continuous suturing using 4-0-ethylene for better cosmesis. So the wound is closed. Now wash the wound. Don't forget to wash the cavity, because hemostasis as well as spilled tumor cells, infections, reduction, everything will work with irrigation. Pressure irrigation is important. Half of 20 ml syringe is filled with saline and washed. Now oncoplasty flaps are being mobilized. A drain is removed at 2 days. You see that I brought it out from the inframammary crease, because that is, any drain exit points are also included in radiation. So we cosmetically also it is useful to bring it out from the inframammary crease. We remove it at 2 days because some seroma must always remain in the breast for the contour, for better cosmesis. So the upper and lower flaps which were mobilized during the lumpectomy are now approximated, because the lumpectomy cavity must get the bulk of fat. Otherwise, during radiation, when they boost the lumpectomy cavity with extra 9 grays of radiation, what happens is that there will be dimpling and contracture, and that causes bad cosmesis. So after that, we have closed the wound. As the video continues, I can take questions. Thank you very much.
A few questions.
Suppose
I just want to ask you about phylloides.
Yes,
Usually, when we remove the huge giant fibroadenoma,
Yes, sir.
we never suspected phylloides, but the HPR comes as phylloides.
Correct, sir.
So, how to convince the patient, and what is the follow-up? This one like?
When you evaluate a patient with a big fibroadenoma, more than 3 centimeters, what we normally do is we do a core needle biopsy. Generally, core needle biopsy will give you the diagnosis. If it is a smaller tumor, fibroadenomas also, we try to take a cuff of normal tissue to be on a safer side. If at all later on it comes as a phylloids, we keep the patient under close observation. Ask them to come at 3 monthly follow-up, at least for the first 2 years, and then 6 monthly follow-up, so that if at all it comes back, you can detect it early and redo it.
And anything further sonography or advised or anything for that?
Clinical examination, mammogram or sonomammogram, whatever is indicated for that particular age, it will be done.
you are given methylene blue.
Yeah.
You have seen one lymph node which you are harvested as you showed.
Yes.
Then that is sent to the histopathology. How they can make out whether, how we can make out whether it's 2 or 3, because 2 or 3 more than that we have to do?
No, the timing between injection and your opening of the axilla are important. At 15 minutes to 20 minutes, generally it goes to the first lymph node. You should open, if you don't see a blue streak, we wait for some time. At that point, don't dissect the axilla. So once the first lymph node, which is draining the blue lymphatic, you will see the blue lymph node, we pick it up immediately. If you wait for a longer time, you may get 2 or 3 nodes. Then you have to send all those 2 or 3 nodes.
No, you have removed one lymph node which you have seen and sent.
Yeah.
That comes as positive or negative. You need to do more than 3 or something to do axillary clearance, is it not?
No, 6
so
is
that you have not
sampling.
done.
6 nodes are sampling.
So will you do every time sampling there?
No, we don't do. Even if 2 sentinel nodes are positive, we can avoid axillary dissection. More than 2 sentinel node positive, only we are doing axillary dissection.
Then you have to check other lymph nodes also.
We feel the axilla when methylene blue is used. If we have used isotope, we use the isotope, the probe to check for residual activity in the axilla and remove those nodes also. If we have used ICG from the surface itself, the camera will show whether there are one nodes or multiple nodes in advance.
So just removal of one node versus level 1 removal. Which is good and which is
one node or two node sentinel node removal. The advantages are shoulder disc motility, nerve saving the intercostal brachial nerve, as well as the lymphedema risks are all lowest with that. The more you go from 1 to 2 sentinel nodes to beyond that, the risk of all these increase.
In continuation with his question, because there are postgraduates also,
Yes, sir.
what is ideal sentinel node biopsy?
Means the technique or numbers?
No, not technique. If you get a specimen of sentinel node biopsy, when do you say it is an ideal sentinel node biopsy so that you can take a call on addressing axilla after the frozen section report?
If the surgeon has
Since
picked
there are
up the
postgraduates
proper sentinel node by the technique I described, the first 2 nodes in the axilla which drain the breast, there should be only 1 or 2 nodes. If you send more nodes, that means it is contamination. Contamination means that you are sending more tissue, the pathologist will not be able to dissect each node 15 to 20 cuts and report to you on time.
But if you are going to make a decision that 3 or more needs full axillary clearance, if
3 nodes positivity means
if that is going to be taken a decision
clinically, when you have removed 2 nodes,
clinically
2 or 3 nodes you have sent to the pathologist. When you remove the sentinel nodes, suppose I remove 1 or 2 sentinel nodes. If I feel they are positive, I check the rest of the axilla. When you palpate, you should not feel more than 2 nodes being positive there, clinically also. We cannot send 5 nodes and find out that 3 nodes are positive. When we are doing it, we pick up 1 or 2 nodes and examine the rest of the axilla, feel and see whether 5 millimeter, 6 millimeter, 8 millimeter nodes, if there are odd nodes, suspicious nodes in the axilla. Those nodes you can remove and send separately as non-sentinel nodes. If you feel that there are 3 or more nodes positive in the axilla, you can go ahead with axillary dissection.
Thank you, Dr. Venkat. Thank you, everybody.
Thank you very much. Thanks a lot.
Thank you, sir, for that enlightening session on the management of Phyllodes tumor. Our next session focuses on a vital anatomical dissection, ilioinguinal block dissection, a procedure that demands surgical precision and thorough anatomical knowledge. We are privileged to invite Dr. Ravi Verma, Professor, Kanachur Institute of Medical Sciences, to deliver this video presentation. The session will be headed by the same chairpersons.
Okay, fine.
Video. Okay. Good afternoon, everybody. I'll quickly go on to my topic, ilioinguinal block dissection. So here we are removing 3 groups of lymph nodes. One is superficial inguinal nodes. They are into 5 groups, that is central zone, superior lateral zone, and inferior lateral zone, superior medial zone, and inferior medial zone, depending on the tributaries of the veins. And coming to the deep nodes are one which is deep to the fascia lacta. So these are basically situated medial to the femoral vein. You can see clearly femoral vein, medial to femoral vein. So the node of Cloquet is the most Suffolk node. So third group, that is pelvic group. This is the iliac group. Here 3 groups of lymph nodes we are dissecting. One is external iliac, internal iliac also called as hypogastric, and obturator nodes. So here the boundaries will be like medially is the ureter, laterally is the genital branch of genital femoral nerve, and superiorly is the bifurcation of common iliac, inferiorly circumflex iliac will come, and deep inferiorly the obturator nerve. So coming to my case capsule, so 70-year male patient with a history of non-healing ulcer over the left foot for the duration of 8 months, with a comorbid condition of diabetes mellitus, along with the biopsy has revealed as squamous cell carcinoma. Ultrasound and MRI shows bulky multiple lymph nodes, inguinal group of lymph nodes. So basically incisions, there is a traditional Lacey's incision as well as step ladder pattern incision. The idea is this is a dressless quadrangle So anterior superior iliac spine, pubic tubercle, 15 centimeters from this, 20 centimeter. This restless quadrangle node should be addressed completely. So coming to the video. So starting with the Lacey's incision. So flap is raising the flap. I prefer a thin flap around 1 centimeter. And we can see a bulky nodes. You can see in the superficial nodes. And you can see the great saphenous vein. And delineating the great saphenous vein. When delineating only, I will find half of the nodes towards the lateral side. And that's the adductor longus. That is my medial boundary. So tributaries of ligated. So coming to the lateral boundary, that is a sartorius muscle. So sartorius fascia is lifted. So now we can going for the cloacat node, that is near the SF junction, close to the femoral vein. So this node is sent for the sentinel node now. And removing other deep nodes near to the femoral vein. Yeah. So once you remove the deep nodes, we can make out vein, artery, and I'm dissecting the femoral nerve now. So SF junction, I'm ligating the flush ligation. And there are saphenous preserving as well as non-saphenous preserving. I'm not coming to that controversial topic now. So SF junction ligation. So distal end ligation. Now again identifying the structures. Can clearly see the femoral nerve now. Now completing my superficial node, continuing with that over the sartorius. That is reaching the apex of the femoral triangle, where the femoral canal extends to the Hunter's canal below that. That's the base of that femoral triangle. So femoral triangle is seen properly, sartorius, adductor longus, great saphenous vein, and femoral artery, vein, and nerve. Now going to the inguinal ligament, there will be some kind of superficial nodes over the inguinal ligament. So clearing all those nodes over the inguinal ligament. So now the frozen section shows negative for malignancy. So hence I didn't proceed for the pelvic group of nodes in this case. I'll be demonstrating the pelvic group in other case of CA carcinoma penis, where the frozen section sentinel biopsy shows the cloacat node shows as a malignancy. So inguinal ligament is opened. This is an extraperitoneal approach. First towards the lateral side, we'll be identifying the psoas muscle with the genital branch of genital femoral nerve. That's the lateral limit. That is the gentle branch of gentle femoral nerve over the psoas muscle. That's the iliac group of nodes. This is going medially towards the ureter or bladder base. That is our medial boundary. I use bipolar in this dissection. Yes. We have completed the pelvic lymph node. This is the same we do for Werthims or ovary in CA ovary, where we do an intraperitoneal approach. So that is the obturator now, that is the posterior medial limit. Below that, obturator vessels will be there. So that is the limit. And medially you can see the ureter. Yeah. A closure of inguinal ligament in 2 layer. You can see. Drain has to be placed one in the extraperitoneum as well as the inguinal region. So this is the sartorius interposition, because sartorius has to be detached from the anterior superior iliac spine and will be covering the femoral vessels to should not complicate for the femoral blowouts. So usually sartorius will be sutured over the adductor muscle and lacunar ligament. So completely femoral artery vein should be covered with the sartorial flap. Usually these drains will be keep on coming for the day 10, day 15. So until it is less than 30 ml, I don't remove any drains. And lymphoria is a major cause. And flap necrosis, I have not faced anything much. And no blowouts in my case till now. So this is a post-op wound, closure done. Thank you.
Thank you, Dr. Ravi. Floor is open for questions.
Good video, Dr. Ravi.
Sir, thank you, sir.
Which incision do you prefer? You showed a vertical incision. We used to do that 20 years ago.
Sir, basically pre-op when mindset, there is a bulky node. If bulky node is if I feel like skin is infiltrating, I'll put a LACS so that how much ever I want to remove the skin, I can easily close the skin easily. When I put a stepladder incision, I have to modify according to the skin involvement. When I see any bulky node or suspected skin involvement, I go directly with LACS incision, sir. If there is no, I am not feeling any skin involvement, I directly go out with stepladder impact.
Yeah, I can understand when there is skin involvement, you have to remove the skin, some TFL flap
This
may be needed.
Closure will be easy.
Yeah, yeah. So, but the risk of problems are least cosmetically also good with the transverse incision.
Stepladder.
Transverse incision. Okay, so if there is a prolonged lymphoria, you know what happens, there will be lymphedema infraumbilical, the whole area, lower limb also
Yes,
on
sir.
that side.
Yes, sir.
How would you manage that prolonged lymphoria in these patients?
So usually I'll conservative management only I will do, sir. Use of crepe bandage, elbow limb elevation, keep the drain until I would kept drain for 3 weeks also. So 21 days also I kept, then I removed. I put a compression dressing also sometime. And some secretions, we can glycopyrrolate, all those things will reduce, I feel, in these cases also, sir.
What small thing what we do is laterally, inferiorly, medially, we
You ligate
grab
it.
the lymphatics
You
and tie them.
ligate it,
So
sir.
that will reduce the lymphoria. You know that the drainage is such a big area, lot
Yes,
of
sir.
lymphoria will be there.
Yes, sir.
So we generally put 2 drains in the groin, in the inguinal region. So if one blocks, the other one will function, so that there won't be oozing through the wound and wound breakdown and dehiscence and infection.
Correct.
And we put stockings, lymphedema stockings. We put them class 1 compression stockings will be good.
3 months I advise them,
So
sir, actually.
generally we have to keep them under close follow-up so that it doesn't get blocked. And slowly it will come down. Invariably it will come down one day.
Okay, sir.
But it takes longer time here than in the axilla.
Yes, sir.
For sure.
I have faced for 1 month, I have faced until the drain I have pushed it, sir.
Any other questions? Okay. Thank you very much.
Thank you, sir.
Thank you. Very good.
Thank you, sir, for your detailed and methodical approach for such a challenging procedure. I now request Dr. Venkatachala and Dr. Ravi Verma, along with our chairpersons, to proceed to the photo booth on the right for a photograph and to collect the certificates of appreciation. I request Dr. Kumar Krishna, Consultant Plastic and Reconstructive Surgery, Kannachur Institute of Medical Sciences, to do the honors.
Our next session brings us to a fundamental yet intricate surgical procedure, thyroidectomy basics. To simplify this subject for us, we are pleased to invite Dr. Guru Shantappa Yelagachan, former HOD KMC Hubli, whose expertise in endocrine surgeries is highly esteemed. To chair this session, we now invite Dr. Siddesh, Dr. Aditya, Dr. Kasa Somashekar, and Dr. Suresh Badigar.
At the outset, I thank our state association and its team and the organizers of MidCon 25 for having given this opportunity. The video of this thyroidectomy may be a repetition for few here and also few of my colleagues. I will be playing the video. At the same time, I will be giving some tips for safe thyroidectomy. Please play the video. You can mute the audio. It's important you should have examined the patient earlier. It's important that you personally put the position for thyroidectomy and then scrub for the case. It's a male patient treated for thyrotoxicosis. It's better to have a nice extended position so that it will be easy for doing a thyroidectomy. The length of incision depends on the size of the gland and the expertise. In this case, it is a bigger incision where it is extending up to the lateral margin of the sternocleidomastoid. Half of the surgery will be done if you have raised a good flaps, both proximally and distally. Proximally up to the thyroid cartilage, pack this, and it has to be a subplatysmal flap to avoid flap necrosis. The lower down, the trick what I'm mentioning, you make a nick here on the operating side, small nick, put your index finger so that this can be used as a traction, so that you will have a nice raising of the flaps. On the opposite side, over the sternocleidomastoid, you will have a flimsy fibers. So make a nick there, put your index finger there, straightway it will go up to the sternal notch. See that? Then it will be very easy to go up to the sternal notch. You need to take care of avoiding injury to the anterior cervical veins at this point. This is incising deep cervical fascia, vertically midline from thyroid cartilage still suprasternal notch. See that you do this in a single attempt, like a slice. Then the next important point is to get the plane between the strap muscles and the surface of the gland. Very important step for doing a good thyroidectomy without much bleeding. Since this patient was having a very huge goiter, the middle thyroid vein was very big. You can see the middle thyroid vein, such a big vein. Usually it is a short and stout vein. If you try ligating and you may injure and avulse IJV. After ligating that, you will have the superior pedicle dissection. This is the laryngeal area. Between the pedicle and the larynx is the Reeves space, avascular plane. So create a plane there. This laterally, what I am holding the index finger here, it comes only if you have mobilized the lobe laterally very nicely. Most of you, without mobilizing, you try hooking this pedicle and land up with problems in bleeding. See, in this case, nicely it has been mobilized, the superior pole. You need to create a segment of superior pole to avoid slipping of the superior pedicle. See this is the segment what I am going to create. The thread suture on the specimen side and the observable suture on the patient side, so that we can now avoid the other problems. So create a segment. It is one of the important steps in ligating superior pedicle. It is called pedicle because it has got both the named vessels. The lower one is not called pedicle because they go artery and vein go differently in different directions. To have a transfixation of that pedicle, again you need to put one more artery and do, because this slippage of this is one of the causes for hemorrhage during
thyroidectomy. Once you do this, see my thumb, it will lift up the upper pole so that you will have a nice dissection here laterally. This is a superior parathyroid gland which was presented in the morning. After dissecting that, come to lower side. This is a dissection of the recurrent laryngeal nerve. In this case, the nerve, the inferior thyroid artery and the inferior parathyroid gland are dissected simultaneously. It is branching here in this case. You can see more than 50% of the cases on right side, recurrent laryngeal nerve divides before it enters into the larynx. This is the area of the Berry's ligament. That's what I am showing there. This is one of the branches of the inferior thyroid artery. It's quite big because the gland is huge, which runs transversely. This is the nerve, this is the artery, one of the branches of inferior. You can see the lumen in the artery, which I am ligating there. So these are the different versions of recurrent laryngeal nerve. So these three, that is the recurrent laryngeal nerve, inferior parathyroid gland and branch of the inferior thyroid artery are identified in an area of circle of 1 centimeter. Simultaneously it has to be done. This is the inferior thyroid vein which goes down into the innominate vein, which may need a ligation. Then you need to mobilize this gland from the trachea. Here I am going on the opposite side, same steps, raising, creating a flap between the surface of the gland and the left strap muscles. Here this patient, the left lobe was going into the mediastinum. He had a retrosternal goiter, which has been mobilized from the neck. See how it is coming up. Once you pull up and dissect out that loose areolar tissue, the gland comes out of the mediastinum. This whole of the gland was below the clavicle. So once you lift up that, we'll have a loose areolar tissue, so you need to dissect out here. And again tackling the upper pole first, so that you will have a safe area for demonstration of recurrent laryngeal nerve and inferior parathyroid gland. This is the area. The nerve needs to be demonstrated before it is being dissected out. This is the area of the left recurrent laryngeal nerve. Left recurrent laryngeal nerve. This is the area of the parathyroid there on the left side. Sometimes you may have to come on the left side for a good dissection on the left side. So once you dissect out on the left side, you need to mobilize the gland from the trachea. This is being done in this case. There can be a blood vessels supplying the gland, that is called tracheal vessels. That is also one of the blood supply to the thyroid gland. You may have to tackle with bipolar. This is the specimen out. After that, you need to check for good hemostasis. Again, check for the parathyroid gland, recurrent laryngeal nerve, and the superior parathyroid gland also. This is the inferior parathyroid gland. This is on the opposite side. Give a thorough wash, do a good suction, and check everything. Count the gauze pieces. In a large gland, probably you must have kept plenty of gauzes in the field of surgery. This deep cervical fascia is closed vertically with the interrupted sutures after confirming the count and the hemostasis, and after keeping a drain in a larger gland. In no cases I have cut the strap muscles. That instance may not come. This is in the morning somebody discussed, this is the non-recurrent laryngeal nerve, which may be seen in some cases. Please remember, this question will be asked. If there is a non-recurrent laryngeal nerve, invariably they will have an associated absence of inferior thyroid artery. They go hand in hand. This is one of the other case where small gland and demonstrating superior parathyroid gland, superior parathyroid gland. So once you pull out, the nerve comes anterior. So these are the disease process. What is the incidence of recurrent laryngeal nerve? What is the incidence of parathyroid gland injury? Since the video was for 8 minutes, this is the faster video I have done. The tricks are, first is, the operating surgeon should have examined the patient with a good history. See that if it is a case of thyrotoxicosis, you have maintained thyrotoxicosis, morning dose of beta blockers are given. And second, the imaging, if you have done, look into the image and suspect some problems on table. Third, the surgeon himself should put the position of the patient so that you will have an extended position nicely. The fourth, the incision depends on the size of the gland. So you plan the incision nicely. Suprasternal notch, 2 centimeter, medial border of the sternocleidomastoid. If you raise the flaps nicely, half of the surgery is done because you will have a good exposure of the gland. Then exactly in the midline, you need to cut the deep cervical fascia so that you will be able to see the strap muscles on either side. Have a patient's nice dissection between the strap muscles and the surface of the gland. Take care not to injure the surface of the gland vessels. Otherwise, it is a hematoma. Your further dissection becomes difficult. So put a right angle there. See that you lift and retract so that you will be approaching the lateral part of the lobe of the gland, lateral lobe. Then pull the gland up. The retracting assistant is very important at this phase. My postgraduates who I have assisted will remember what the upper person should be doing, what the lower person should be doing with a retractor. Then go look for the middle thyroid vein. More than 50% of the patient middle thyroid vein may be absent. Then tackle the superior pole at the Reeves space. Have a nice segment there. Be careful, nicely ligate and do a transfixation. Look for the superior parathyroid. Lift up the lobe medially. Look for inferior thyroid artery branch, inferior parathyroid gland, and a recurrent laryngeal nerve simultaneously in an area of 1 centimeter circle. Definitely you will get all of them. Then tackle the inferior thyroid vein, which runs down into the innominate vein. Then mobilize the trachea, gland from the trachea. If your plan is total thyroidectomy, you need to mobilize little more on the opposite side so that the opposite lobe dissection becomes easy. If required, go on the other side to demonstrate the recurrent laryngeal nerve and repeat the same procedure on the same opposite side. Thyroidectomy is it's a very nice, good anatomical dissection surgery. If you can become perfect in identifying recurrent laryngeal nerve, it's a most enjoyable surgery. Thank you. My video was fast because the time given is 8 minutes.
Sir, here.
Use
of bipolar cautery is really helps.
Yeah, definitely.
So you did not tell about that.
Bipolar cautery, I preferably insist that you should be using the bipolar cautery if you have not demonstrated the recurrent laryngeal nerve during your dissection, because you are going to cut the tissues without being demonstrating. Then definitely bipolar cautery is a must. Second, when you are dissecting the gland from the trachea, bipolar cautery is a must. After doing everything, you are checking for hemostasis. There is a small ooze at Berry's ligament area, because every Berry's ligament area will have a small blood vessel there, which is the one which bleeds. So in the bargain of controlling that bleed, you will be injuring the recurrent laryngeal nerve, which passes through the Berry's ligament in more than 50% of the cases. So at Berry's ligament, after doing every surgery, use a bipolar to have a good hemostasis. So these are particular areas I insist for bipolar. Otherwise, it can be done nicely with a monopolar.
You asked bipolar, specifically 5-inch long, 0.5 millimeter tip. Anything bigger or smaller will not help. 0.5 millimeter tip and 5-inch long, and best is to go with the Megadyne or Valley Lab people, because only they can give that specification.
Thyroid surgery is a good anatomical dissection, sir, like any other head and neck surgeries. Head and neck surgery needs beautiful anatomical knowledge and a good dissection.
No, Dr. Venkatesh, I don't think any brand needs that. It is meticulous dissection in thyroid is important. And recurrent laryngeal nerve, rather than dissecting, just identify it, leave it. Don't try to dissect it.
Don't try to convince the person who is standing by the side, showing him that, yeah, see, this is recurrent laryngeal. No, don't do that. If he is not convinced, it is his problem. Have a good dissection. See that it is left with the patient.
Now, why I mentioned the brand is I tried to find out cheaper options from other companies. I couldn't get it. So I don't want you also to struggle with for trying to find out from different brands.
Because we are in government setup, we are doing all without branded. We are operating with the same what you call cautery.
And for the postgraduates, there are few questions which are standardized questions after your clinical examination. What are the causes for hemorrhage during thyroidectomy? What is the percentage of having bifurcation of the recurrent laryngeal nerve? What is the difference between the right recurrent laryngeal nerve and the left recurrent laryngeal nerve? What are the anomalies associated with the non-recurrent laryngeal nerve? Then what are the post-operative complications? Be thorough with this.
Nice dissection. Appreciate the video. Only one small little tip, if I may. Bring the drain out through the corner of the wound, sir. Don't have an extra stab injury there for the... You put in a nice subcuticular And you're going to have a keloid at the drain side
Yes, sir.
that looks
Yes.
bad.
Yes,
so
sir.
I prefer to bring it out the corner of the wound.
Yes, sir. Taken,
Small
sir.
suggestion.
Taken, sir.
So thank you.
And
good
the
shot
use of Babcock's also to pull the lobe centrally.
My insisting Babcock's is if the
it
gland
helps
is
very
small, difficult to hold with a hand, then only Babcock's. Otherwise, I never use Babcock's. Smaller the gland, difficult is the surgery. Smaller the gland, more the complications. Male patient, greater problems. Treated for thyrotoxicosis, be careful for hemorrhage. There are fixed things in thyroidectomy. So when you assess the patient, keep your mind set. Yes, this is what I am going to do it.
Thank you, sir, for beautifully illustrating the key principles of thyroid surgery.
Thank you.
We are moderators, we want to talk something. Guru Shatab sir, as ever, he is very authoritative in principles of surgery. We appreciate that.
Thank you.
Sir, we do have some questions, sir.
Please, please.
Sir, one thing is, rather than question, just adding to your dissection points, lateral lobes dissection, especially lobe dissection for the PGs, it appears as though it is a very lengthy attachment there. When you don't dissect properly, few fibers you just dissect with bipolar, it gives away. The lobe will come medially and automatically you can easily enter the tracheoesophageal groove. So you can narrow down the pedicles easily. So that is the one observation. Otherwise, many people will say that thyroid covering fascia is a 2-layer. So you dissect out one layer, you keep in between. So easily it will give the way to the middle thyroid vein initially, later the pedicle. Another thing is, at the Berry's ligament, as you rightly said, always it bleeds. And you try to do total thyroidectomy, more injury. So we, in non-malignant cases, we try to leave some part, it is better in the, at the Berry's ligament rather than trying to clear it. One more is drain regarding the cautery. Of late, we are not, it is in really 5-6 years, we are not using any sutures. We are happy with the cautery, but I don't know, I'm not watching my method.
It's a surgeon's preference.
Yeah, surgeon's preference. For the PGs, better you go with the traditional methods. And drain, we are also avoiding the drains nowadays. And we have studied, we have done one study for the PGs we have given. So we have concluded that without drains is much better. Only thing, you should have the good hemostasis.
Thank you, sir.
Thank you. Thank you.
I now request Dr. Anand Ravi to kindly join the chairpersons for the next video session. Our next video presentation focuses on fundoplication, a cornerstone procedure in anti-reflux surgery.
To present this intricate surgical technique, we are honored to invite Dr. L. Ramachandra to the stage, who is the former HOD KMC Manipal. All the delegates are kindly requested to proceed towards their respective seminar halls for a free paper presentation. Tea and coffee have been served on first and ground floors.
I thank the organizers, especially Dr. Rajgopal Chanayan, for giving me the opportunity to talk to you. I'm going to speak on fundoplication. I'll not have any preliminary slide as such. Indications and all those things I'm not going to talk about. Solely it's about the video, and I'm going to present the video. Play it at a speed of 1.5. See, the camera port is in between the xiphisternum and the umbilicus, and two lateral ports. The right lateral port, subcostal in the midclavicular line, is brought across the falciform ligament you have seen. This is the fifth port, and that is the port which is coming just by the side of the, and I'm not getting the, anyway. So after retracting the stomach, this is the pars placida, the transparent gastrohepatic omentum that has to be divided. Sometimes there will be and sole replaced left hepatic artery coming from the left gastric artery. This dissection has to be continued till the hiatus. And once the hiatus is reached, you have to dissect the right crest of the diaphragm. The peritoneal reflection from the esophagus and the stomach to the right crest has to be divided. So till the proximal limit of the hiatus. So once it is reached, you can find a plane between the stomach and the right crest of the diaphragm. Now you are reaching the topmost portion of the hiatus, that is the anteriormost portion. Once the crust is defined, you can find the plane between the stomach. It is a hiatus hernia, sliding hiatus hernia with about 3 centimeters of the stomach inside the chest. You can find the stomach on the right side of the harmonic and the crust on the left side with the Maryland holding the crust. Now you can see the left crust coming in the view. That is the left crust under the Maryland. The pointer is not working. I don't know. Yeah, now I have come to the gastrosplenic ligament. I would like to take the proximal most 4 short gastric vessels with the harmonic. Nowadays I am using ligature, both are good. The advantage of ligature is the smokes won't be there. It is much lesser. So as you go proximally, the short gastric vessels, they go on getting shorter and shorter. The proximal most one will be the shortest. So you have to be very careful while dividing it. You may thermally injure the fundus of the stomach, or you may injure the spleen, so you have to be very, very careful. The blood loss will be less than 5 ml most of the time. Very rarely you encounter any injury to the vessels. So now I am dividing the reflection of the peritoneum from the left crest of the diaphragm to the stomach, rather esophagus also. Yeah. Now the mobilization of the fundus is over. Now you can make an aperture posterior to the stomach, proximal portion of the stomach. Now there is an aperture. So you pass the cruciolmi, that is ball holding forceps, and then you can bring in an umbilical tape. Yeah, that is the forceps which has been brought. So you can make a loop of the umbilical tape. This is used to retract the stomach and the esophagus. So now that about 3 centimeters of the stomach was there, you have to mobilize the esophagus adequately. You may have to go till the inferior pulmonary ligament. While doing so, you have to be very careful not to injure the pleura. If you injure the pleura, anesthetist will start shouting at you, hey, the pressure has gone up, something must be wrong. Then you should be ready to put an intercostal tube. Only once I had to put an intercostal tube because I had made a big aperture in the pleura. So you can see that is the pleural reflection. Now I'm dissecting on the left side. So all the loose area tissues have to be dissected, divided, so you will gain the length. You must bring down the gastroesophageal junction by almost 3 to 4 centimeters below the hiatus. That is the pleural reflection. So what is very important while doing so is to prevent the injury to the vagus nerve. So that is the posterior vagus. It is very difficult to injure the anterior vagus. Usually it hugs the esophagus and goes. The posterior vagus also hugs. It is very difficult to injure it. If you injure the vagus nerve, there can be stasis post-operatively. The gas bloat syndrome, all those things will come up. Now I am suturing the hiatus. If your port placements are ergonomically all right, it is very easy to suture. Anybody with moderate skills can do a fundoplication very easily. So you should put sutures so that the bolus of the food easily passes through the hiatus. So there should be a gap between the esophagus and the last suture you are going to put. The video is playing 1.5 times the actual speed. Yeah, now we have finished the repair of the hiatus. Now we pull the fundus from behind the esophagus, and once you pull it, if you leave, the fundus should not go back, and that is a shoe shine maneuver. You hear it in very many conferences, shoe shine maneuver. So you take the suture on the fundus on the left side, go through the muscular layer of the esophagus, and fundus which is brought onto the right side behind the esophagus. On the right side you have to take and then approximate the fundus. So it's a complete wrap, 360-degree wrap. It is called Nissen's floppy fundoplication. It should be floppy. There should be a gap. The food bolus should pass through the esophagus very comfortably. Otherwise, dysphagia will be there. Most of the patients of this fundoplication in the initial days will have some dysphagia till the edema subsides. For solids, they say, I'll have to take some water along with the solid food. That is fine. Over a period of time, that will become all right. If it doesn't become all right, the patient will get used to it. Some amount of dysphagia, you must tell them. This patient had LAC esophagitis, hiatus hernia. He was not able to lie down after food. Every night he has to get up and take water with cold milk. So this man was very, very happy immediately after the procedure. So below and above you have taken the muscular layer of the esophagus also. In between, I have not taken the muscular layer. You should not forget to take out this umbilical tape. Thank you very much. Any questions, most welcome.
Floor is open for discussion.
Good evening, sir. I'm Dr. Kapil from iGot Bangalore. That's an excellent video. I agree with everything that you do. One small addition, what we do differently is, after we take the wrap, we take a Polian stitch of the wrap onto the crura. Because we've seen that post-surgery, sometimes these crural stitches give away. One, if you fix it, you're sure...
No, you take a stitch on the wrap and then to the crust.
Yes.
The problem here
there is a standard description even in Shackelford which says that the wrap has to be fixed below the diaphragm onto the crura. So that is one thing that we would do. And second thing is, what I would like to do, I mean, at least for the benefit of the PGs is, whenever you're opening the lesser sac, make sure that there's no vessel there. Sometimes, up to 1/3 of the patients will have either an accessory or a replaced accessory artery there.
Yeah, I mentioned about it.
Yeah.
You have to be very careful about that. I have got the video of replaced left gastric artery also.
Yes.
You have to make 2 windows in that.
Correct.
One window
It makes it
above
more
that
challenging.
and one window below that. It will take about half an hour extra.
Exactly.
But it is not all that difficult.
Yes, sir.
Yeah.
Yes. Thank you.
Thank you, sir.
About the wrap being fixed to the crus, if there is a very large hiatus hernia, I do that. In fact, last day before yesterday, I did one large hiatus hernia. I fixed the esophagus also to the crus. 1 stitch on the left side, 1 stitch on the right side. Because large hiatus hernia esophagus is a bit shorter. So pulling it down is difficult. You have to mobilize till the inferior pulmonary ligament. And after that, 1 stitch serum, rather muscular layer to the crus on either side you put, and then wrap also you can fix it to the crus. Okay.
One more thing for the benefit of the PGs, if they ask, if you can't mobilize 3 centimeters of the esophagus, there are some bailout procedures for that?
Pardon?
You
No,
have to-
if
Yeah,
the
you can
short.
cut the anterior end of the hiatus
Correct.
a bit,
Correct.
and then suture it from behind. You will gain the length.
Yeah.
You will gain the length in the sense the diaphragmatic hiatus will move up by a centimeter. That's what I do. I mean,
Also,
if you have got any other tips, you tell me.
Also, you can cut the vagus nerve. You will get some more length.
Please
I
don't
won't
do it.
that. I won't do that.
Don't do it. Please don't do it.
They'll
You will
come
land
back
up
and
in
make your
problem.
head.
You'll have to do another procedure
You know,
later.
the things of bloating and all those things are more of a temporary phenomenon.
No.
There's something called
I
as-
would not like to cut vagus. I never had to cut the vagus. In case you are falling short of the esophagus, then you can do Lee Colis gastroplasty.
Yes.
It is not difficult. It is not difficult, I am telling you.
I was coming for that.
You can put a circular stapler on the fundus about 3 centimeters below the angle of his, and then over that you can put a tri-stapler, Covident tri-stapler, that curved one will be there. You can put through the hole which you have made with circular stapler, and then put a
standard
stapler. That is a Lee Colis
Gastroplasty.
gastroplasty. That is easier. Never cut the esophagus for God's sake.
Vegas.
Sorry,
Thank
never
you,
cut the
sir.
vagus for the
Vegas.
God's
Yes.
Thank you.
Thank you.
Thank you.
Any other questions?
Thank you, sir.
As he said, fixing the wrap to the diaphragm.
Yes.
Again, so you usually fix the wrap.
I fix it for a large hiatus hernia, because if you fix the wrap to the diaphragmatic hiatus, one problem can occur. Esophagus may retract and the entire the wrap will come down. So that is the problem. So I would not like to fix it unless it is a very short esophagus or you have pulled too much, large hiatus hernia is there. In that event, I put a stitch on the esophagus to the crus also, if I have to put the wrap to the crus.
Thank you, sir.
Any question? Okay. Thank you.
Thank you, sir, for simplifying such a technically demanding procedure.
Thank you very much.
We now request Dr. Guru Shantappa Yellagachin and Dr. Ramachandra and our chairpersons to kindly proceed to the photo booth for photographs. And I request Dr. Satyamurthy Aitala to hand over their certificates of appreciation. We now move on to a session that discusses the art and challenges of a routine yet deceptively complex procedure like in Steen's hernioplasty. Common surgery, yet not easy.
To share insights on this topic, we invite Dr. Shilpa Suresh Huchanawar, known for her excellence in abdominal wall surgeries.
To chair this session, we invite Dr. Satyamurthy Aital, Dr. Prithvi Shetty, Dr. Prabhu, and Dr. Rekha V.S.
A very good evening to all of you. At the outset, I would like to thank the KSCASI officials and the organizers of the 8th MidCon, Kanachur Institute of Medical Sciences, for giving me this opportunity to present my video here. I bring greetings from Karnataka Medical College and Research Institute, Hubli. I'm a professor there working. And finally, the postgraduates, you can come to a surgery where you are more familiar with, and probably the most common surgery which you do in your routine OTs. So kindly let's go on with the video. The most commonly performed surgery nowadays for a symptomatic inguinal hernia is a tension-free Liechtenstein hernioplasty. So we in our institute do it only for symptomatic hernias. Okay, asymptomatic hernias we never operate, especially for direct inguinal hernias, and very small indirect inguinal hernias, we do a waitful watching. So what we do is a symptomatic inguinal hernia, probably coming more often with pain, and that's where when it's an uncomplicated hernia, where we go and put a mesh. But for complicated hernias like obstruction, strangulation, incarceration, or for the matter of a perforative peritonitis, we never put a mesh. We have other types of tissue repairs. So I'll show you a very simple hernioplasty. They say that when you watch a surgeon doing a hernia meshplasty, that itself defines how skillful the surgeon is. So it all depends upon how you, because this is one of the first surgeries you get in your postgraduate as one of the first surgeries. So kindly just pay attention to this anatomy. What our speaker previously presented was a very complicated posterior anatomy of the inguinal canal, where we have a very complicated posterior anatomy when we do a laparoscopic inguinal repair. We don't have the angle of doom, we don't have angle of pain, the canal of death, nothing, but you should have a very good anatomical knowledge for the inguinal hernia. Please start the video without the sound. So this is the inguinal crease. Sorry, this was the video taken 2 weeks back, and all courtesy goes to my postgraduate, graduate Dr. Pragnya. So if it is a good video, please acknowledge her. If it is a bad video, blame me. Okay, so this is the incision. This is the anterior superior iliac spine. This is the pubic tubercle. This is the inguinal crease. So about 1.5 to 2 centimeters or 2 finger breadths below the anterior superior iliac spine, you take an incision around 5 to 6 centimeters or 8 centimeters, just short of the pubic tubercle. Open the skin. While you're opening the skin, you come across 2 important vessels, the superficial epigastric vessels and the superficial external pudendal vessels, which I have ligated and cut because of short of time. I had to just skip those slides. So once you incise the superficial fascia, that's the Scarpa's fascia, you divide the external oblique in the line of the fibers, and then you palpate the pubic tubercle. These are the cord structures here. So you palpate the pubic tubercle, and in flush with the pubic tubercle, you lift the cord and the cord structures, and there will be anteromedial to this, you will find the hernial sac once you open the cremasteric box. So this is what I'm trying to show in with this, that's a posterior weak wall. Now once this is the opening of the cremasteric box, once you open the cremasteric box, this is how you open it inferiorly and superiorly. You dissect using blunt dissection and sharp dissections the sac. This is a pearly white sac which is defined, and then you can always, the whole of the sac need not be dissected up to the bottom of the scrotum because of the lot of edema and the bleeding. So you divide the sac in between, okay, and then the rest of the sac you have to lay it open. Very important to lay it open because you have to prevent the hydrocele of the hernial sac post-operatively. There is no need to dissect the sac completely up to the bottom of the scrotum. So this was a complete hernia, so this is just left as it is. This reduces the amount of pain and inflammation in the post-operative period. Then you have the proximal sac, which is a lot of omentum is there. You can ask the patient, you can ask the head end anesthetist to slightly do a head high position, or you twist it so that all the abdominal contents are reduced. And then this is the standard method what we were taught when we were in the postgraduates. Take a transfixin, the suture at the base of the incised sac. I usually prefer to double ligate. I was taught in KEM, so I always double ligate the sac. Once the sac is double ligated, the extra part of the sac is incised with either with the cautery or the sharp scissors. Okay. So I take one more suture, doubly ligating the sac. And now I have a weak posterior wall. I have a weak posterior, okay. Now I'm dividing the sac, the extra amount of the sac, and the sac naturally gets into the peritoneal cavity. Now I have a weak posterior wall. I would like to do a plication of this weak posterior wall. Clinically, he didn't have a direct hernia, but on table, I will see that there is a weak posterior wall. So I will start plicating the weak posterior wall with the 2,0-proline, come from the pubic tubercle to the few fibers of the conjoint tendon and the inferior part of the iliotibial tract. I will go on plicating it in the form of a dun, not taking the posterior wall of the sac. You have to depress the posterior wall with the back of your forceps and approximate the conjoint tendon, that is the internal oblique and the transverse oblique fusion to the inguinal ligament below. So this is continued up to the deep inguinal ring. Till the deep inguinal ring, enough space has to be left. They say a little finger space is left so that you do not obstruct the spermatic, these vessels and the cord and cause ischemia. So you have to hold it and tie it there. This is how you plicate the posterior wall. Yeah, once you plicate it, you start putting the mesh. Usually we use lightweight meshes. So the mesh ideally should be placed at least 1.5 to 2 centimeters beyond the pubic tubercle on the rectus sheath. Okay, no need to take a periosteal pubic tubercle, because nowadays it is not done because of the high incidence of post-operative pain, that is because of osteitis pubis. Then posteriorly beyond the cord, it should be placed at least 2 centimeters. So inferiorly over the over the reflected part of the inguinal ligament, you start putting the continuous sutures. This is how you put the continuous sutures over the inguinal reflected part of the inguinal ligament here. Once you have come to the end at the near the inguinal deep inguinal ring, you have to place your mesh, dividing the mesh approximately how much it is, and then put the mesh all around, creating a space for the cord structures, and then place the mesh all around here on the conjoint tendon with around 2 to 3 stitches, with 1 stitch beyond the cord. This is how it is placed. Once this is placed, you have to close back the layers what you have incised, especially the external oblique and the Scarpa's fascia. So this is how you take sutures near the deep inguinal ring. I'll be open to questions. It is just showing the placement of the mesh. Okay, then I will cut it in the line of just so that it is placed posteriorly to at least 2 to 3 centimeters, and it is placed properly posteriorly as well as on the conjoint tendon. The extra mesh, I'm cutting it so that it is placed properly on the posterior wall without any folds. I do not cut the ilioinguinal nerve. I always keep it along with the superior leaf, okay, along with the fascia attached to, because it comes posteriorly, pierces the transversus, goes in between the internal and external oblique, comes out of the external internal oblique, then comes to the superficial inguinal ring. I do not devascularize it by taking it out, but some people even cut the ilioinguinal nerve because of post-operative mesh, because of mesh encasement and post-operative pain. But I usually don't do it. So then the superficial fascia is closed. Then finally the skin is cleaned and closed with, I put staplers here, but you can always close it with a subcuticular incision. Thank you.
Doctor, good surgery, nice demonstration, but I beg to differ with you. You do not do any tissue repair in a Lichtenstein's, in an indirect sac. You're introducing the tension. So you're losing the tension-free hernioplasty.
Okay.
So what you have to do is, if you have an indirect sac with a large ring, you close just a little repair of the deep ring. And don't do any tissue repair of the tissues. If you have an direct sac, which is a bulged posterior wall, you can then plicate the posterior wall to help you to put the mesh properly. But tension-free hernioplasty does not involve any
suturing application of the posterior wall.
Okay.
Well taken, sir. Yes.
No, thank you, ma'am.
Thank you, sir. Thank you so much.
If there's no other question per se, thank you, ma'am, for showing this video in a kind and lucid manner.
Thank you, ma'am, for unraveling these complexities of hernia repair. I now request Dr. Shilpa Suresh and our chairpersons to kindly proceed to the photo booth for a group photograph. And I request Dr. Savita Kalwar, Consultant GI Surgeon Mudhol, to kindly hand over the certificates. We now transition to the last panel discussion for today evening, after which we'll have the paper presentations. It is an interactive and clinically significant panel discussion on post-operative intestinal fistula, a complication that challenges even the most seasoned surgeons.
To moderate this session, we are pleased to invite Dr. K. Jairam Shenoy, a stalwart whose expertise in complex gastrointestinal surgeries is widely respected.
To be a part of this distinguished panel, we invite Dr. Mohammad Shafi, Dr. Prem Kumar, Dr. Nagaraj Bhalki, and Dr. Kapil Kishore. Dr. Sunil will be a part of the panel discussion on behalf of Dr. Nagaraj Bhalki.
You can. Yeah. No, this pointer.
At the end of a tiring, delayed session, you see a lot of fatigue in the hall itself with the empty. So let me thank the organizers for inviting all of us. On behalf of my team of professors, I thank everybody, the Karnataka State chapter of the ASI, the organizing team, for this honor of conducting the panel discussion. This is on a very complex, demanding topic, as anterocutaneous fistula. This is a vast topic. Probably this would require a half a day, if not a full day. So, as a postgraduate, I am told the midcon focus is on the postgraduates more than on the qualified surgeons. So that being the case, we decided to restrict it to specific aspects to avoid confusing the PGs. This is mainly to equip them with how to face a complex fistula. And for the practicing surgeons, it's a scourge of a practicing GI surgeon. No one would dream to have, but everyone will have sometime or other. Something like in connection with some other condition, it's told only two kinds of GI surgeons, those who did not have a fistula, or those who are going to have a fistula, something like that. So post-operative, we are dealing with a specific here. I have a panel of senior professors, Professor Prem Kumar from Bangalore, Professor Mohammad Shafiuddin from Gulbarga, Dr. Kapil Kishore, again from Bangalore, and Dr. Sunil Krishna from Manipal. So I already said this is a very complex fistula. The etiology involves the deformed one from birth, that like the vitellointestinal duct, or a diseased bowel, like the Crohn's disease due to inflammation or tuberculosis, some infection or infiltration by the cancer or some. And then the damaged one, either an external wound or internal wound, irradiation, accidental, incidental, some kind of injury. And then we talk of the iatrogenic trauma. For all these, we talk of one cause, two causes, but when it comes to postoperative enterocutaneous fistula, it's a complex one. It may not be due to the surgery itself, or it may be because of the surgery itself, or a combination of that. All that put together, ECF becomes a very, postoperative enterocutaneous fistula becomes a very intriguing one. So we are going to discuss the what, the why, and how of postoperative enterocutaneous fistula. And then probably we touch upon, so what? What if there is one, how to approach and how to go about, or how to overcome a problem. This will be the highlight. We'll try to be as brief as possible. I will start with Dr. Kapil Kishore. I request him to tell us how we will face a patient approaching the hospital with history of, or in the hospital itself, a fresh patient after surgery, a post-operative, post-abdominal surgery patient presenting with a pouring wound. How will you evaluate and initiate the evaluation of a patient, even as you assess the risk factors and assess the threat to life, because ECF can be a threat to life.
So for the PGs, whenever you see a patient where you're suspecting it to be an EC fistula, enterocutaneous fistula, always begin with the history. What type of surgery the patient has undergone, whether it was an elective surgery or an emergency surgery, because the things are different. Second thing, you need to see whether it was a laparoscopic surgery or open surgery, because in laparoscopic surgery, inadvertently, if your ports are there, you may injure the bowel somewhere. That is second. Third, always speak, if the patient is referred to me, I would always speak with the referring physician to see what were the intraop findings. Was there any pus there? Was there any features of Crohn's there? So always speak to the operating surgeon to know what are the intraoperative findings. Then you have to take the history, whether it's an early presentation or a delayed presentation. Then look at the general condition of the patient and also reassess the history of any previous history of tuberculosis or Crohn's, or the patient has been on any immunosuppression. All these form a part of the initial evaluation of the patient. And then when you come to the wound per se, you have to look at the wound, where it is located, what is the nature of discharge, and the amount of discharge. This needs to be quantified, because as you're trying to manage these patients, all these factor in. Also, most importantly, look at the skin. How is the skin around the tissue? That will give you a fair amount of impression of what you're trying to deal with. The next part of it is, how do you assess the threat of life? Threat of life, this is the most important thing as a clinician that you need to assess. Whenever you see an EC fistula, you don't know how long it has been there, the patient comes to you, your immediate priority is to make sure that the patient has no sepsis, there is no malnutrition, and there is no fluid electrolyte imbalance. This is most important. So again, the sepsis 6 protocol has to be kicked in. You need to check for the fluid electrolytes. You need to make sure there is no pedal edema. Pedal edema in this patient is a very broad thing. You need to start looking for that. And always when the patient is hypotensive, start IV fluid challenge. Once the fluid challenge is given, the heart rate, if it comes down, then it is fine. Otherwise, these patients require ICU care for intensive monitoring. This is how I would do the initial assessment, sir. What was the other question? The risk factors. Again, you can divide these risk factors as patient-specific risk factors, disease-specific risk factors, and surgeon-specific risk factors, which we'll be describing in the subsequent slides.
Professor Shafi, would you like
Having
to add?
said that Dr. Kishore's advice, my simple advice to the postgraduate, during post-operative rounds, after 48 hours, if patient complains, pain, fever, then when you examine, when there is a tachycardia, first thing is that you should open the operative wound and observe for that. If there is any ooze, open a one stitch there and see that the content is very, very important. If there is a pus, you should think SSI, surgical site infection. If that is pus is mixed with some bowel contents, then you should suspect. The history always you know that what surgery they have gone. The simple way, if you are doubt, then you send that the discharge for analysis. One. Then what next?
Will you send every patient to the ICU?
No, no. First I will see in post-op ward. First I would like to see that when assessing that patient, the risk factor we know that cause of the disease, operated site, whatever that. For them, I would like to tell one algorithm or mnemonic in ECF, that is SNAP. SNAP, S-N-A-P. Sepsis, rule out sepsis, then nutrition, then anatomical location, then plan. So now we are in the first step that we have to rule out the sepsis. And otherwise all factors what is sir is said, we are along with them.
Yeah, we'll move to the next question. Professor Sunil Krishna. How will you institute initial management of a patient with the post-operative intracutaneous fistula?
Yeah, already continuing the whatever the previous one. Okay, the history is very important. Okay, so whatever they said, once we have some idea about the fistula, like we have like whatever they said, go through the OT note, go take a good history. One more mnemonic which we always have to have under mind is friend. So foreign body, radiation, infection, inflammation, epithelialization of the tract, then neoplasm and distal obstruction. These are the things also in a brief history we need to know whether these things are there in the history or not. So once it is done, you are sure that it is a fistula, the intracutaneous fistula, maybe a post-operative which we are discussing now. The initial management is, initial challenge is, we have to concentrate three things. One is electrolyte imbalance to be treated, nutritional things to be treated, control of sepsis. These are the three things. Rest all we can, anatomy, everything is a later part. Now electrolyte imbalance, there are a lot of fluid losses are there. When the fistula is proximally, the fluid loss is more. When the fistula is distally, the fluid loss is less. So for an example, jejunal fistula will have a, jejunal or duodenal fistula will have a more fluid loss. The fluid loss is significantly causes hypokalemia. Due to that, kidney will try to preserve the sodium and the serum sodium hyponatremia will be there. Bicarbonate will be excessively lost and patient will have a metabolic acidosis. So we need to correct the fluid hypovolemia also to be corrected, and these patients will have a anemia that has to be corrected. Anemia, hypovolemia and all the electrolyte imbalance to be planned in the initial management. Then second one is the nutrition. Check the albumin. Already Dr. Kapil has spoken to you regarding the albumin level and pedal edema. So check the albumin. Make sure that nutritionally patient is not deteriorating. Make sure that nutritionally patient is planned. Now nutritionally, either in the initial period we try to give a total parenteral nutrition because we want to deflate the, we want to put a rice tube and deflate the proximal part of the gut, and probably so that's why TPN will be considered. Gradually we have to plan for a enteral feeding as well. Either is the proximal fistula is there, we can plan for a distal enteral feeding as well. All these patients initial, one more thing which I forgot is, all these patients initially to be catheterized and urine output to be measured. Make sure that urine output is at least 0.5 ml per kg for these patients. The output should be good, then only the hypovolemia you can see whether the patient is electrolyte imbalance and nutritionally patients are. So TPN to start with, gradually you have to plan for a enteral feeding as well. TPN has got its own adverse effect and side effects also. Then control of sepsis, these patients will have a probably gram-negative coverage and anaerobic coverage should be given, and if at all there is a localized abscess, that to be drained and sent for a culture. Subsequent culture, the organism can be considered to change the organism whenever the culture report comes. These are the initial things which we are planning. So I repeat, electrolyte imbalance, nutrition, as well as the control of the sepsis is a main thing which we have to concentrate. Now coming to the nutrition, which I forgot to tell you, Before that, in the initial management, we need to categorize these fistula patients into 3 categories. Whether they are low fistula, which is less than 200 probably 200 ml per day, and moderate fistula 200 to 500, more than 500 is a high output fistula. Because high output fistula, you need to step up your need of that calories. Probably these patient needs at least probably 30 to 35 kilocalorie per kg per day as compared to the low fistula. Whereas in the protein intake also for these high fistula needs around 1.2 to 2.5 gram per kg per day intake of protein as compared to the low fistula. So categorize the fistula, plan your electrolyte balancing, plan your nutrition, and control the sepsis and follow the culture and sensitivity reports. So,
Professor Prem Kumar will add. If any.
That's a good coverage from Dr. Sunil sir actually. From my side actually for the postgraduates, remember I want to add on that in the early stage only just start a central line. I think that is which we are all talking about sepsis, hypovolemia and all those things. Remember to start a central line in the beginning itself, and try to include a nutritionist in your team. We are all talking about sepsis, nutrition, all those things, and generally we have specialists in that. So I think I would suggest, if at all they're available, try to add in your team. Otherwise, I think Dr. Krishna has covered most of the topics and nothing much from my side.
You see any role for any invasive investigations here?
To begin with, I think we should have a low threshold for investigations in these cases. As sir was telling, we'll open up the wound prior when we suspect. That's good thing what we all do. But we have the sonogram, which is very easily available to start with. So low threshold for investigations is what I can add on, sir.
The next question, Professor Mohammad Shafiuddin. How to get at the anatomy and pathology? These are vital of an ECF, but in post-operative setup particularly. Yeah, anatomy and pathology of it.
To locate the anatomy, one is physical, the secretion or what you got ECF, we can have analysis of ECF. Depending upon that, you can make that sodium, potassium, bicarbonate and chlorides. That combination, it will show that is it a gastric fistula or it is a upper GI fistula or a lower GI fistula or sometimes pancreatic fistula or biliary fistula, depending upon analysis, one simple one. Second one is you can have ultrasound, one is to locate that, and the previous history of surgery we can take into consideration, and depending upon that risk factors, for example like Crohn's disease, radiation, you will come to know that what type of fistula you are going to get or it is present there. Then role of imaging, role of imaging, that is radiological imaging. In that first simplest is the fistulogram is the best one. Only the higher investigation that radiological like CT, MRI, only then when there is a role of when there is a sepsis, then you have to locate the abscess cavity or peritoneal cavity collections. All these you have to rule. There the CT and MRI has got. In laboratory investigations, in blood investigations, you have to go for serum transferrin and albumin and what you call thyroglobulin binding proteins, pre-thyroglobulin binding proteins. These are the basic investigation that will give guide to the what type of fistula, what is the content of the fistula.
So just to this thing, you are seeing a patient on POD5, you're suspecting a fistula. When would you get, when do you start thinking about imaging for these patients?
That's what, the content of the fistula, depending upon the content of the fistula. If there is a ileal fistula, you get fecal matter, or colonic fistula, you will get, then you will get clearly you will get, and you there, and we categorize, you should see that it's a low fistula, volume fistula, or high volume fistula. So then depending upon that, the first investigation role is only the fistulogram at the most.
Exactly.
Maximum you can do it. No role of CT, MRI unless there is a sepsis.
So the plan, how I would do it is, if I see a patient on day 4, day 5, I will wait for at least a week's time, I will not jump in to do these confirm or rule out fistulas as long as the patient is not going septic.
Yeah, the message is clear.
Yes.
If there is a downpour or outpour,
Yes.
you don't rush.
Rush. Yes.
So stabilize the patient. Priority is on stabilizing the patient.
Just get an ultrasound in the initial phase
Yes,
so that there are no
ultrasound will,
collections
yes.
anywhere.
Non-invasive. Bedside, non-invasive.
Yes.
Yeah.
And once this is done, get a CECT either with a positive oral contrast, or if you're suspecting rectal, give a rectal contrast also to define the anatomy of the fistula. That is how I would put it.
So the next question is to Professor Prem Kumar. He will tell us about non-operative management of a post-operative ECF.
Yes, sir. I think this is quite an interesting topic for most of the surgery postgraduates who are very inquisitive to operate. So when we put non-operative, doesn't mean that we are just keeping your fingers crossed and waiting for it to close, but rather actually there is a active, structured, a multidisciplinary process which is going on behind this term of non-operative.
This is the time the surgeon does not sleep.
Yes, does not sleep, but it appears that we are just not doing anything, but we are doing plenty behind that. So remove there some, let's use the term, few killers behind for these patients who die. That is, number one is by the sepsis, which is we all are talking actually. And second, we have the malnutrition, which is generally happens for these patients. So to begin with, actually, sir mentioned that an approach called as a SNAP approach, which generally is followed actually. It's a UK-based approach that is to begin with is sepsis, then comes your nutrition, then anatomy, and the plan of action for the patient. Here we can actually further divide this management of non-operative into 3 phases. Number one is the stabilization phase to begin with, that is 0 to, let's assume 7 days or first week. That is, we stabilize the patient. Patient is generally in the shock and all. We resuscitate, hypolemia, hypokalemia, hyponatremia, all this is corrected. Then comes your optimization phase, which goes on for at least 6 weeks. That is, we try to maintain the nutrition of the patient. We ensure that the patient does not deteriorate and henceforth. And then finally, we come to the last phase, that is where the decision-making phase, that is beyond 3 months. At least 3 months we wait for if the patient does not deteriorate. Please keep this in mind. If the patient deteriorates, sepsis is increasing, peritonitis, of course, we plan to open up. But if the patient does not deteriorate, we can wait minimum up to 3 months or up to 6 months to take a decision whether to intervene surgically or just wait for it. Most of the patients who have low output fistula, they tend to close, around 70% of them close spontaneously, and only 30% who may have the high output, we might require a surgical intervention. So this is the main key for the management of the non-operative management of the ECF.
Yeah, I fully agree, whatever the non-operative. In addition to that, to add on to that, there are some pharmacological drugs which definitely won't help in the closure of the fistula. Probably that output of the fistula will have some control over the output of fistulas. For an example, somatostatin analogs, octreotide, there's one drug which probably decrease the output. Definitely, it is not a treatment for any fistula. Fistula won't close with that. So some pharmacological drugs, one is a octreotide, which can be considered. PPIs can be considered up to 40 to 80 milligram per day can be considered. Some of other drugs, probably loperamide, can be considered probably in a high output fistulas where a patient may not go for a significant nutritional deficiency and electrolyte imbalance. Loperamide will act temporarily, and you can give up to probably 60 milligram per day. Loperamide can be considered. Diphenoxylate, one more drug which can be considered. In recent article I have seen amitriptyline also, probably it decreases the absorption. Probably amitriptyline also has got some role in probably the decreasing the output of the fistula, especially in a high output fistula. Probably those who are having a Crohn's, underlying Crohn's, cyclosporin has got some action, infliximab has got some action in reducing the output of the fistula. Otherwise, whatever the non-operative should be follow all whatever the other.
Dr. Sunil, just touching upon that role of octreotide, when would you think of starting that? And after you start, how would you decide whether it is helping or not?
Actually, very interesting topic actually. Now, octreotide, you need not continue. If the output is not at all reducing, the octreotide role is only for a proximal fistula, and you start for a couple of days. If the output is not decreasing, there is no role of continuing the octreotide. You can discontinue the octreotide also.
There has to be at least a 30% reduction in the fistula output after 48 hours of giving it.
After starting the octreotide.
Yeah, that is very important because otherwise you're just
Stop
throwing
it.
the money in the water.
Stop
the patient
it.
is not getting benefited.
Yes.
Even the complications of octreotide like cholecystitis, gallstone formation, all those. That's the reason ideally we give for 48 hours. If the volume of the output is decreased, you continue. Otherwise, stop it.
And again, just for the benefit of the residents, it is a warning. Never ever give a bolus of octreotide because I nearly landed up in trouble because it was about to be given many years ago. Suddenly I came, then of course there was the usual blast of all those things, theatrics, because the pharmacology, read pharmacology before reading. Don't go by the rep's recommendation because you see as an infusion which is running at a very slow pace, and a bolus can straight away lead to a cardiac arrest. Remember, this has to be remembered.
And that octreotide, more so, or it is helpful in pancreatic
Yeah.
fistulas rather than other.
Dr. Sunil pointed out that it is a proximal fistula. Exactly. It's believed to reduce the secretion. As Dr. Kapil put it, if it is not coming down in a short time, there is no point in continuing.
I think low volume fistula need
Yeah.
not be
Need
panic.
not be.
Need not be
This is only
panic.
for
Maintain
high
electrolyte balance, hydration, nutrition. It will close within 4 weeks, 5 weeks. If
So
doesn't
we'll go to the
close,
next question now. Local care, fistula care, we call it.
Yes. Yeah.
Yeah. More of skin.
Care of the local management of fistula. has
Local
got a
management.
Local management of the fistula is very important whenever we talk about the skin excoriation. This fistula, especially the proximal fistula, it is more about watery content, will seep through the skin, and skin excoriation is the one which is really irritating to the patient. So what we have to concentrate is, instead of that, make it as a control fistula and make sure that whatever that it is not coming into the skin contact, and make sure that it gets collected in the bag. By that you can measure the output also. There are a lot of things are there, like zinc oxide paste can be considered around the skin. By that the skin excoriation can be reduced. Okay, then coloplast can be applied. There is a vacuum assisted dressings where it will place the around the stoma, around the fistula opening, remain the skin will be with the coloplast, and it will be controlled fistula into the bag. Even in a vacuum assisted, you can put a separate tubes onto the skin surface. By that, none of the skin secretion which is coming through from the fistula won't get in contact with the skin, and it will be connected to the separate bag. So these are the things we should be careful about. This skin management is very important in a proximal fistula as compared to the distal fistula. Distal fistula may not have a skin excoriation as much as compared to the proximal fistulas. And already we have discussed, try to have some control of the output also. You try to reduce the output of the fistula by using some pharmacological drugs, whichever is helping to the patients. Anything?
the local management most, however, is the skin excoriation. That's the most important thing to prevent. So for that now readily available some of the pharmacy, there is adhesive bands and transparent what you call CGF grafts layers are there. So in my experience, the best one is the zinc oxide or silver paint. We put it and observe, and regular change of, and keep a stoma bag there. It will collect. Then same time you try to see that the distal part of the bowel is properly working or not. That is also included. If there is a what you call obstruction there, or some diverticulitis or some Crohn's disease or distal part, then you have to manage in a different way.
Will you insert any tubes like
there is a chance of using nowadays the nephrostomy tubes they are using. The size available like 18 to 32 centimeters. So depending upon the output of the fistula, you can plan the nephrostomy tube. They just cut the end of the nephrostomy and made make a one hole, a 2 centimeters side hole on the nephrostomy tube, and you bring it out. You can collect that in the separate bag. So that is one more, they are trying that, and it is a good one, simple way.
So we'll move to the next question there.
Yes, sir.
Yeah. This is Professor Mohammed Shabir. This is about resurgery. When do you decide and why do you decide on resurgery? When do you go in? When it is an emergency or after waiting, whatever. What about the decisions to reoperate?
See, first of all, the principle in ECF surgery, role of surgery, immediate surgery is not advisable unless otherwise there is a sepsis or collection of abscess in the peritoneal cavity or peritonitis, then immediate surgery is required. Otherwise, what happens, you will land up in a big problem. When there is a small one, you can make it a big issue. That. So wait, if there is no sepsis or no source of infection in the abdomen or peritonitis, then you can wait and plan for depending upon the output of the fistula. So usually the ileal fistulas, I think you wait at least 3 to 4 months. That's what they say, 40 to 50 days ideal period there. Because there are so many studies there, immediate post-op, if we operate, if there is sepsis, it is good. Otherwise, what will happen? The mortality rate will double. They say that if you operate in second week, third week, the mortality is 20% almost. It increases. There are a lot of studies. So better control, you maintain hydration, nutrition, electrolyte balance, and weight and advice. So nutrition in the form of like oral and parenteral.
I think I very much agree. That is, it is not that we are going with a definitive plan, but rather as just to save the patient, because we try to maintain a non-operative management and wait for the healing of the fistula. But if we are left with no choice that the sepsis is increasing and it's gone for peritonitis, luckily most of the collections can be managed by your percutaneous drainage.
Yes, conservative.
Yeah, conservative. But some cases do deteriorate, and such patients, of course, even as a last resort, probably will just try to go inside the abdomen and try to control the source of infection. But of course, the rate of mortality is definitely steep, and bad outcome is expected, sir.
No, what he said is best. One point I would like to add, that collection of pus, that is a abscess. When you are draining, you can drain ultrasound, and same time they say that you can add a water soluble dye into that. When you put a pigtail or something catheter, when you come out, even that will delineate the fistula tract, that dye.
Sure.
So that will help. What you said is, that's a good one, non-invasive.
No, because I have not separately created a section of question today for want of time. There's a 40-minute one about the interventional procedures. You can add that if you, interventional procedures, non-operative, short of surgery, any interventional procedures. You can.
So that will locate that, sir.
Yeah, sure. Yeah. Kapil will tell us about the principles of surgical technique.
Brief principles, again, they are the same. Make sure that there's no sepsis, there's no malnutrition, and the patient has got no electrolyte disturbance. Once this is done, then what is the challenging thing is, you have to make sure that the treatment is individualized for each patient based on the location and the output of fistulas. The 3 R's, the 3 goals of the fistula surgical management is always resect, resurface, and restore. When I mean resect is, these are our fistulas which have already been established. They are not settling down with conservative management. So the fistula tract along with the adjacent bowel, the unhealthy bowel, has to be resected. You have to resurface the fistula's opening site on the skin as well as restore the continuity. This is important. And also what you have to do is, whenever you're doing these resections, especially for these Crohn's fistulas, always make sure that you're not resecting or removing more than what is necessary. Do the bare minimum, make sure the patient is optimized, make sure the patient has got good nutrition, make sure that the patient has got good antibiotic coverage. That takes away. And most importantly is, you need to have a good preoperative plan. And in some cases where there's a bad battle abdomen, don't do extensive adesholysis. Go in, solve this problem and come out. When you try to do more of adesholysis to clear this bowel, that is when you will have the trouble. Get a good contrast CT, make sure that the distally the contrast is going, go in, resect the bowel and come out. This is how I would do it.
This question is mainly based, I think, probably once the patient is initially managed and patient is fully stabilized, and we are pretty sure that this fistula is not going to cure with the conservative management, it has to be operated. So these patients, we can choose a time. Best times to be chosen before going ahead. One is nutritionally. Albumin should be constantly on a higher side before planning for any surgery. What Dr. Kapil said is correct. Unnecessary adesholysis and all should not be done. That diseased segment of the bowel should be completely resected before going in. Get a proper imaging, even an endoscopy, if at all it's a colonic, to rule out any underlying malignancy, underlying inflammatory condition also to be ruled out. It is individualized. These surgeries are individualized. It is not for one-sided. It is individualized based on the patient. Lot of comorbidity, patient's underlying disease, everything to be considered, everything to be evaluated, and we have to plan once the patient is fully fit as nutritionally also.
Should it be only resections, or is there a role for bypass, depending on this location? Do you see any role for any bypassing the site of the fistula?
So as long as that fistula is there, the fistula has
No,
to
we-
be resected.
Yeah.
There is no role of bypassing in these cases.
Yeah.
And one more thing, just to touch upon, there is always some attributing factors. Example is, you use a mesh, there is a fistula. You have to be prepared to remove the mesh. This is one thing that you have to remember.
Anyway, we'll come maybe at a later stage.
Yes,
We'll,
yes.
if time, yes.
I think bypass surgery is available only in duodenal blowout, subduodenal fistulas, where they give GJ and bypass that part of the duodenum. That is going to help there.
Even an acute fecal fistula at times, either role for a small bowel to the distal large bowel bypass.
It depends upon the disease. That radiation bowel is there, post-radiation bowel or diverticulitis.
Yes.
In
The
such
technique, the principles of the surgical intervention may change according to the pathology of the condition.
Yes.
Yeah, that's fine.
By doing only bypass, definitely that fistula is not going to heal. Probably the output of the fistula may
Not to buy time. If the patient's condition is bad,
yes, condition is really bad.
massive resection is
Yes.
going to be deleterious to the patient's
then-
interest.
yes,
That
yes.
may be something like a middle path.
Yes, yes, sir.
Yes.
Sure.
Yeah. Yeah, exactly.
Control fistula.
So we will go to the next question now. This the preventive aspect. How do we generally a post-operative? No one wants a post-operative ECF. Is there any way we can minimize the risk of this, knowingly or unknowingly? It should not happen. So whatever is known, we can take the steps to reduce the risk. Professor Prem Kumar will tell us about.
I think this is the most important question of all this panel discussion, I feel, sir, because the mortality rate is very high, maybe from 5 to 30%. It can vary in high output. So prevention is not an ICT, but maybe a must actually. So for this grave condition. So to begin with, actually, I will not start with just an intraoperative way to prevent a EC fistula, but rather a pre-op, that is ensuring that some factors which are fixable, fix it. For example, we're just talking about albumin. If the patients, if it's an elective procedure and albumin level is low, don't try to take up the case. First, stabilize the patient, increase the albumin level, control the comorbidities like the diabetes mellitus. Ensure that the patient is quite optimized for the procedure. So don't just jump to for the residents, this is purely that. Don't think that is just your the art of surgery, your skills which matter, but the pre-op optimization, which is a very important factor. Coming to the intraoperative, ensure that the main thing is the perfusion of the cut edges, which we always say when we do an anastomosis, because most of the cause for these EC fistulas are from the anastomotic leak or the mist or the iatrogenic enterotomies which has happened. So for the anastomosis, ensure that the cut edges are bleeding well. Nowadays, we have a new technology of the immunofluorescence which can be ICG, which you say, which can
Make
be
sure that-
used if it is available in your center to ensure that there is good blood flow and so on. And post-operative care is also as important, and be very cautious that if the patient is deteriorating, the first point what we mentioned, that we have a very low threshold to immediately suspect and take the treatment at the initial stages itself than waiting for it to deteriorate further. For the non-surgeon factors, I think even the starts with the anesthetist using a vasopressor, ensure that there is a judicious use of the vasopressors, which generally surgeons neglect. So that has to be.
We are unaware.
Unaware.
Unfortunately,
yes, sir.
it catches us in the
Yes,
post-operative.
exactly, sir.
At least I have burnt my hands.
Definitely, sir. So that is one point I think which we
when
need to
they
mention.
don't tell us when they use it.
Yes,
and that's probably the worst enemy of an anastomosis.
Exactly. So then, of course, you have your radiologist friend who is going to help you to identify any collection and so on, and the nutritionist in the first point, which I always support. So these might be some of the non-surgeon factors which might help. Kapil, you want to add on something?
You want
Nothing,
to add
sir. I think
anything?
that
Yeah.
covers most of the spectrum. As I said in the beginning, it can be the patient factor, disease factor, and surgeon factor. The patient factor, always optimize. Disease factor, make sure that you can optimize them. Surgeon factor, it's my skill, I have to improve on my skills. Make sure when I'm closing, I'm not pinching in a bubble. Make sure that if I'm using a mesh, I'm not using those metal tackers. These are the things that, which you learn. And a lot of common sense will avoid most of these complications. That's how I would put it.
In brief, I think we have covered most of the things.
If I can just add on
Sure,
about the skill, actually, most of the postgraduates, they think that the anastomosis technique is the most crucial. And of course, it is important, but it is not the thing. If you realize that when we do
Now you already said
anastomosis,
the bleeding edge is what matters
when we
because
do an
patient's
anastomosis
nutrition,
in a
bleeding
healthy
edge.
patient, however you do that,
Yes.
take-up is
Because-
very good.
And always important to say that if you are playing to the gallery, you make it beautiful. That is only for the gallery. But for the patient, what matters is the healing of an anastomosis. The bleeding edge is what matters. That is the take-home message, if I'm not wrong. So there may not be much time left for the scenarios which we wanted to discuss. Actually, I wanted to discuss a couple of scenarios. Here there is a repetition, almost a repetition, a 45-year-old patient coming with a gangrenous ileum, resection, post-operative day 5. Suddenly, there's a bilious leak, plenty of it, albumin low, hemoglobin low, CRP very high. How do you go about? Do you know it's a fistula or an
Depending upon the discharge content, we can mount ileal means that is a feculent smelling discharge, thick discharge. So that
how do you
will
act?
include.
How do you act?
So just you see that first is the local, you open the wound, stitch there and confirm that is not a surgical side
Will you go for
infection.
an emergency
No,
reoperation?
no, I will wait. And I'll see that what for surgery, then it is a small bowel resection. Most probably.
So next scenario is a high output dilemma. Established fistula, over 1 liter.
So this is where again the role to ensure that the patients is
we have discussed at length on this.
Yeah,
sure.
so it is the same things and nothing much nutrition planning.
Yeah. I think this is a very interesting case we had in our unit just a month ago. She had a 65-year-old lady. She had a hernia repair elsewhere 35 years ago, again reoperated after 10 years. And then a few years after that, she started leaking in the groin, about 200 ml. Exactly 2 minutes we'll be out because a very interesting case I want the PGs to see. He presented with a leaking wound, 200 ml, feculent. And
most probably that looks like a colonic fistula.
Colonic fistula, yeah.
Why
We also
sliding
thought of it.
maybe they have missed the sliding hernia.
We also thought like that. We also thought like that.
In that way.
And
So,
this is a low
during the
fistula.
course-
Patient is, I think, since 10 years patient is having. So definitely low fistula.
Very
But-
troublesome.
Yeah,
because
troublesome.
After surgery, and
So
this was the photo seen and she presented. You could see the fecal matter, the old hernia wounds, and we could even feel the mesh upon at the time of dress.
Hydrogenic.
Yeah, because second one was, see, this is how it was. Clearly. So we did a colonoscopy, a sigmoidoscopy. Nothing was visible. Through the wound, dye was injected. It was not entering the colon. So we, because the government hospital, the appointments are, according to appointment, the CT was for the next day. So we could not be prioritized. So we did the CT. And the wound was communicating with the proximal ileum. So this was an ileo-cutaneous fistula through the hernia wound, through the mesh. So this is a combined enterocutaneous, post-operative, post-hernia. So we have all the chapters put together now.
Was it was a reducible hernia or irreducible hernia?
No, this was hernia repair. The first was 35 years ago. The second was 25 years ago.
25 years ago.
And now the patient has come at the age of 65. She is living with the fistula for the last 10 years.
10 years.
For an event which happened 25 years ago. Our tolerance is very high.
Yes.
Naturally.
Yes.
And then she reported to the government hospital with a leaking fistula, 200 ml a day. This is what it was. We removed the mesh, did the resection, and a few days ago she was discharged.
Was hernia was there, mesh? What about mesh? You kept
No,
mesh?
we didn't repair the hernia. We just removed the mesh and just did a primary closure there.
That's what for the postgraduate, when there is hernia-induced infection or perforation or fistula, we have to remove the mesh.
So this is what happened. Yeah, just another, because time is up. So, yes, okay.
Sir, you can finish that. Complete that.
This is just another event which happened in the 90s, early 90s. A friend of mine who is practicing in a suburban area long ago, a surgeon here did an appendicectomy for an acute appendix on a youngster. Started leaking. He came back to his hospital. He drained it. Preliminary ultrasound. It was drained, and he managed for a few days. Sent the patient home, but the sepsis won't subside. Again, the patient came for the third time in a month's time, but this time the patient was red. Both his wound was red, his face was red, and the attendants were also having a red face, leaving the surgeon red-faced. So this time, third time, of course, before that, third exploration he did a lot of suturing, resuturing of the area, thinking that, and fourth time, by then it was all Vaidya Pranani Dhananisha. Before that, he wanted to send it, then he landed in, he called me. I said, okay, send it to our divine place. So we stabilized no CT those days in a government hospital. We just did a fistulogram. To our surprise, this was going from right iliac fossa. There was a small collection. The dye was filling around the cecal area, and on a track up the no pictures available. Up the right paracolic gutter straight away to the subhepatic area, communicating with the first part of the duodenum. Now PGs. Before we shut our shop, what is the diagnosis? Yeah, of course, I've written, because just to wake them up at least. What is the diagnosis?
I think pages are there more, we are here.
I'm just creating awareness, that's all. At the end of the day, they have to wake up.
So sorry to interrupt in between. We might have to conclude the session.
Yeah, sure.
Mike.
This is the outside the purview of the enterocutaneous fistula. We are not dealing with the enterovesical fistula or enterovaginal fistula. So this is because enterocutaneous fistula, I already said in the beginning, it needs a full day of discussion.
Yes.
It
is very difficult to compile. I think Jairam sir has done very justification to the topic. We have compiled very well and make it in a short way. So we should thank each other, sir, because audience are not there.
So thank you very much, everybody, from the association, from the organizers, and the crowd. Thank you very much.
Thank you, sir, and thank you to all our panelists for sharing their valuable experiences and perspectives. We now request Dr. K. Jairam Shenoy and the panelists to proceed to the photo booth for photographs and to collect their certificates of appreciation. I request Dr. Satyamurthy Aitar to do the honors.
Up next, we'll be starting with the free paper presentation, session A in this hall. Only these two. Okay. Judges for this session would be Dr. Sunil Joshi, Dr. Sangamesh, Dr. Gopinath Pai. Dr. Sunil Joshi, Dr. Sangamesh, Dr. Gopinath Pai.
Candidates ready,
Correct ಇದೆ ಸರ್. ಕರೆಕ್ಟ್ ಇದೆ ಇವರಿಲ್ಲ ಸರ್. ಇವರಿಲ್ಲ ಸರ್. ಇವರು ಕರೆಕ್ಟ್ ಇದೆ ಸರ್. ಕರೆಕ್ಟ್ ಇದೆ. ಸ್ಟಾರ್ಟ್ ಮಾಡೋಣ.
We'll be starting with the free paper presentation. The first presenter is Dr. Vardhan HR. Three names. These three names only. What? Dr. Sunil Joshi. Dr. Vardhan HR. He's there.
Good evening, everyone present here. Myself, Dr. Vardhan from Department of General Surgery, R. Jalapa Hospital.
Kamran.
Okay. The thyroid nodules are my topic for today is the TSH level as a predictor, as a risk factor for thyroid malignancy. Thyroid nodules are common in clinical practice with a prevalence of up to 68% when screened by high resolution ultrasound. Most nodules are benign, but the diagnosis of malignancy is crucial as thyroid cancers are rising globally due to improved detection. Risk factors for malignancies include age, male gender, and radiation exposure, family history of thyroid cancer, and rapid growth and compressive symptoms and lymphadenopathies. TSH regulates thyroid growth and functions. Elevated TSH may stimulate cellular changes linked to the cancer development. Recent research suggests that higher TSH levels within the normal range are associated with increased risk for thyroid cancer in euthyroid patients. Nodule size and cytology findings with Bethesda system aid in risk stratification, but predicting malignancy remains a challenging thing. The rationale for my study is to assess whether the serum TSH can serve as a convenient and cost-effective predictive marker for thyroid malignancy, and also to improve the risk prediction and guide management in euthyroid patients presenting with thyroid nodules. The aim of the study is to determine the TSH level impact on thyroid malignancy in euthyroid nodules. Primary objective of the study is association between TSH and thyroid malignancy, and my secondary objective is assess the relationship between the nodule size and malignancy. This is a retrospective observational study conducted in R.L. Jalapa Hospital, Kolar, between January 1st to April 30th, 2025. My sample size is 85 patients who has undergone thyroidectomy for nodular thyroid disease. Inclusion criteria: with age more than 18 years, euthyroid patients who has underwent thyroidectomy that will include total or hemithyroidectomy for single or multinodular goiter. Complete preoperative and postoperative records are also collected. Exclusion criteria: history of thyroid medications or radioactive therapy, overt or subclinical thyroid dysfunction, and insufficient documentation. Demographics like age, gender, BMI, personal history of other cancers are also taken, and preoperative investigations like serum TSH and fasting T4 levels with nodule size through ultrasound or clinical method or FNAC cytology. Surgical and histopathological data, which is type of operation performed, final histopathology, that is benign or malignant. Histological subtypes are also documented. The cohort divided post-surgeries into a benign group, which are non-cancerous, and malignant group. Mean TSH and nodule diameter was measured, and proportion with TSH more than 2 milli international units per liter, and nodule more than 4 centimeters. Bethesda classification of 1, 2, 1 being non-diagnostic, 2 being benign, and 3 and 4 with intermediate risk, and 5 and 6 with suspicious or with malignant disease. My results include the sample size of 85 patients who has underwent thyroidectomy for nodules at R.L. Jalapa Hospital between January to April 2025. Mean age being with 46.2 years. Plus or minus 13.9, representing primarily middle-aged adults. 80% of them were female, matching the higher prevalence of thyroid disorders in women. BMI being the mean BMI with 31.2 kilograms per meter square, majority being overweight and obese. Thyroid function and nodule size with mean TSH of 1.8 milli international unit per liter, with average nodule size being 3 centimeters, in which 31% has nodule size more than 4 centimeters. Histopathological outcomes with 62% being malignant and 37% being benign, reflecting a high malignancy rate among the surgical cases. In this, the table depicts that TSH and nodule size are statistically significantly different between benign and malignant group, with higher TSH and smaller nodules in the malignancy. Rise in TSH from Bethesda 2 to 6 mirrors increased cancer risk. The trend is statistically significant, with p-value being 0.001, supporting the hypothesis that higher TSH, even within the normal range, is associated with a greater risk for malignancy. Coming to the discussion, the study revealed that euthyroid patients with malignant thyroid nodules had significantly higher mean TSH levels compared to those with benign nodules. Logistic regression confirmed that the TSH as an independent predictor with a 1.45-fold increased odds of malignancy per 1 milli international unit per liter rise in TSH. This results support existing literature indicating that even TSH levels within the normal range may stimulate tumorogenesis through increased thyroid cell proliferation. The correlation between higher TSH and increasing Bethesda category suggests that TSH may be linked to the nodule aggressiveness and cytological progression. Contrary to TSH, larger nodules, that is more than 4 centimeters, were more oftenly seen in benign, consistent with the notion that malignant nodules tend to be smaller. No significant association was found between the age, gender, or BMI after adjusting for other variables. So clinical implication, preoperative TSH measurement could serve as an inexpensive, readily available biomarker to improve the malignancy risk stratification in euthyroid patient with thyroid nodules. It helps in identifying the patient who may benefit from closer surveillance or earlier surgical intervention despite normal thyroid function. The inverse relationship with nodule size highlights the need for integrated assessment for incorporating the TSH and nodule size and cytology in clinical decision making. Coming to the conclusion, this study at R.L. Jalapa Hospital confirms that normal TSH levels are significantly linked to thyroid malignancy risk in euthyroid patient presenting with nodular thyroid disorders. Smaller nodules and elevated TSH independently predict malignancy, whereas larger nodules are more likely benign. TSH levels rises with Bethesda cytology category, supporting their value as an adjunct in thyroid cancer risk assessment. Incorporating TSH measurements into preoperative evaluation can aid the clinicians in stratifying the risk and tailoring the management strategies for euthyroid patients with the thyroid nodule. This approach can potentially improve the patient's outcome by facilitating timely diagnosis and by choosing the appropriate treatment. That's it.
All these patients had a normal range of
TSH. Normal range of TSH was only taken. The inclusion criteria for this was euthyroid patient with normal range of TSH. So that is between 0.5 to 5. Sir.
So all these patients you had where you were thinking of malignancy, yes, TSH was more towards a higher limit.
At a higher level, sir, towards higher limit. I mean, within the normal range, the TSH was a little high, the higher limit, sir.
You have mentioned malignancy, but you have not mentioned which type of malignancy in all these slides.
Sir, all type of thyroid malignancies were included, like papillary carcinoma, follicular carcinoma was included in the study, but the groups were divided between benign and malignancy. The aim of the study was to just show that within the normal range, the TSH levels which tend to be at the higher side in the malignant group, sir.
No, but what I want to know is whether this particular elevation in level of TSH is more in favor of papillary or follicular. Because whenever we do thyroidectomy, in case of papillary carcinoma, we give suppressive dose of L-thyroxine, thinking that we are going to suppress TSH. Yeah, so that's the reason why I asked you.
Sir. No, sir. We just, yes, sir.
If higher levels of TSH are associated with higher level of malignancy, you want to advise frozen section in every case of benign nodule?
Not necessarily.
With the high level of TSH? Borderline higher level of TSH?
Sir, one thing is we can preoperatively send TSH. We can, this will aid in early treatment and early surgeries rather than waiting for the patient the nodules to develop into malignant.
See, TSH is near upper side of the borderline, yes, isn't it? Yes, TSH. So there is higher sense of malignancy, you are telling, as per your study. So we have done only solitary nodule is there, we have done hemithyroidectomy, yes, not taking into account other risk factors. So suppose final HBR report comes as malignancy. Do you want to go ahead with one more surgery?
It's complete surgery. Since the surgery will be incomplete, so complete surgery, we can do it after the
So my question, why not the frozen section in suspected cases or high risk cases?
Yes, sir.
Your same point can act as one more high risk factor for malignancy.
Sorry, sir.
Isn't it? Your higher levels of TSH in clinically euthyroid patient, that itself can act as a high risk factor in a malignancy. So we can add that part also. You do further study with a larger sample size. So that itself can become a risk factor later on.
Yes,
isn't it? Yes. Good presentation.
Thank you, sir.
Thank you, judges. Please note this was Dr. Vardhan HS, FRP 34. Yes, sir. Up next we have Dr. Lingraj, FRP 118. Dr. Lingraj, FRP 118. After this, we'll have Dr. Bhimya, FRP 95. Please be ready with your presentation. Dinner would be served at 8 p.m. in the MU hall. At 7:30 p.m. in the MU hall.
Good evening, everyone. My name is Dr. Lingraj. I'm presenting correlation between the primary breast tumor and lymph node metastasis. Traditionally, breast cancer is thought to progress in a stepwise manner through several stages like hyperplasia, intraductal carcinoma, invasion and growth within the breast, followed by the metastasis to the lymph nodes and distant sites. A commonly accepted theory is that as a cancer grows, cells within the tumor acquire the capability to spread, to survive, to flourish within the regional lymph nodes and other distant sites. It is thought that risk of developing metastasis increases monotonically with tumor size because the larger the cancer at diagnosis, the more cells are available to metastasize. However, the evidence for this theory is indirect. Patients are followed forward in time to record the transition from non-metastatic state to metastatic state. The cross-sectional correlation between tumor size and metastasis is a graphical representation of a sample of different patients at the point of diagnosis. Most studies to date which have reported a correlation between the primary tumor size and likelihood of metastasis have taken only the greater dimension into consideration. In our study, we have considered relationship of lymph node metastasis to all three dimensions of the primary tumor. Aims and objectives. To determine the correlation between size of primary breast tumor and lymph node metastasis taking into consideration. Only length, only height or depth, only breadth or length, breadth and height. Materials and methods. Database from Department of General Surgery and Department of Pathology, Basveshwar Teaching and General Hospital attached to Mahadevappa Rampura Medical College, Kalburgi between January 2024 to March 2025 was collected and all cases that were pathologically confirmed were selected. Exclusion criteria: women with no primary tumor found, unknown primary tumor size, diffuse disease, Paget disease or of the nipple or in situ disease. Patients classified as nodes not assessed were excluded from this analysis. Prevalence of lymph node metastasis at diagnosis was defined as the proportion of patients with least one histologically confirmed positive regional lymph node metastasis. Sample size was calculated using the formula. Sample size was, sorry, it was 44. Results were, the study sample size contained 43 females and 1 male belonging to the age group of 45 to 70 year old, those are females, and 53 that is male. 36 had infiltrating ductal carcinoma, that is non-specific type, while 4 had mucinous carcinoma, 2 had papillary variant and 2 had other variants. Out of those presenting with infiltrating ductal carcinoma, 20 showed lymph node positivity, and among those with mucinous carcinoma, 1 showed lymph node positivity. On running statistical analysis using SPSS V27 grad pack, the correlation between length of the primary tumor to lymph node positivity was found to be significant with Pearson correlation coefficient of 0.460. There was a significant correlation between the height of primary tumor and lymph node positivity with a Pearson correlation coefficient of 0.373. And there was a significant correlation between length, breadth and height of the tumor and the lymph node metastasis with a Pearson correlation coefficient of 0.326. However, there was no significant correlation between the breadth and the primary tumor and the lymph node metastasis, as the Pearson correlation was 0.247. On discussion, we examined the relationship between the primary tumor size and the prevalence of metastasis. For cancers between approximately 7 to 60 mm in size, there was a clear linear correlation between tumor size and the probability of metastasis. However, for very small cancers and for very large cancers, there were notable departures. At the time of origin of the breast cancer, a small number of non-cancer cells in the breast duct acquire the characteristic of non-cancer cells, and as these replicate, the daughter cells diffuse into the breast parenchyma and grow into the lymphatics and into the blood, where they may form an invasive breast cancer, a nodal metastasis, or a distant metastasis. We identified a non-linear relationship between the tumor size and the nodal and distant metastasis. Potential explanation for the lack of size effect on metastasis for very large and very small and very large tumors relate to variations in the propensity and the opportunity for individual cells to metastasize. For example, there may be a smaller proportion of cells accessible to the vascular or lymphatic systems in the larger tumors, a lack of stable blood supply leading to central necrosis and can lead to metastasis. In conclusion, the relationship between the tumor size, mainly length and height, and the lymph node metastasis is, in patients with carcinoma breast is statistically significant. Limitation of the studies where it was a cross-sectional study, a small sample size, the grade of the tumor was not taken into consideration, duration of tumor was not considered. Thank you.
Hello, good presentation. How would you, what kind of study is this? One place you say it is cross-sectional. What is cross-sectional study? Is it cross-sectional study or retrospective study? You are analyzing the data retrospectively,
Yes,
isn't it? So cross-sectional and retrospective, are they retrospective? Are they same?
No.
Well, that is the important point you should know. Have you done the biomedical course?
Yes, sir.
Okay, all right. That's one point. Number two, so you have tried to tell us, you compared, what was your, how did you assess the size? Was it post-operative or diagnostic modality?
Diagnostic modality, sir.
Diagnostic. Based on that, you had a 3-dimension.
Yes, sir.
Did your tumor size correlate with the operative specimen as well?
Yes, sir. It was correlated, sir.
It did? It did?
Yes, sir.
Okay. And then you wanted to know whether there was, so what procedure did you do for all the, were done for these cases?
So radical mastectomy, sir.
Radical. So
yes,
all 44 cases which you said have
almost,
undergone?
sir, like most of
almost nahi hota hai statistics mein. There's no statistics. Almost in statistics. You got hardcore data there, so you got to tell us.
Yes, sir.
Whether all of them underwent MRM?
Sir, when the size was smaller, we did some breast conservative surgery, sir. Like other where the size was bigger, we did radical mastectomy.
So what the simpler ones, what did you do? Only mastectomy?
Yes, sir.
Only mastectomy. So how did you compare lymph nodes then? Whether metastasis?
So radical mastectomy, sir. Like, so wherever the lymph nodes were.
So you did radical and modified radical?
Yes, sir.
So if you have not done a lymph node dissection, how will you identify if there is a malignant?
You have told that you have done a conservative breast surgery.
Yes, sir.
Where you have done removal of wide local excision, and then what about axilla? What have you done for the axilla? Did you do SLNB?
Yes, sir. Wherever the axillary lymph node were excised.
If you say breast conserving surgery for a diagnosed case of CA breast, it is understood that SLNB, sentinel lymph node biopsy, is must. That is mandatory. Without sentinel lymph node biopsy, you cannot do conservative breast surgery or breast conserving surgery in a proved case of CA breast. That is first point.
Yes.
Okay. Second, you told one case was male breast, CA breast.
Yes,
what you did in that case? What surgery was done in that CA male breast?
Radical mastectomy with lymph node excision, sir.
How CA male breast is different from CA female breast? Because of absence of breast tissue, a very early local spread to the chest wall, isn't it? Very soon it will become local advanced breast carcinoma. So we may have to do sometime removal of underlying muscle fibers also, like pectoralis major, isn't it? That's why we say prognosis in CA male breast is more dangerous, worse than in female, isn't it?
Thank you, judges. Please note this was Dr. Lingaraj, FRP 118. Yes, sir. Up next, we have Dr. Bhimya, FRP 95. Dr. Bhimya, FRP 95. After that, we'll have Dr. Nandan Kumar, MS, FRP 87. Kindly be ready with your presentation.
Good evening, everyone. Myself, Dr. Bhim, a general surgeon resident from AJ Institute of Medical Science, Mangalore. My topic for today's paper presentation is management of complex incisional hernia using component separation technologies. It was a case series done in the Asian Institute of Medical Sciences and Research Center. Introduction, that incisional hernia occurs in 11 to 20% after any laparotomic post-laparotomic procedure, and the large defect measures if more than 10 centimeter are difficult to repair by the primary closure. The component separation technique enables myofascial advancement with preserved innervation of the primary. The study objective is to evaluate component separation technique outcomes in the complex hernias. The objective of the study to assess the outcome of the component separation with mesh reinforcement, to measure recurrence and complication and recovery, to evaluate anatomical and functional restoration after compartment separations technique. The materials and methods included in this study, the patient selection criteria, there were 15 patients were included, in which the 5 patients were male and 10 patients were female, with a mean age of 58 years. Defect was measuring more than 8 centimeter with width of 60 centimeter square area. And exclusion criteria comes under like the patients with immunosuppressed status, with a patient with any active infection and BMI measures more than 40, or any previous history of component separation. The materials and methods, the surgical technique was like the most of the procedure was done under general anesthesia, with in some cases along with the epidural anesthesia was used. And after making the incision over the hernia, the external oblique aponeurosis was incised lateral to the rectus muscle, and the posterior rectus sheath was released, and polypropylene mesh in onlay or sublay position with 5 centimeter overlap was used. And after component separation, midline was closed with number 1 polypropylene mesh, and drains were placed. Polypropylene suture and drain was placed. Outcome of the surgery, and the outcomes were monitored for recurrence or any surgical site occurrence after the surgery, or hospital stay duration and functional recovery. And a patient was called for follow-ups after 2 weeks and 3 months and 6 months. Results, the hernia characteristic, the mean defect size was 12.4 centimeter, and in 40% of the cases it was measured 8 to 10 centimeter, and in 33% of the patient 10 to 15 centimeter, and more than 15 centimeter defect was present in 27%. All patient had in all patient we have put mesh. So results, the early post-operative outcomes, the mean hospital stay was 8 days with a range of 4 to 18 days, and complications was occurred in 2 patients. One was a seroma form and it was aspirated, and one surgical site infection was occurred. Initially we managed with IV antibiotics and followed by the oral antibiotics, and the no compartments, abdominal compartment syndrome or mesh infection occurred. The result, the functional and late outcome, that is 93% patient resumed daily activity by 3 months, and 1 patient had mild chronic pain, no recurrence or reoperation at 6 months, and 93 patients reported improved quality of life. The discussion, there was 0% recurrence versus compared to the 15 to 20% recurrence rate in the traditional repair, and the surgical site outcome rate was 13.3%, much lower than the older reports, as it was like 58%. The obesity did not impair any success rate, and mean BMI was included at 31.2. So a result aligned with earlier studies that done by Dice and Nowitzki, it was better. The conclusion of this study, the component separation technique with mesh placement is effective for complex hernia repair, and the key factors were it preserved vessels, precise dissection, tension-free closure, and the functional restoration achieved with minimal morbidity. And component separation technique is a gold standard for large abdominal wall defects. Thank you.
Your comparison with the Nowitzki was, unimaginable. You know what is the series of cases with Nowitzki has done?
No, sir. No, sir.
Anyway, the presentation is fine.
So your exclusion criteria, did you include any recurrent cases in that? Recurrent hernias, you have to, when you mention about the
No, sir.
exclusion
Recurrent
criteria,
hernias were not included.
so that has to be a part of your presentation. Okay. Many important exclusions there. So now, what is the alternate for component separation? This thing treatment.
So we can do by layer repair, primary repairs.
Primary repair for a big defect.
After like.
You said we are talking about bigger defects now.
Yes.
We are talking about anything more than 10 centimeters.
10 centimeters.
What is the alternate for this? What did you do earlier? Now, before you got this CST, before component separation, what was your alternative? What was the treatment you used? Because we need to have some basis on which we have improvised, isn't it?
Yes.
What was done?
We can put the mesh directly over the defect after closing the closing primarily. We can put the mesh over the defect, sir.
You want to close primarily and then put a mesh on that?
Yes.
Okay. Now, this is a series of 15 patients, isn't it?
15 patients.
You told you have excluded patients with BMI of more than
40.
40. Why did you exclude them? Because most of the time your sample size is defects of more than 8 centimeter, isn't
Yes,
it?
yes, sir, yes.
So more than 8 centimeter defect will be obviously seen in obese patients, not in thin build patients. What made you to exclude them?
Sir, if BMI is more than 40, the recurrence chances will be more, and the seroma formation, the complication will be more.
They need such patients also need surgical treatment, isn't it?
Yes, yes. They need.
Your patients were with hernia, initial hernia with defect more than 8 centimeter.
8 centimeter.
You would have matched the case-to-case basis,
Yes.
isn't it? BMI of more than 40 centimeter, 40, same cases you would have compared.
Yes.
In the two types of repairs, isn't it? Would have got more sample size. For thin-built individuals,
Yes.
rarely we get such big size defects in incisional hernia.
No, sir.
Unless
Usually
there are some surgeon faults.
No, sir, usually the large
Non-porous
defect
patient like
will get in obese patient only, sir. But the BMI, the upper limit for BMI was for this patient was 31, sir. We excluded after more than 40 BMI, we excluded, sir.
Okay.
All right then.
Thank you, dear
Thank
judges. This was Dr. Bhimya, FRP 95. Up next, we have Dr. Nandan Kumar MS, FRP 87. Dr. Nandan Kumar MS, FRP 87. After that, we'll have Dr. Uzma Sultana, FRP 90. Kindly be ready with your presentation.
Good evening, one and all staff. My paper for today presentation is immediate oral refeeding in patients with mild and moderate acute pancreatitis. It's done in the Navodaya Medical College in Raichur. Introduction. Acute pancreatitis is the third cause of hospital admission for gastrointestinal disease. Recent studies have recorded an increase in worldwide incidence of this disease also. During an acute pancreatitis episode, hydroelectrolytic enzymes, toxins and cytokines are released, which can result in organ failure caused by systemic and metabolic dysregulations. This cascade of events leads to hypermetabolism and a negative energy balance, making nutritional support indispensable. Aim and objective of the study: to establish the optimal time to start oral refeeding in mild and moderate acute pancreatitis in order to reduce hospital length of stay and complications. The patients with acute pancreatitis in Navodaya Medical College and Hospital in Surgery Department were included in this study. Materials and methods: 133 patients were included for the randomization. Included patients with a diagnosis of mild or moderate acute pancreatitis admitted consecutively into our hospital from 2023 to 2024. Patients were randomized into two treatment groups, that is immediate oral refeeding IORF and conventional oral refeeding. The immediate oral refeeding group was given low-fat solid diet initially immediately after hospital admission, was compared to CRF group, but that is a progressive oral diet was restarted when clinical and laboratory parameters as improved. that is a conventional treatment. In terms of length of hospital stay, and that is a primary endpoint, and pain relapse, diet intolerance or complications, and hospital costs. The primary endpoint of the trial was the length of stay. Secondary endpoints included complications, abdominal pain relapse, and laboratory findings, and diet intolerance and hospital costs. In the inclusion criteria were age more than 18 years and with mild or moderate acute pancreatitis. Exclusion criteria are pregnancy, breastfeeding, poor oral intake for reasons other than acute pancreatitis, abdominal pain lasting more than 96 hours prior to admission, pancreatic neoplasm, that is surgery needed for any other causes, trauma, endoscopic, that ERCP needed as acute pancreatitis etiology, chronic pancreatitis or short bowel syndrome, severe or critical acute pancreatitis on admission. The outcomes, here the study group, it shows the length of hospital stay, it has reduced significantly because the patient has been started on low fat solid diet on the day of admission itself, rather than starting after the course of antibiotic in control group study, sir. And days of refeeding to the discharge has been reduced, and the intolerance to diet is also reduced because it has been started because of the psychology factors also is acts on the patients, and complications also has been reduced, sir. Discussion. The optimal timing for refeeding in acute pancreatitis was investigated in this randomized study, demonstrating that the administrating an immediate oral low-fat solid diet to mild or moderate acute pancreatitis patient significantly reduced length of stay and hospital cost without increasing the risk of complications when compared to conventional oral refeeding groups. It is possible to start an oral diet without waiting for reduction in abdominal pain, peristalsis to begin, or appetite recovery. Furthermore, there is no need to apply analytical restrictions such as amylase, leukocytes, or C-reactive protein levels to start the diet in mild or moderate acute pancreatitis patients. The conclusions: the administration of immediate oral low-fat solid diet to patients with mild and moderate acute pancreatitis is safe and feasible. Immediate oral refeeding food was associated with a significant reduction in the length of stay and hospital cost without increasing the risk of complications. Although the timing of refeeding is now established, further studies should compare low and normal fat diets and should be sufficiently powered to identify differences in adverse effects and complications. And the reference being this. Thank
you. Of these pancreatitis, what are the etiological conditions for these patients whom you have chosen?
Yes, sir.
You have not mentioned about that.
Yes,
you
sir.
have done exclusion criteria,
yes,
but you have not chosen who are the people, what is the type of pancreatitis, what is the etiology of pancreatitis in which you are starting this early refeeding.
Okay, sir. In
anything specific? There are various etiologies.
Yes, sir. Yes, sir. And it can be started in the patients majorly in the age more than 18 years of age group, sir. It will be under alcoholic pancreatitis more common, sir. So those patients were more common in our hospitals, sir. The other patients include the gallstone pancreatitis and.
I'm not asking you what are the different types. Okay. Who are the patients whom you have chosen?
Alcoholic, majorly.
Majorly, you have not mentioned anything else. Majorly alcoholic.
Majorly alcoholic.
All of them are alcoholic only.
Yes, sir. Yes. That's most
Now, good to hear that we are hearing randomization and all that here. Good study. So, how did you randomize the patients? What is the randomization technique?
Sir, there are units divided, no, sir. So based on the units, because of the.
So did any particular surgeon prefer to do one, or it was randomized? What is the randomization?
It's like the 4 to 5 surgeons has been divided. The patients have been divided into 4 to 5.
What is randomization? How did you randomize?
It is not. The patient or the treating doctor doesn't know which patient.
So what is that called as? What is that technique called as? Blinding. Yes.
Blind.
Single blind, double blind, triple blind.
Single.
Okay. All right. So randomization. Randomization is putting patients into each group without trying to know who it is, what it is, and then randomly one this group, one that group, something like that.
Yes, yes.
So you said mild to moderate pancreatitis, isn't it?
Yes.
Were there any objective criteria as to say whom you put into which code? There has to be some objectivity.
Like
Objectivity. Who is mild? Who is moderate? Who is severe?
on presentation to the clinical symptoms, sir, the patient in chronic or severe pancreatitis, the patient will be more.
We're not asking theory. How did you do it?
On what basis you have
What
divided
basis?
patients?
Objectivity. Whom did you call? Yeah. Whom did you call mild? Whom did you say was severe?
Any criteria you have taken into account?
Bedside score was a BISAP score.
Which score?
So on what basis that you have to mention that, isn't it?
Yes, I mean,
On what basis you want to divide the patients as mild, moderate or severe, because you are excluding severe cases, isn't it? You have to mention that criteria. Without that, the study is not proper. Isn't it?
So the major indication you wanted to start the feeding was, what is the reason? What is the purpose of starting very soon?
Purpose of starting very soon is the loss of gut bacteria, relocation of gut bacteria when we started the late phase of oral refeeding, and the nutritional status of the patient has been will be deteriorated, sir. And
so which one is more important?
Is
Is it nutritional or gut microbe?
Gut bacteria, because of cause of further secondary infections will be more, sir, if the bacteria are relocated or other things.
Relocated or anything else?
Gut mucosal.
Translocation?
Sir, translocation of the gut bacteria.
Okay. So outcomes was only length of stay, is it? No other criteria. So if you have election, when you choose them or objectively put them into categories, the outcomes can be compared very easily. It's very vague. So length of the only stage that you will consider, or anything else? Pain relief?
Pain relief on the feeding, pain has been not increased in many patients, sir. Like majorly in a study group, after oral immediate low fat solid diet, the pain has been not increased significantly.
So did your the intervention help to reduce pain as well?
Yes, sir. It has.
Or was it analgesics?
And no, sir. Analgesics has been given to the both control and study group as normal BD doses.
Sir, anything else?
What is the study period?
So study period over 1 year, sir. In my
so you have to mention the month also, because you in the study you have written only 2024 to 25.
December, yes,
23 to 24 you have written.
Yes, sir, 23
it can mean 2 years also, isn't it? January 23 to December 24 will be 2 years.
Yes.
Or January 23 to January 24 will be 1 year. So you have to mention month also, not just year.
Yes.
Okay.
And your study also, you mentioned somewhere it's multicentric. I don't think it's multicentric.
Single centers.
Huh?
Single centers.
Then why did you write multicentric? The words have no meaning. Multicentric. Okay.
All this together will make us to question the virginity of your study. Whether you have done the study or not. You should not give such chances to the examiners or judges, man. Okay, good.
Thank you, judges. Please note this for Dr. Nandan Kumar, FRP 87. Up next, we have Dr. Uzma Sultana Mullah, FRP 90. FRP 90. After that, we'll have Dr. Arun KP, FRP 92. Kindly be ready with your presentation.
Evening all. Myself Uzma Sultana Mullah. Today's my topic is a comparative study of breast lump in premenopausal and postmenopausal women. The introduction is breast cancer is the most common female cancer with the incidence of 28.2% in India, and about 30% of women suffer from benign breast disease at some point of their lives, and about 5% the risk of various cancers like ovarian, breast and uterine cancers. The objective here are to compare the clinical presentation of the breast lump and etiological correlation in the pre and postmenopausal women, and to identify the most common benign and malignant breast lump in the pre and postmenopausal women with histopathological examination, and to identify the high risk group for the CA breasts. Here the study duration I have taken is for 1 year and the sample size is of 50. 50 female patients who presented with the palpable breast lump to the Al-Amin Medical College during the period of 1 year after taking informed consent. Inclusion criteria has been included is women above 18 years presenting with the palpable breast lump will be included in this study, and the exclusion criteria is the patient who are on OCPs and hormone replacement therapy, and also the patient with the breast lump on chemo and radiotherapy. Here the methods are the total of 50 patients who presented with the breast lump were divided into group A comprising of premenopausal and group B of postmenopausal women. Demography, history and clinical examination, FNSA and core biopsy was done, and sonomammogram was done and data recorded. Patient underwent appropriate surgery and histopathological examination was compared. Results are among 50 patients, 32 were premenopausal women, they were grouped into group A, and the remaining 18 were grouped into postmenopausal women into group B. In the premenopausal women, majority of the patients were in the age group of 31 to 40 years, and the postmenopausal group was, majority of the patients were in the age group of 41 to 50 and 51 to 60 years. The mean age of the patients in the group A, that is premenopausal women, were 33 years, and the group B was 62 years. The mean duration of the lump in premenopausal group was around 10.6 months, and in postmenopausal was around 12.7 months. This is the bar diagram showing the blue one the blue one is the premenopausal age group, which shows the incidence is more common in the 31 to 40 years age group with the 56.2 incidence, and less than 30 years patient presented with the 31.2 incidence. And the postmenopausal age group, that is the bar diagram of the red diagram, shows the incidence is more common in 41 to 50 years and 51 to 60 years. And the next bar diagram shows the duration of lump, which is more common in the group B with the incidence of 12.7 months, and in the group A is around 10.6 months. Next is the group A, which shows 65.6% were benign lesions and 34.4 were malignant lesions. In group B, 33 were benign and 66.7 were malignant lesions. In premenopausal group, most common histopathological diagnosis was fibroadenoma, and postmenopausal group, most common histopathological diagnosis was invasive ductal carcinoma. In premenopausal group, 43.8 had CA breast and 43.8 also had fibroadenoma, and the rest other were benign breast disease. In the postmenopausal group, 77.8 had CA breast, 11.1 had fibroadenosis and other benign breast disease. The bar diagram is showing the CA breast, that is the red color, which indicates the postmenopausal age group with the incidence of 77.8%, and the very less incidence of the postmenopausal age group showing fibroadenosis and other diseases, whereas the premenopausal age group, where the most common was the fibroadenoma with the incidence of 43.8%, and they also had a risk of developing CA breast with the similar incidence of 43.8%. The conclusion is in this study, malignant breast disease is more common in the postmenopausal women, benign breast disease is more common in premenopausal women. Fibroadenoma was the most common benign breast disease, and invasive ductal carcinoma was the second most common malignant breast disease among premenopausal women. Next, in postmenopausal women, invasive ductal carcinoma was the most common malignant breast disease, and fibrocystic disease was the most common benign disease. Usually the diagnosis is delayed in young patients, resulting in the advanced stage of the presentation. This is due to the lack of proper screening programs of the young women that leads to the aggressiveness of the disease. These young groups of patients have had high-grade tumors, which indicates the aggressiveness, clinical behavior, and poor prognosis. Breast cancer awareness programs, screening programs, and easy access to healthcare system may help to increase the awareness and early detection of the breast cancer in young females. These are the references taken. Thank you.
Okay. So studies should be usually focused, and you should be identifying, you have to focus to a particular area, reduce the number of objectives, outcomes, and other. Try to focus as much as possible. If you want to tell us what differently have you done in this study to the already present information, what have you added?
Patient presenting with the breast lump.
What new thing have you given? Yes.
Yes, sir. Patient presenting with the breast lump, sir. So in the age criteria, according to the age criteria, and also we are taking the patient for the surgery accordingly after doing the diagnosis and all. And post that, we are comparing the histopathological diagnosis, which has been which is very common in the premenopausal as well as in the postmenopausal age group.
All right.
What have you done for all these patients? What surgery you have done? Both premenopause and postmenopausal?
So depending on the ideally the patient is presenting with a breast lump, sir. So based on the history as well as the clinical examination and the further sonomammogram and true cut biopsy accordingly, when the diagnosis has been obtained, accordingly we have treated, like when there is simple fibroadenoma, excision has been done, and accordingly the management has been done. And whatever excision has been done, we have sent for the sample for the histopathological examination, and based on that further management has been done.
Which investigation do you want to do first to rule out malignancy? Is it the sonomammography or FNAC?
FNAC, sir. First clinically we will examine based on the consistency of the lump. If it is hard, we have to do this one, FNAC, and so mammogram.
Invasive investigation like FNAC or core needle biopsy has to be done last. You know the triple
Invasive.
assessment, isn't it? Triple assessment, clinical
yes,
examination,
clinical
followed by
radiological examination.
Finally, histopathological or cytological examination, isn't it?
Yes, sir.
And second is, you told in conclusion, screening for CA breast will help to reduce the prognosis, isn't it? Improve the prognosis. You have not done study anything on screening. How can you comment on that in conclusion? You have given so many conclusions, 8 to 10 conclusions. I think only 1 or 2 parameters you have studied. Remaining 8 or 9 parameters you have not studied at all. How can you conclude on them without doing any studies? That's why sir has pointed out rightly. You have to concentrate on 1 or 2 parameters. So many parameters you have mentioned in the conclusion without doing any study. What screening do you have done in your study to comment on that? Any screening you have done?
Like screening programs helps to diagnose the
What do you mean by screening, madam? What do you mean by screening?
Like early detection of the
What do you mean?
lump.
What is the definition of screening?
Do you have any evidence to say that screening will improve the outcomes? You've not done anything. So that's all right. Good presentation. Thank you.
Screening is doing investigation before development of symptoms, isn't it?
Yes.
Before development of symptoms. Asymptomatic patient submitting for investigation.
Yes.
It is not diagnostic, it is screening investigation. Okay?
Yes. Okay. Thank you, sir.
Thank you, dear judges. This was Dr. Uzma Sultana, FRP 90. Up next, we have Dr. Arun KP, FRP 92. Dr. Arun KP, FRP 92. After that, we'll have Dr. Gishnu Gopal, FRP 96. Kindly be ready with your presentation.
This is the slide changer. For the next slide, this, and for the previous slide, this is the pointer. Good evening, everyone, to the chairperson and all other dignitaries on the dais and off the dais. So my paper topic of presentation is clinical profile and management of choledocholithiasis, an observational study. I'm Dr. Arun from Bangalore Baptist Hospital, finally a surgery resident. So aim in my study is to study the clinical profile and management of patients diagnosed with choledocholithiasis in Bangalore Baptist Hospital. Objectives include management of patients and the clinical profile of the patients with choledocholithiasis. It is an observational study with 186 as sample size and over a period of 2 years. Inclusion criteria, all patients diagnosed with choledocholithiasis and their age more than 18 years. Exclusion criteria, refused for surgery and age less than 18 years. So research methodology, in our hospital, any patients diagnosed with choledocholithiasis, initially they are checked for pancreatitis, whether if they have gallstone-induced pancreatitis, plan for ERCP, and plan for interval cholecystectomy. If no pancreatitis, plan for ERCP, plus if the post-ERCP, if they develop pancreatitis, plan for lap chole. If they develop pancreatitis, plan for interval cholecystectomy, and if no pancreatitis post-ERCP, there will be plan for lap chole on the index admission itself. So study method include that evaluation of age, symptoms, comorbidities, and complications of CBD stones, and investigations include liver function test, CBC, and coagulation profile, amylase lipase, radiological, USG, CT, and MRCP. Various treatment modalities include primary treatment was ERCP plus stone extraction. If stone extraction was not possible, plan for lap CBD exploration followed by open CBD exploration. Post ERCP complications included bleeding, perforation, pancreatitis, cholangitis was also assessed. Results, it was higher
prevalence was noted in older adult more than 60 years of age. It is around 39.2%, and male predominance around 58.6%. Right hypochondrium abdominal tenderness was the most abdominal pain was the most common symptom, around 94.1%. And the most common comorbidity noticed was type 2 DM, 38.7%, and systemic hypertension in 32.3%. In this choledocholitis patient, post-lap cholecystectomy patients were 17 patients, it's around 9.1%. So investigations, elevated total counts was noticed in 142 patients, 76%, and altered LFT was noticed in 167 patients, which was around 89.8%. 41 patients had pancreatitis on admission. So investigations, USG abdomen was done for 125 patients, in which CBD stone was detected in 48 patients, and it was 38.4%. CECT was done in 125 patients, in that 110 patients had CBD stones, which was 88.6%, and MRCP was done in 145 patients, in which they have 140 patients had CBD stones and 96.5%. That's a graph depicting. ERCP was done in 186 patients, and ERCP stenting was done in all patients, but stone extraction was possible only in 179 patients. 7 patients stone extraction was not possible. So CBD exploration was done in 7 patients, in that lab CBD exploration was 5 patients, and open CBD exploration was 2 patients. And after ERCP, post-lap cholecystectomy was done in 123 patients, 72.8%, and it was not done in 46 patients. Type of CBD calculi most commonly noticed was secondary choledocholitis, which was in 163 patients, 87.6%. And complications, pancreatitis was noticed in 18 patients post-ERCP, 9.7%, bleeding nil. Cholangitis was noted in 2 patients, and perforation in D2 segment was noticed in 1 patient, 0.5%. Discussion, sensitivity wise, USG abdomen, according to literature, it is sensitivity to 15 to 40%, and CECT abdomen 88 to 96%, MRCT is 90 to 94%. And most common ERCP complications were pancreatitis around 15%, cholangitis in 0.4 to 10%, bleeding in 0.3 to 2%, and perforation was noticed, according to literature, it is 0.5 to 2.1%. Thank you.
So did you, what was your protocol? Did you offer ERCP and stenting for all the patients only when they refused, or was not possible you went for the surgical technique?
No, sir. All patients planned for ERCP only,
Okay.
US ERCP.
Okay.
But that ERCP patients, stone extraction was not possible in 7 patients. That 7 patients underwent CBD exploration.
Okay, so those 7 patients who underwent CBD exploration were ERCP stone extraction failures?
Failure patients, yeah.
Okay.
It was not refused patients.
Did you not get MRCP in any of the patients? MRCP?
MRCP was done, sir. 145 patients.
In all the patients you
Yes,
could
sir.
get MRCP?
Yes, sir.
Why did you rule out patients of less than 18 years old? Because in some patient you can get in such, especially hemolytic diseases, you get pigment stones, isn't it? In even children also you can get gallstones with CBD stones.
Consent, less than 18 years, patient won't be, parents' consent has to be taken, so we
parent consent
prefer.
to be taken. Why any definite reason to exclude patients of less than 18 years?
Nothing.
What is the percentage of males in your study?
58.6%.
It's quite high or low?
It's actually higher, sir. 58% compared to females.
Thank you, respected judges. Please note this was Dr. Arun KP, FRP 92. Up next, we have Dr. Gishnu Gopal, FRP 96. Dr. Gishnu Gopal, FRP 96. And the last presenter for this session would be upcoming next, Dr. Anusha CS, FRP 98. Kindly be ready with your presentation. We'll be taking up Dr. Anusha CS next, as Dr. Gishnu is not there. Dr. Anusha CS, FRP 98. Dr. Anusha CS, FRP 98. Dr. Anusha. Last presenter. Anusha, last presenter. Dr. Anusha CS, FRP 98, the last presenter for this session.
Okay, thank you. Good evening, everyone. I'm Dr. Anusha CS, surgical resident from Al-Amin Medical College. My paper will be on evaluation of modified CT severity index in predicting clinical outcomes of acute pancreatitis. It's a cross-sectional study. Introduction. Acute pancreatitis is a common yet potential life-threatening gastrointestinal emergency. It's characterized by the sudden inflammation of the pancreas. Its clinical presentation varies widely. It might be mild self-limiting episodes. It might have or severe forms of, or it have severe forms accompanied by organ dysfunction, systemic complications.
Excuse me, can you please go little back in?
Okay. Given this variability, early and accurate stratification of disease severity is essential to guide timely and appropriate interventions. CCT, contrast enhanced computer tomography, it plays a pivotal role in assessing the extent and complications of acute pancreatitis. Balthazar previously had introduced CT severity index, which combines the pancreatic inflammation and necrosis to grade disease severity. Though widely used, the original CT severity index, it lacks extra pancreatic complications. This limitation has led to adoption of modified CT severity index, offering improved correlation with clinical outcomes in patients as demonstrated in our study. To address this limitation, Mortel had proposed a modified CT severity index, a simplified and more reproducible scoring system. The modified CT severity index demonstrates stronger correlation with clinical outcome parameters, including rates of infection, organ dysfunction, and the need for percutaneous intervention or surgery, length of hospital stay, and mortality compared to the original CTSI. The main objective of this study was to evaluate the accuracy of modified CT severity index in predicting the clinical outcomes in patients with acute pancreatitis. Materials and methods. This was a prospective cross-sectional study. It was conducted from December 2023 to Jan 2025 in a tertiary center, that is Al-Amin Medical College. A total of 150 patients were selected who were diagnosed with acute pancreatitis were enrolled. They were enrolled using convenience sampling. Inclusion criteria includes patients who were included based over revised Atlanta diagnostic criteria. They were supposed to require two of these following acute onset of abdominal pain persistent with pancreatitis, serum amylase or lipase levels elevated to at least 3 times the normal limit, imaging studies suggestive of acute pancreatitis. Exclusion criteria include patients were excluded if they had known allergy to iodinated contrast because CCT was used. Renal dysfunction if serum creatinine was more than 1.5 mg per deciliter even post rehydration. Pregnancy and age below 18 years. Materials and methods. All included patients underwent contrast enhanced computer tomography CT of abdomen and pelvis, that is within 48 hours of admission. The modified CT severity index was calculated to each patient depending on this. It has 3 components: pancreatic inflammation, pancreatic necrosis, and extra pancreatic complications. Pancreatic inflammation with normal pancreas has a score of 0. Intrinsic pancreatic abnormality score of 2, and pancreatic and peripancreatic fluid collection with score of 4. Pancreatic necrosis with no pancreatic necrosis 0, less than 30%, less than or equal to 30% 2, and more than 30% 4. Extra pancreatic complication, one or more of these complications might be there: pleural effusion, ascites, vascular and GI complication, parenchymal complications. Based on modified CT severity index, mild pancreatitis was with the score of 0 to 2. Moderate pancreatitis was with score of 2 to 4, and severe pancreatitis with a score of 6 or more. Clinical evaluation and management. All the participants who underwent detailed clinical examination and biochemical evaluation, including CBC was done, ABG, serum electrolytes, renal and liver function test, and coagulation profile was done for all the patients. Patients with the MTSI score of less than 6 were managed conservatively. IV fluid resuscitation to maintain mean arterial pressure of more than 60 mmHg. Target urinary output of more than 1 ml per kg per hour. All the patients were kept NPU until 2 to 3 days, and later were introduced nasogastric tube feeding. Gradual reintroduction of oral feeding. Analgesics and prophylactic antibiotics and with stomatostatin analogs were used. Patients with the MCTSI score of more than or equal to 6 were initially managed conservatively, and those with score of more than 8 with signs of local or systemic complications were evaluated for interventional procedures, which include ERCP with or without stenting, open or percutaneous necrosectomy, drainage of pancreatic abscess. Outcome include MTSI scores were correlated with clinical outcomes, including development of local or systemic complication, duration of stay, and mortality. Recurrence follow-up was done at 6 months, 1 year, and 2 years to check for recurrence. These were the results. The age group majorly affected was 41 to 50 years, the one in the pink, and gender distribution including male predominance with 1 males and 49 females. And the male to female ratio included 2.06:1, which confirms a male predominance. In our study, the area under the curve was for MTSI score was 0.861, indicating strong diagnostic accuracy. The sensitivity and specificity was 66 and 90% respectively, with negative and positive predictive values at 62 and 80%. The association between MCTSI scores and clinical outcomes remained statistically significant, with p-values of 0.045 plus or minus 0.01 for recovered patients and 0.030 plus or minus 0.013 for those who died, underscoring the predictive value of MCTSI in acute pancreatitis. Discussion: the modified MCTSI score has proven to be a reliable image-basing tool evaluating the severity of acute pancreatitis and predicting the clinical outcomes. Our study reinforces this by showing a strong correlation between this MCTSI scores and increased risk of complications. The most affected age group was the 4 decade with male predominance, largely attributable to alcohol-induced pancreatitis. The higher rate of complications in patients with MCTSI scores between 8 to 10 highlights its utility in early risk stratification. Compared to traditional systems, MCTSI showed superior specificity and acceptable sensitivity in predicting clinical outcomes. This is in line with other studies that found MCTSI to have higher predictive value than the original CTSI. The statistical significant p-value in both survival and mortality groups further support its clinical relevance. Additionally, the MCTSI can assist in planning patient management from conservative care to timely surgical and endoscopic intervention. However, this study has its limitation as it is done for only a small sample size and a single center study. Conclusion: based on the findings, the modified CT severity index proves to be a highly accurate and practical tool in clinical evaluation of acute pancreatitis. Its strong specificity and positive predictive value make it particularly effective in identifying severe cases and anticipating complications. The statistical significant association between MCTSI scores and clinical outcomes underscores its utility in guiding timely and appropriate patient management. These are the references used. Thank you.
At last, you could with your maintenance, you could do just with your time maintenance.
Sorry, sir.
It's okay. How many patients you could intervene surgically, or any other modes of intervention?
Around, sir?
Any surgical interventions or any?
Has open necrosectomy were done for few patients. I have not added those values.
But depending on the CT severity index, you told some patient needed interventions.
Sir.
Maybe in the form of minimally invasive like percutaneous or endoscopic or open surgery. That you didn't mention in your results, isn't it?
Sir.
Did you really do any interventions?
We have done, sir, open necrosectomy and interval necrosectomy we have done, sir, for few cases.
You should not say few cases. How many cases you have studied?
You have to mention that
How many? What is the number of your sample size?
150, sir.
You have to
150
mention
sample.
2 cases, 3 cases, or 10 cases, and if you cannot say few, isn't it?
Okay, sir.
You told sample size is small. 150 is big sample. How many of them died?
11 of them had died, sir, and around 88 of them had developed co-mobs, sir.
What are those
Complications, sorry, complications, sir.
So I have only one question. I just want to know whether you would like to call it as a cross-sectional study or a prospective study.
It's a prospective cross-sectional study, sir. It will compare the exposure and this thing at the same time, sir.
Thank you.
Thank you, sir.
Thank you, judges. This was Dr. Anusha CS, FRP 98. With this, we have concluded our session. Judges, please note, number 7 has been reallocated to another room. He was there, but he was reallocated.
Oh, I see. 6 weeks.
Up next, we'll be starting with session 4 of free paper presentation. There are 6 presenters for this session: Dr. Enas, Dr. Varsha, Dr. Dharini, Dr. Apurva, Dr. Nishant, and Dr. Bhumika. This was the order. I repeat: Dr. Enas, Dr. Varsha, Dr. Dharini, Dr. Apurva, Dr. Nishant, and Dr. Bhumika. Kindly be ready in this order with your presentations. The judges for this paper presentation would be Dr. Gopinath Pai, Dr. Satyamurthy Aital, and Dr. Kiran Kumar. The judges for this paper presentation would be Dr. Gopinath Pai, Dr. Kiran Kumar, and Dr. Likith Rai M. The first presenter, Dr. Ainaz Boje, FRP 52. Judges, please note, Dr. Ainaz Boje, FRP 52. The next presenter would be Dr. Varsha, FRP 63. Kindly be ready with your presentation.
A paper is on an objective assessment for female stress urinary incontinence using translabial ultrasound and observational study. The pelvic floor muscle forms a complex and intricate system and thereby contributes to urinary continence by providing external support to the urethra. Furthermore, it also provides support to the abdominal and pelvic viscera as well. As per the Incontinence Society, urinary incontinence is involuntary urination. Herein, stress incontinence is the involuntary loss of urine due to increased intra-abdominal pressure or because of physical exertion. Stress urinary incontinence is seen to affect between 4 to 35% of adult women. And to complete, the other types include urged, mixed urinary, total incontinence, continence when incontinence, and overflow incontinence. Urinary incontinence is a distressing disease adversely affecting the well-being of patients physically, socially, and psychologically. Apart from this, there is an added factor of social stigma which prevents these patients from coming forward and addressing the disease and treating it. Therefore, there is a need to assess the significant impact of stress urinary incontinence in order to improve the quality of life. There are several diagnostic modalities available, but these lack the sufficient sensitivity and objectivity to diagnose SUI. Herein, translabial ultrasound seems to be a relatively reliable, comfortable, and inexpensive modality to assess bladder neck mobility, descent, and thereby assessing pelvic floor disorders. The various modalities available to assess incontinence are urodynamic studies, videocystourethography, sonography, and dynamic MRI. The aim of our study was to assess the efficacy of dynamic imaging through translabial ultrasound for evaluation of clinically proven cases of stress urinary incontinence. This was a prospective study, with the location of the study being the General Surgery and Urology Department at our hospital, and the duration of study was December 2023 to May 2024. The inclusion criteria was female patients above the age of 18 years and patients with stress urinary incontinence irrespective of their previous vaginal or C-section delivery and irrespective of their parity. The exclusion criteria was that of patients who are not willing for clinical examination, translabial sonography, patients having a neurological hyperactive bladder, or patients with a history of exposure to radiotherapy or UTI. This was the pro forma for data collection which was followed. The radiological investigation done was that of translabial ultrasound. After ensuring the requirements as mentioned, translabial ultrasound examination was done using a GE Voluson 730 expert system with a curved array volume transducer and an acquisition angle of 85 degree. The measuring parameters were that of urethral length, rhabdosphincteric thickness, and retrovesical angle in resting state, and bladder neck descent and retrovesical angle during the Valsalva maneuver. And the data collected was entered in Microsoft Excel sheet, and the parameters were analyzed and compared to the normal values. Total of 63 patients with SUI were analyzed. Most of these patients were between the age group of 66 to 75 years. Apart from this, we also assessed a normal group of around 5 individuals. Herein, we found the urethral length in the patient group to be between 2.1 to 4 centimeter, whereas the normal group had an average of around 3.02 centimeter. The rhabdosphincteric thickness was measured, which was found to be ranging between 2.6 to 3.4 in the patient group, and the normal group had an average of around 5.04 centimeter. The bladder neck was normal in both the patient group and the normal individual group as well. The retrovesical angle during rest was measured. Herein, the normal angle during rest is ranging between 90 to 120 degree. We found that in the patient group, most had an angle of more than 140 degree, and the normal group had an average angle of around 129.5 degree. The angle was also measured during straining, the normal angle being 140 to 190 degree. In the patient group, it was found that most of the patients had an angle which was in the upper limit of value, and nearly 20 patients had an angle of more than 170 degree. And herein the normal group had a normal angle average of around 144 degree. The bladder neck descent was assessed, which was found to be between 6 to 10 mm in the patient group, and the normal group had ranging between 3 to 4 mm. There was a study which was conducted by Dietz et al., wherein these mean parameters were assessed as shown, and the parameters are shown to be compared from our study. The study conducted by Dietz et al. Addressed the Australian population. Therefore, the differences in the values could be attributed due to the difference in population and the Indian population having a different nutritional status and having a different parity status. These are some other studies which were conducted, but these also have addressed the European population and the Italian population. There is no Indian study as of now which is evaluating translabial ultrasound in stress urinary incontinence. To conclude, the efficacy of dynamic imaging through translabial ultrasound in clinically proven cases of SUI has shown useful results. This is an ongoing study which will help in establishing parameters with respect to the anterior, middle, and posterior compartment of the pelvic floor. And this will further help in integrating translabial ultrasound with other fields like coloproctology, urology, gynecology, and physiotherapy as well. This is an ongoing pilot study which will further include post-operative assessment of the same parameters and evaluating the quality of life as well. The limitations of the study was that the grading of SUI was not covered and the small sample size of the normal group. Thank you.
Is the only parameter which you chose, or is there anything which you compared to know the outcome of this particular SUI?
So we already...
Because you have mentioned that your study is limited. Same time, you don't have any other comparative study in India. you have compared with the Australian and others where the urethral length is very less.
Yes, sir.
Though people, ladies are more taller than bigger than Indians, but you said urethral length is still smaller compared to Indian ladies. Maybe depending on parity, I don't know how parity elongates the urethra.
So parity in terms of pelvic floor weakness, like the rhabdosphincteric thickness was affected, is what we
you
saw.
mentioned about length of the urethra.
So in terms of all parameters, sir, primarily rhabdosphincteric thickness is what is affected when we talk in terms of parity. And in terms of ethnicity and nutritional status, that is, like ethnicity is when the urethral length comes into play, and nutritional status again for the pelvic floor muscle strength, which will tell us about the bladder neck descent, sir.
Yeah, how many of them are postmenopausal, how many of them premenopausal?
So in
that also you should mention, because that is also one of the important factors.
So like it was like 33 were in the premenopausal or like perimenopausal phase, and the remaining were postmenopausal.
How many of them of the?
So out of 63, 33 were like
almost 50-50.
50, yes, sir.
Cesarean section patients were excluded?
No, sir, not excluded, sir. They were included, sir.
Now, how does this cesarean people who are not people who have undergone cesarean affects this particular?
So they are more prone to having weakening of, especially in India with the status of multiparity.
Multiparity in cesarean doesn't matter.
No, so that's like neither vaginal delivery nor C-section was excluded because it was not impacting the C-section was not impacting the values specifically, sir.
You have found out so many values or so many parameters of stress urinary content.
Yes, sir.
How is it going to helpful in treatment?
So basically, we have a lot of modalities which are available. We basically want a modality which is comfortable for the patient, especially female patients, because the other modalities like that are available, like urodynamic study or videocystourethography, they are invasive and they are uncomfortable. Herein, translabial ultrasound is relatively less invasive, even taking into account dynamic MRI. Even if that is available, it is not it is very expensive and it is not available in a lot of hospitals. So again, the translabial ultrasound will be relatively inexpensive in helping to diagnose SUI, sir. That was the study.
Thank you, respected judges. This was Dr. Inaz Boje, FRP 52. Up next, we have Dr. Varsha, FRP 63. Dr. Varsha, FRP 63. After that, we'll have Dr. Harini Kishore, FRP 123. Kindly be ready with your presentation.
Paper presentation is on the topic a case series of malone meatoplasty under the guidance of Dr. Vipin Tiwani, a urology assistant professor. Introduction is lichen sclerosis is an autoimmune condition which in males mainly affects the foreskin and glans penis. It may be complicated by urethral involvement, which can be a simple meatal stenosis to severe and extensive urethral strictures. Although circumcision generally arrests the progress of the condition, the procedure may trigger meatal stenosis. A novel technique is described to relieve stenosis of the external urinary meatus in patients with lichen sclerosis. It's a rapid and easy to perform on outpatient basis and allows good cosmesis with a low incidence of spraying when the patient passes urine. So the indications are, it included patients with meatal stenosis in a ventrally placed meatus or severe stenosis in any position that does not extend significantly into the navicular fossa. Patients were a total of 10 patients underwent the operation in a 6 months period. The mean patient age was 47 years, ranging from 20 to 74 years. A total of 7 patients had histological proof of LS, whereas the other 3 patients were circumcised previously, but showed clinical evidence of LS on the glans penis. Follow-up, it was done by interview and clinical examination by opening the new meatus to look down the urethra. And this technique was used to rule out any recurrence. One patient had recurrent symptoms with poor flow. cystoscopy was done, which showed a widely open urethra but a significantly enlarged prostate. The remaining 9 patients who remained under review were given a questionnaire asking if they were pleased with the cosmesis of the operation and if they sprayed when they passed urine. If they did, how often and how badly. Contraindication to this study was that it's a severe LS involving the navicular fossa or fibrosis of the corpus spongiosum of the glans was a contraindication, as this technique requires some suppleness of the tissues to allow the formation of new urethra. The technique was 240 nylon stays sutures were placed on either side of the stenosed meatus. A small ventral myototomy is then performed and the epithelium of the urethra and glans is opposed with either 60 or 70 polyglactin sutures. This will widen the meatus without making it hypospadiac, and it allows the insertion of forceps to assess the stricture, which does not extend significantly into the navicular fossa. If it did extend into the navicular fossa, then a buccal mucosal graft urethroplasty was performed. And if it does not, and if ventral myototomy can be done adequately without creating a hypospadiac meatus, it's not necessary to perform this technique. But if it does, then we do a deeper dorsal myototomy, which is performed by cutting through the glans. Again, the epithelium in the dorsal myototomy, the epithelium of the urethra and the glans will be opposed with 60 or 70 polyglactin sutures. The combination of this ventral and dorsal myototomies will completely open the stenosed meatus. But the cosmetic appearance is poor at this stage, since the sutures of the dorsal myototomy will pucker the glans due to the thickness of the corpus spongiosum of the glans. So as seen in the picture, figure A shows that first ventral myototomy is done, and in figure B, dorsal myototomy is being done. And in figure C, after doing the dorsal myototomy, the below picture shows that there is puckering of the skin, which gives it a poor cosmetic appearance. And that's why, to overcome that poor cosmetic appearance, an inverted V-shaped relieving incision is done with the apex of the V close to the proximal limit of the dorsal myototomy, as it's seen in figure A. The edges of the relieving incision are then freed by sharp dissection. The opposing left and the right inner edges are closed with continuous 70 polyglactin sutures, as seen in figure B, where the inner edges are approximated to each other. And the outer glans there is then opposed with interrupted 6070 polyglactin sutures, as seen in figure C, where the outer layers are approximated to each other. So finally, the result is it looks like a slit-like tip, that is a slit-like but good caliber meatus at the tip of the glans is seen, which is in figure B. So this is just a picture to show that preoperatively that's how the stenosed meatus looks. Then in figure 2, a ventral myototomy is done. Figure 3, we do a dorsal myototomy with a V-shaped relieving incision. And figure 4 is a slit-like meatus. The result is that there were no immediate complications. No patient had recurrent stenosis or fistula formation with this technique. Of the 10 patients, 9 patients replied to the questionnaire. Most patients did not spray at all, and even if they did, it was only occasional and they did not find it constant or severe. All patients were pleased with the cosmetic results of the surgery. Discussion is that treatment of the urethral complications of lichen sclerosis is known to have a high rate of recurrence. When and Mundy reported that extragenital skin or buccal mucosa grafts provide the best long-term results for the treatment of LS strictures in patients with LS, but in patients with LS, meatal dilatation cannot be relied on to be effective. Another technique was Kim and King described a technique of meatoplasty, which was based on the principle wherein the patient with meatal stenosis after hypospadiac repair, they identified that the need for meatoplasty to be sited into the dorsal glans, but they did so using a V-shaped flap that distorts the glans actually and makes the preservation of the slit-like meatus impossible. Also, there were no long-term results with this technique. So an advantage of this technique is that because of the ventral and the dorsal meatotomies performed, it allows a wider opening, which is less likely to restenose. And if there is some contracture, it also retains the meatus at the tip of the penis. Conclusion is that with the results, we can conclude that the technique was effective in the medium term as there have been no recurrences. It produces a good cosmetic result with most patients being pleased with the result. Spraying was occasional in the post-operative period, but no patient found it constant or severe. But further attention to the shape of the neovascular fossa may improve the outcome of this technique. These are the references. Thank you.
So, scopy on all these patients whom you have operated?
No,
because you are the one who told in the beginning that associated stricture of the urethra is a common occurrence in these patients. So you have done only metaplasty, but ever tried to do histoscopy in all these patients before you touch them?
No, sir. We just firstly, I'm sorry, on OPD basis itself, whether it was going up to the neovascular fossa. If it didn't, that's where we decided to go ahead with the meatoplasty.
All these patients were circumcised or?
No, sir. Only 7 of them were circumcised.
Did you do circumcision on all these patients?
No, sir. My study had 10 patients, of which 7 were circumcised.
No, circumcision is beneficial in lichen sclerosis.
Sorry, sir?
In lichen sclerosis?
Yes, sir.
Circumcision is beneficial. That's what you have told in the beginning.
So the patients who didn't have circumcision, there was the lichen sclerosis part was seen even in the glans. So when it extended to the glans, or there was already stricture involved in the meatus, in such patients we didn't go ahead with circumcision directly. We went ahead with the technique.
Is this surgery indicated in other causes for meatal stenosis also?
I've not tried.
You have tried only in
lichen sclerosis patients.
And 10 surgeries were performed. Is it done for cosmetics or the patients were symptomatic? Because most of the studies you've shown only talking about the cosmetic appearance, not about the symptoms. Because patient might have a meatal stenosis, but there may not be any. Whether you have done these cases for a cosmetic issue or is it for the symptoms, the 10 cases you operated?
Symptoms as in they presented with the problem of stenosis, so...
No. There is some complaints, right?
Yes, sir.
It can be acute urinary retention,
yes, sir.
of urine,
yes.
or hydronephrosis.
Yes, sir.
Have you operated for that reason?
Or you operate for the cosmetics only?
Both. Cosmesis as well as the... cosmesis is an added benefit to it, but mainly because of the symptoms that they came with.
So all the patients had symptoms?
Yes,
10
sir.
patients
Yes, sir.
of stenosis?
It's stenosis patients.
Thank you, respected judges. This was Dr. Varsha, FRP 63. Up next, we have Dr. Dharini Kishore, FRP 123. Dr. Dharini, FRP 123. After that, we'll have Dr. Apurva P, FRP 41. Kindly please be ready with your presentation.
Good evening, one and all. Today I'll be presenting my... Good evening, everyone. Today I'll be presenting my paper on multifaceted role of acellular dermal matrix in novel wound healing. It's a case series. I'm Dr. Dharini Kishore, and I'm presenting under the guidance of Dr. Naveen Narayan, who's a professor and head of Department of Plastic, Reconstructive and Aesthetic Surgery in Adi Chinchinagiri Institute of Medical Science, Mandya. So, wound healing is a complex process which involves various cellular and molecular mechanisms, and matriderm is an acellular dermal matrix which is composed of bovine collagen and elastin, which has been designed to mimic the human dermal structure, facilitating wound healing and reducing scar formation. It's a three-dimensional matrix. It's a three-dimensional matrix substitute constituting of bovine collagen type 1, 3, 5 and elastin hydrolysate This composition mimics the human dermal extracellular matrix, providing a scaffold for cellular ingrowth and neovascularization. I'm presenting a case series with, I've taken up 4 cases in this. Case 1 is a 26-year-old male who presented with multiple facial injuries in a road traffic accident with a contaminated wound within a few hours of the incident in a conscious state. The facial bone fractures was managed conservatively and thorough debridement of the multiple facial wounds and abrasions was done. But in view of contamination, definitive wound closure was deferred and a meshed collagen sheet was applied on presentation. And after 2 weeks, the patient was taken up for surgery. And a 2 millimeter matriderm along with a simultaneous full thickness skin graft from the groin was used to cover the full thickness skin loss which had occurred over the forehead, the dorsum of nose, the right cheek area, right nasal ala and upper lip on the right side. A tie over bolster dressing was done to secure the full thickness skin graft and underneath matriderm in place. The figure 3 shows the uptake of the full thickness skin graft with the matriderm, which was 100% at 3 weeks and 4 weeks, and at the 6th month follow-up, the grafted areas were pliable compared to near normal skin tone. However, the graft retained most of the groin skin color and contrasted with the surrounding hypopigmented healed abrasions, though it was less dark than the original groin area color. And in case 2 was a 37-year-old male who presented with a post-debrided raw area over the right upper limb. This was 2 weeks after the presentation for a necrotizing fasciitis as a consequence of snake bite. At presentation, the patient had a large raw area extending from the dorsum of the right index finger to the elbow over the dorsal aspect. The right index finger proximal interphalangeal joint was exposed along with bare bone of proximal phalanx without the periosteum. The affected area was thoroughly debrided and irrigated. And a 2 millimeter matriderm was applied over the open joint and a bare bone of right index finger and the exposed tendons over the dorsum of wrist. A split thickness skin graft harvested from the thigh and the meshed graft was secured over the raw area and matriderm concomitantly in the same sitting. The split thickness skin graft uptake was near complete with small islands of raw areas over the forearm which healed secondarily. The resultant grafted area where the matriderm was applied was supple and visibly more pleasing at the 4 months follow-up, shown in figure 7. And the third case, where a 67-year-old female patient presented with a diabetic foot ulcer over the right heel region for 2 months, measuring 7 into 8 centimeters with slough and islands of pale granulation tissue with minimal pain and tenderness. On debridement, the calcaneum was exposed. The osteomyelitis part was freshened till there was active bleeding. Since the elderly patient with multiple comorbidities couldn't withstand a major flap surgery, a 3 millimeter fenestrated matriderm was applied and a split thickness skin grafting was done at the same time. And a negative pressure wound therapy was applied. On the 7th post-operative day, the healthy skin graft was noted. The patient was followed up for a week. At the time of the last follow-up, that is 2 weeks after the skin grafting, 100% of the skin graft was found to be healthy. And case 4 was a 48-year-old male patient who was diagnosed with squamous cell carcinoma of the floor of the mouth upon biopsy of the ulceroproliferative growth on the left side of the floor of the mouth. The patient was operated and a week after the diagnosis with wide local excision and regional lymph node dissection. For the ensuing defect, the free anterolateral thigh flap was planned and executed. But on the 8th day, there was partial flap loss was noticed and which was debrided. And after 2 weeks, the patient had developed an orocutaneous fistula, which was communicating to the left side of the neck with continuous drooling of saliva, seen in the figure 10. For this, we determined to use a acellular dermal matrix, that is the matriderm, for treatment instead of another surgical intervention using flaps. So a 3 mm matriderm was rolled and inserted into the curated track with the openings closed with matriderm pieces. The neck wound was closed with split thickness skin graft, while the mucosal opening was closed with matriderm only, and a bolster dressing was applied. The fistula healed, and the split thickness skin graft was 100% and the oral opening closed with mucalization. Patient later underwent radiotherapy. Patient was followed up to 6 months with no recurrence or wound breakdown. So this case series underscores the versatility of matriderm as a dermal matrix and complex wound management. Clinical evidence and our experience demonstrate its ability to enhance graft take, promote cellular ingrowth, neovascularization, and improve scar quality even in challenging scenarios like exposed bone and mucocutaneous fistula. Its single-stage application with skin graft offers advantages including reduced operative time, hospital stay, and morbidity. While cost and infection risk in contaminated wounds remains the limitations of the study, matriderm shows promise as an adjuvant in reconstructive surgery. So in conclusion, matriderm is a versatile and effective tool in wound coverage with numerous applications already for burns and chronic wounds. To fully establish its role in clinical practice, further comparative studies are warranted, particularly those assessing long-term outcomes and patient-centered metrics such as quality of life, graft durability, and functional recovery. A large-scale randomized control trials and long-term follow-up studies will be essential in validating its efficacy and safety relative to other established dermal matrices. These are the references. Thank you.
Good presentation and novel technique. You have any comparison or previous studies in this particular aspect? Your series is too small.
Yes, sir. Previously, matriderm was commonly used in our institute for burn patients, and it showed good results with that. These we followed up for where there was bone exposure, and this was just an observational descriptive study. So previous, I don't have a study to compare. Sir, cost-wise, a 4 into 5 centimeter piece of matriderm cost around 20 to 25,000, sir. Sir, this is done in a single setting, along with the graft, and it has shown good results.
What about the any studies which shows that how much efficacy this matriderm has it? Yours is a case series. Have
yes,
you consulted any other study which is done elsewhere showing?
It's usually done in burn patients, sir, and some chronic wounds.
Burn patient, how much percentage burn patient? Or how much thickness?
Even with deep burns, they've been used and has
percentage, how many percent? Because it's a costly treatment, it is not so cheap, even for a...
Yes, sir.
So if you are covering for some 10% burns, that I don't think Indian population is affordable for that.
Yes, sir, but multiple stages of debridement and post-dressing. Yes, sir.
Infection is one important factor which you told you cannot use this particular matrix.
Yes, sir.
And one more, the technique. So are you going to just to place it or you are fixing it?
So we'll use a wet, the matriderm is dipped in a wet saline and mounted onto the wound, and post which either a full thickness graft depending upon the area.
You are not suturing it?
A bolster dressing is done, sir.
No, you are not suturing the matriderm.
No, sir, matriderm is not sutured.
Is it a standard practice?
It's the commonly...
No, is it your modification or is it a standard practice?
This is the commonly used technique.
You are not aware of it. Okay. Thank you.
Thank you, respected judges.
Thank you, sir.
This was Dr. Dharini Kishore, FRP 123. Up next, we have Dr. Apurva, FRP 41. Dr. Apurva, FRP 41. After that, we'll have Dr. Nishant, FRP 106. Kindly be ready with your presentation. Dr. Apurva. Dr. Apurva, she's not there. Up next, we have Dr. Nishant AL, FRP 106. Dr. Nishant, FRP 106. Are you there? No? Okay. At last presenter for today, that is Dr. Bhumika, FRP 109. Dr. Bhumika, FRP 109. Are you there, ma'am? Dr. Bhumika. FRP 109, sir. Dr. Apurva 41 is not there, and Dr. Nishant FRP 106 is not there.
Good evening, everybody. Myself, Dr. Bhumika, second year postgraduate student from Oxford Medical Hospital, Bangalore. I'll be presenting on a topic of assessment of neuroendocrine tumor of appendix, presenting as acute appendicitis. Background: neuroendocrine neoplasm of appendix are rare tumors with incidence rate of 0.15 to 0.6 per 1 lakh per year. Due to lack of specific clinical symptoms for neuroendocrine tumor of appendix, investigations and radiological examinations are of little significance for the early diagnosis, most of which are found accidental in pathological examination of post-operative specimens. Objectives is to identify neuroendocrine neoplasm in post-appendectomy specimen and its pathological findings. Methods: design and duration: hospital-based retrospective study from January 2024 to December 2024. Setting in the Department of General Surgery at Tertiary Care Teaching Hospital. Eligibility: inclusion criteria includes more than 18 years of population who underwent open appendectomy, laparoscopic appendectomy, and appendectomy with right-sided 100% survival and no recurrence. Discussion: appendiceal and neuroendocrine neoplasms are rare, often discovered incidentally during appendectomy. Preoperative diagnosis is challenging due to non-specific symptoms. Histopath features includes cord-like nested tumor structure, salt and pepper chromatin pattern. Immunohistochemistry being positive for synaptophysin and chromogranin E. Classification and grading based on WHO classification as well-differentiated, poorly differentiated, and mixed NET. Grading is based on KI-67 index and histological features, being grade 1, 2, and 3, categorized as K1, KI-67 less than 2%, KI-67 3 to 20%, and KI-67 more than 20%. Conclusion being, appendiceal NEN are rare but generally have favorable prognosis. Post-operative pathology is essential for diagnosis, and treatment decision depends on the tumor signs and pathological features.
Your treatment vary based on the location of the neuroendocrine tumor on the appendix?
So, if it is involving lymphovascular invasion or mesoappendix invasion, after excision, patient should be undergoing chemotherapy or complete, depending upon the extension of appendiceal involvement, even the patient can be progressed to the right hemicolectomy.
That's what. In which condition you do right hemicolectomy?
If the base of appendix is involved,
okay,
and mesoappendix is involved, and lymphovascular invasion is present.
All your patients were post-operative.
Yes.
What is something? Is there anything special in this particular presentation?
Sir,
because none of them are diagnosed preoperatively.
Yes, sir. So when the patient are present as acute appendicitis,
yeah, you have one case. You have told you have done hemicolectomy. What is indication for hemicolectomy in this particular patient?
when the base of appendix is involved, sir, and even the mesoappendix was involved, so the complete.
I want to ask you. All these are post-operative.
Yes.
And one case you mentioned that it is a right hemicolectomy.
Yes.
What was the indication for doing right hemicolectomy? And all the other patients, it was post-operative diagnosis.
Yes.
Including, is it also here in this case also, hemicolectomy? Was it post-operative diagnosis or pre-operative diagnosis?
No,
or on the table diagnosis? Did you have any frozen section?
On table.
Why didn't do frozen section in this particular patient?
So when on table, it was involving even the base of appendix, and cecum was also involved. So after sending into the pathological findings, it was treated with hemicolectomy. Open, sir. That. Two of them are laparoscopic, and rest all the 9 were open, sir.
Because total 11 cases you are talking about. So over here, how many period? I mean, how many period years you studied?
2 years.
2 years.
Yes.
So we're talking about how many cases, out of how many cases, this 11 incidents now?
How many
because
cases?
all the patients underwent emergency appendicectomy.
Yes, sir.
So total, how many emergency appendicectomy has been done?
Sir, in that 9 were emergency, sir. 2 were.
No, how many? See, all patients were operated for acute appendicitis.
Yes, sir.
How many acute appendicitis patients have operated? In 2 years.
Sir, approximately 30 to 40.
So 30 appendicitis means 11 neuroendocrine tumor. In a 30.
In 2 years, huge endometrium. You understand?
Yes.
I think you have looked at the figure. Only 30 appendicitis.
2 years, 30 appendicitis.
And you have got
11
neuroendocrine
neuroendocrine.
tumor. What is this?
Okay, thank you. Thank you. Okay.
So with this, we conclude the session for today's evening. We will be meeting tomorrow at 8:30 for the next sessions. All the delegates are kindly requested to proceed towards the MU hall on the ground floor. A sizzling hot dinner is waiting for you all. The delegate certificates will be given in hand after 12:30 p.m. tomorrow. Delegates are requested to kindly proceed to the MU hall, ground floor, for the dinner tonight.